توحيد وسيف تثنى، من يوم ابو ترك تنهض ونجم، قاموا لشام العز محد تونى، وخلف رجاجيل على قدر الاحداث، وانصاح صايح قال وفداك حنا، وجسنا على المنوى وعيت على الغير، وما كل عشاق وصل ما تمنى، وإن قالها الله نجعل الحلم واقع، ونطوع الصعبات بالعزم منا، نبني عمار الدار بأفكار وعلوم، ونصنع سلاح جيوشنا في وطننا، طق طبول النصر في يوم مجده، وسلوا سيوف بشجاعة تغنى.
من يوم ابو تركي تنهض ونجم، أبشر قاموا ونشام العز محد تونى، أبشر تسعير من
بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على خير خلق الله أجمعين، صاحب السمو الملكي الأمير عبد العزيز بن طلال بن عبد العزيز، الرئيس الفخري لجمعية طب الأسرة والمجتمع، أصحاب المعالي والسعادة، قادة القطاع الصحي والتحول، الزملاء الكرام، السلام عليكم ورحمة الله وبركاته. يسعدني أن أرحب بكم في هذا اليوم العظيم مع انطلاقة مباركة لجمعيتكم، جمعية طب الأسرة والمجتمع، في هويتها الجديدة واستراتيجيتها الطموحة. وخير ما نبدأ به هذا الحفل كلمة من رئيسنا الفخري صاحب السمو الملكي الأمير عبد العزيز بن طلال بن عبد العزيز، الذي رغم انشغال جدوله تكرم بقيادة هذا المؤتمر والإشراف عليه وإخراجه بالطريقة التي ستكون بإذن الله مثالا لانطلاقتنا في هويتنا الجديدة في جمعية طب الأسرة والمجتمع. أود أن أنبه لكم أيها الزملاء أنه قد تم فتح قناة خاصة على اليوتيوب لاستيعاب عدد المشاركين، حيث تم بحمد الله تجاوز حاجز 13,000 مشارك معنا في هذا الحدث الكبير. فبهذه المناسبة صاحب السمو أشكر لكم تكرمكم بافتتاح هذا المؤتمر، فلتفضلوا.
بسم الله الرحمن الرحيم. أصحاب المعالي والسعادة، قادة وممثلين القطاعات الصحية بالمملكة العربية السعودية، السادة أعضاء الجمعية السعودية لطب الأسرة والمجتمع، السادة أعضاء الأكاديمية الأمريكية لأطباء الأسرة، السادة المتحدثون الكرام، السلام عليكم ورحمة الله وبركاته. وبعد، إنه من دواعي سروري أن أكون بين هذه النخبة من المتخصصين والممارسين لمهنة تمثل خط الدفاع الصحي الأول للفرد والأسرة والمجتمع. كما يطيب لي أن أرحب بجمعكم الكريم في هذا المؤتمر النوعي العالمي الرعاية الأولية اليوم وإلى الأبد، والذي تنظمه جمعية طب الأسرة والمجتمع بمناسبة مرور 33 عاما على تأسيسها وإطلاق هويتها الجديدة بعد مسيرة حافلة بالعطاء وجهود خيرة بذلها القائمون عليها منذ انطلاقاتها وحتى يومنا هذا. السيدات والسادة، إذا كان طب الأسرة والمجتمع يعد ركيزة أساسية من ركائز الصحة المجتمعية في الظروف الصحية الطبيعية، فإن طب الأسرة والمجتمع اليوم يأتي في مقدمة الاهتمامات الصحية للفرد والأسرة والمجتمع كطب وقائي نتيجة للظروف غير العادية التي نتجت عن جائحة كورونا. السيدات والسادة، من المهم لجمعية أن تواكب هذه التطورات، ومن المهم أكثر لهذه الجمعية أن تواكب مستهدفات رؤية المملكة 2030، والتي أصبحت اليوم بمثابة خريطة طريق لكافة القطاعات دون استثناء، بما فيها القطاع الصحي بكافة أطيافه الحكومية والخاصة وغير الربحية. إننا نتطلع لاستراتيجية تقوم على تعزيز وتطوير الرعاية الأولية كحجر الأساس للتحول الصحي، وأن تقوم الجمعية بدورها العلمي كمرجعية لطب الأسرة. ومن هنا ارتأينا أن يكون هذا المؤتمر بالشراكة مع برنامج تحول القطاع الصحي، وذلك لدعم ومساندة جهودهم المباركة. إننا ومن خلال استقطاب الخبرات العالمية في مجال الرعاية الأولية يسعدنا أن يعقد هذا المؤتمر بالتعاون مع الأكاديمية، وستستمر الجمعية بهذه الشراكات الاستراتيجية مستقبلا، وذلك لدعم وتعزيز وتطوير الرعاية الأولية في المملكة وفقا لما تقتضيه هذه المرحلة. بارك الله حضوركم وسدد خطاكم، والسلام عليكم ورحمة الله وبركاته.
وعليكم السلام ورحمة الله وبركاته. ألف شكر سموكم الكريم على هذه الكلمة. كما أعلن صاحب السمو الملكي الأمير عبد العزيز بن طلال بن عبد العزيز استراتيجيتنا الجديدة بعقد الشراكات العالمية، وانطلاقا من هذا المؤتمر الذي يعتبر باكورة هذه الاستراتيجية بالاشتراك مع الأمريكان أكاديمي أوف فاميلي فيزيشن It's a great honor and pleasure to welcome our next speaker, Dr. Shahir Al-Shehri, who is the president of the Saudi Society of Family and Community Medicine. Dr. Shahir has led a tremendous effort in coming up with a new vision strategy for the Saudi Society of Family and Community Medicine in collaboration with his colleague. And we're going to hear from Dr. Shahir about how he would see the society as the catalyst for the primary care transformation in the country. Dr. Shahir, it's an honor to welcome you to the stage.
So much. Wait a minute for the slides. One minute, please. I think some problem in the slide, but I can start with out. It's coming now.
We can't see it.
You can't see it?
No.
Okay, so 1 minute.
Do you need technical support, Doctor? We can get on board.
Just, I don't know. I think no. No, that's all. Thank you very much. بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه أجمعين. I want to thank everybody sharing this event, and I think one of the important events to work together, all the sector working in the transformation for the health. As we know, now the Saudi Arabia has a big transformation era, and to move to 2030. One of the best and big transformation, what you say, it is in the health field. And really, our colleague in the Ministry of Health and the other sectors of health working hardly to this transformation to give our citizen and our country to be one of the best for the accessibility and the quality, and also the value-based for our citizen. And this transformation also, it is not just taking around the disease. It is around the person at whole, because we're starting from the promotion, prevention, treatment, rehabilitation. For now, it is really a big, and you need everybody to work on this. Saudi Society of Family and Community Medicine has a big role, especially when we are looking to many things. As you say, the Saudi health system reform, now it is tried to remove completely what you have, the old system. And what you say in this picture is really, it is nice when looking about the 6 domains of the new model of healthcare, and also the level how to get these domains. And we've concentrated it. Everybody, we know family medicine and community medicine has a big role in many of this one and work with this one. And the Saudi Society start to reform their strategy according to this system on working how to do with this things. Area of transformation, as you say, digital, patient center, humanizing, restructuring the sector, all this one, it is in our mind in the Saudi Society when you're working with all of our colleagues. When we are looking to what is our role as the Saudi Society, all the level of the area focus, health promotion, prevention, treatment, and rehabilitation, to be a comprehensive according to the family and community medicine principles, even according now to our health system principle in the reform. Now also, it will put our mind to moving to the community find the root of the problem, strengthening the role of the public health. And as our colleague and working in the transformation, they give a big and huge concern about the role of public health, and really it is excellent to start and doing by this one. Also, for that, how to reach, we are working in raising the awareness of the professional before the community of their true rules, occupying and empowering the community for their rules, and building effective collaboration between the relevant authority. I think that these three things, with the professional and with the community and with the institute themselves, it is very important to work together. And in Saudi society, we are working as a non-governmental organization. Usually, a non-governmental organization has a freedom to work with different settings and cover the gaps which may be having, if not treating by some of the institute. We are in the gap to working in this thing. The main rule for us in this area will help in the paradigm shift. We have a role for paradigm shift by using our events like what Dr. Hadi do now, and by many things, also building transformational leadership. And this is very important to create a transformational leadership to help us to reach what you are planning at the one. Also, we have augmentation rule. Working one, not 1 + 1 = 2. We are working 1 + 1 = 3. If we are doing like that, we are a platform for the professional. And now the professional working together and share the experience and knowledge and everything. I'm sure it will be very strong for our health system. Also, we have a scientific rule for the transformation through our magazine. For that, we are working hardly, if we put it in our new strategy, to building the future skills, because you need many future skills for our new resident, also for our staff, how to meet what's happening in transformation by this new skill, like digital skill, communication skill, resilience skill, and we count many things like that. And this is our goal. Also, we are building the research capacity, and the research is very important. So this is one of the roles we are working it and started to make it or catalyze it in our new strategy. That, in summary, what we are thinking about all, and I am happy now, and I am this group from different institutes, from that, to work together. And I told you frankly, our society, it is for you. To anything we want, we are as a platform, and we can do many things together. Thank you very much.
Thank you very much, Dr. Shaher. And indeed, the society is for all of you out there who can hear us. We want to hear from you. We want to work with you all. We have our arms, hearts open to work with everybody for a common goal of reforming the healthcare in the country, built on a strong primary care. A few announcements before I go to my next speaker. Around 11 to 11:30, stay tuned. We'll have a few big announcements that's of interest for every single practitioner across the nation. So stay tuned with us, don't go away. And at the end of the day, around 4:30, we'll have a very special session where you can directly ask our national and international expert. And as I said earlier, we've had the YouTube channel for you, because we have, like, as we speak now, on the live with me, more than 4,000, but the registrant is 13,000. So we put a majority of them through the YouTube. And everyone who gone through the YouTube will have their CME accredited as well. So with that, I will welcome our next speaker, a very well-known figure of family medicine in the country, Dr. Abdullah Al-Khnizan. Dr. Abdullah is a consultant and a professor of family medicine. He's a practicing physician in King Faisal Specialist Hospital and professor of family medicine at Al Faisal University. He is well-published researcher and with special interest in family medicine. He's gonna take us on a journey about primary health care in Saudi Arabia. What did the lecturer would say? Dr. Abdullah, welcome to the stage.
السلام عليكم جميعا. يعطيكم العافية. Thank you very much, Dr. Hadi and the whole group. It's really a my pleasure and honor to contribute and participate in this very important meeting. And congratulations to the anniversary. I'm right now actually in UK, so I had to go through the British system because you have to do a few things here and there before you can be released with what's happening right now in UK. So it's really very interesting to see how far we have gone with the healthcare transformation and with what's happening with Vision 2030. When you compare to these two systems, with what's happening with COVID and access to testing, we are really advancing. This is my message to everybody. We are really advancing in our system, despite the fact that we are going through the transformation over the last probably two to 3 years. But we are seeing the impact. I can tell you that, from my experience with what's happening right now in UK and going through a few parts of the healthcare system here. So I would like I will go through the few literature within Saudi Arabia actually, and fortunately or unfortunately, most of these literature that I will talk about are probably governmental, related to primary care, are probably governmental documentation. Because unfortunately, when it comes to research, and we will come to that in Saudi Arabia, we have a few research, but it's not the best. And I think this is another issue that we need to talk about. First of all, I must say that primary care in our country was established very early on with the Al-Ma'ata Declaration in 1978. Our country was part of that declaration, and I guess some of you remember the dispensaries that were, available across the country, and these dispensaries were formally in 1983 changed and renamed into primary healthcare services. At that time, I think our country were working on different fronts, the secondary care, tertiary care, and primary care services. And at that time, most of the services were run or started by general practitioners. When we say general practitioners, because I guess we have some colleagues who are outside, from outside our country, they are general MDs who are working in the different primary care centers. So they did not necessarily have specific training in the field of family medicine or primary care. So they are bachelor degree, maybe with some training, minimal training, diploma in the field of family medicine. And currently, still, this group of physicians, well, I think they are a very important group of, the workforce in Saudi Arabia in the field, who are, taking control mainly of the services provided by primary care centers in our country. Since the establishment of the Arab board and Saudi board in family medicine, we are having more and more of family physicians, trained family physicians who completed board certification in the field of family medicine. Training in family medicine in our country and in the field of primary care and community medicine in our country started actually strong somehow. As you know, it was led by our leader, teacher, and professor, Dr. Zuhair Subai, who had multiple experience in different, with different training in different areas, including Johns Hopkins University at that time. But for a different reason, I guess, I think part of it is the fact that the leaders of our country and leaders of healthcare were overwhelmed with probably secondary and tertiary care. Probably secondary tertiary care were given priority at that time over primary care, and that's why we see huge number of graduates of North American system, British system, and other systems from the main big specialties, pediatrics, OB/GYN, internal medicine, surgery, coming since the 70s, I would say the 60s, 70s, 80s, 90s, and beyond in these fields. But for whatever reason, as I mentioned, I think, primary care was not given a priority. We see very few graduates coming from these different, countries into our country at that time in the field of primary care. I'm not saying that's a bad thing. It's good actually to have local training early on, but also it's very nice to see a mixture of, experience coming into the country, into the field. Unfortunately, this didn't happen. We were exposed probably in the 80s, 70s, probably to the British system. We have a few graduates from the British system, but again, primary care, family medicine did not have the same exposure of scholarship trainee from across the world for very long time. And I will talk about that later on. And I think that exposure is extremely important because it gives you different school of thought, which happened in pediatrics, internal medicine, private OB/GYN, surgery, but it did not necessarily happen in family medicine in our country. If you look at chronic diseases in our country, which is, represent the bulk of what we do in primary care, unfortunately, this is based on the Saudi health interview survey, which was conducted in, the last one was conducted in 2013. Unfortunately, we have an epidemic of chronic diseases in our country, unfortunately. And I would say one of the key diseases, which is actually I would say you can call it the father or mother of most of the diseases that we have in our country, obesity. Unfortunately, we have an epidemic of obesity, and it's very prevalent. It's one of the most or highest in the world. And if you think of overweight, it's another 30%. So almost 60-70% of our population are either obese or overweight. And this is probably, why we have other diseases as an epidemic, unfortunately, in our country, including diabetes. At least 14% of the population, 15% of the population are diabetic already. And unfortunately, another 30%, around 30% or 25% are pre-diabetic. So almost 40-50% of the population are either diabetic or pre-diabetic, unfortunately. And by the way, the Saudi health interview survey starts from the age of 15. So we're not talking about the adult. This disease is, deep into our pediatric population, unfortunately, again. So around 30% of the population are either, including portion of pediatric population are unfortunately diabetic or pre-diabetic. Hypertension is also another epidemic. 15% of the population are from the age of 15 and above are diabetic. As you know, we have data from the age of 25, which actually, elevate all these figures into the level of 30s and 40s%, unfortunately. In addition to that, which is another condition that I consider, or disease that I consider another key of what we are facing in Saudi Arabia in terms of the burden of disease, smoking. Unfortunately, smoking also is very prevalent in our country, unfortunately. As you know, smoking in North America and Western Europe is dropping right now because of the restrictions that is happening. Unfortunately, in our country, it is still there, and it is very high, actually, reaching up to 12% of those above the age of 15. And 23, almost a quarter of the males are smoker, unfortunately. We are blessed that we have lower, rates of smoking among females. But as you know, unfortunately, we have recent figures, because this figure talk about 2013, that unfortunately smoking among females is increasing, reaching up to 10%. These are the recent figures. So unfortunately, these numbers are increasing in our country, and I think we need more effort in this regard, especially to tackle smoking and obesity, because they are the key for most of these diseases. The impact of these diseases is coming into our country because, as you know, we are a young population, and we are a young nation. 60% of the population are below the age, or 60 to 70% are below the age of 25. And that's why we are not seeing the impact of these diseases on coronary artery disease. However, with what we, have, seen with the baby boomers, they are coming into our country, and in 10 years, we will see a doubling and tripling of our elderly population. And at that time, we will see the impact of all these diseases in our population, unfortunately, unless we work and do something about it. And one of the key factors in combating these diseases is improving primary care. In terms of healthcare spending, we are in the era of value-based healthcare. This is the budget of healthcare spending in Saudi Arabia, publication that we did. And as you can see, the budget of healthcare spending in Saudi Arabia is almost doubling every 10 years for the last 2 decades. Can we continue doing that? No, we cannot. We'll probably go by 30% more by 2030, but it will be very difficult to go beyond that. And no country will be able to do that. That's why the concept of value-based care is very important in this era. The good news is the fact that, for the last 2, 3, 4 years, we are in the era of Vision 2030 and the era of healthcare transformation. And really, we're blessed to have this, and we are really lucky. I feel very lucky personally that I'm living this era, I'm seeing these changes. Which we are seeing it right now. We don't need to wait to 2030. Alhamdulillah, COVID, what's happening with COVID and the success that we had and the high advanced, very well organized healthcare system, even when you compare it to, the best healthcare systems in the world. This is in one aspect, but I think we will see it in all aspects in our life, inshallah, soon. Health sector transformation strategy is a very important document that was published, which described a lot of things that need to be improved, and what will happen to our healthcare system by vision or by 2030. That document is, I think, a very important document. It described actually and very transparent document, by the way. It described primary care current status as inadequate and inconsistent, with insufficient and poorly distributed capacity and capabilities for the provision of public health and primary care services in the country. And that's why there is a need to improve primary care services in our country. As you know, we know that this is happening, although we started to see significant changes over the last 2 to 3 years. And again, if you compare what's happening in Saudi Arabia with primary care compared to secondary care and tertiary care in Saudi Arabia is doing well. Tertiary care is very advanced, as you know. We're probably doing things that many developed countries that they cannot do. But when it comes to primary care, we are clearly behind. And in a study that was published in Saudi Arabia, and I think this study summarizes it all. What's happening in primary care in Saudi Arabia? So this group of researchers, they try to ask the public why you are bypassing primary care to the emergency or to the hospital, and they indicated clearly that there are multiple issues, including unavailability of drugs, unavailability of diagnostics, and their lack of trust of the experience of the staff working there. And we know that these are probably the key issues when it comes to primary care services in Saudi Arabia. And this brings us to a very important topic, which is research in primary care in Saudi Arabia. This group of researchers actually, they published this paper, which is, I think it's a very interesting paper describing what's happening when it comes to research in Saudi Arabia. And as you can see, I mean, the number of publications in the field of primary care is low. And we talk about 3, 8, 11, 12. The good news, it's improving gradually, but it's still, even 100 in 2018, it's still low by the standard of a huge country like our country. And the other issue is, which indicated in this research and other researchers actually, 95% of research in Saudi Arabia is cross-sectional studies. So it's weak, unfortunately. And the reason behind that, again, unfortunately, primary care was not a priority. Community-based, research, primary care research was not a priority in our country, unfortunately. More of specialist and subspecialist research. Most of these, funding agencies, research centers are focusing on rare diseases, specialist diseases, and forgetting community-based research, which we desperately need, especially in the era of Vision 2030, which really have shifted the focus from sub-specialized healthcare into primary care, because it's the key to improve the wellness and health of all population in our country. And I really think that we really need to push, and I think this is one of the areas that is still lagging, even with what's happening, the coordinated. Now we see a very coordinated, effort by multiple parties. I will talk partly about it towards improving primary care in Saudi Arabia, because it's the focus of Vision 2030. But when it comes to research, I think things are a little bit lagging. I think the Saudi society can help in this regard. Primary care was probably the only level of care that was mentioned frankly and clearly in Vision 2030. And as you know, Vision 2030 now is the guiding principle of the whole country. So primary care is the only level of care that was mentioned in the main document of Vision 2030, in the highlight of what we need to do in our country. And this is very interesting. I think we're privileged as primary care physician that this was mentioned clearly. And as you can see, the public health sector will focus on promoting preventive care, on reducing infectious diseases, and in encouraging citizens to make use of primary care as a first step. This is very important word that we need to use when we argue about anything with anybody. As you mentioned, Vision 2030 is the guiding principle in our country. And as you can see, we are in an era where what is decided upon will happen. And that's why we see the huge transformation, even in primary care, to be frank with you, that's happening over the last 2 to 3 years. So again, if you look at what are the key objectives of the healthcare transformation, it's all actually about primary care, facilitating access to healthcare services, improving the quality and efficiency of health services, promoting prevention of health risk, enhancing traffic safety. If you think about it, it's all about primary care and its component, urgent care and other components of preventive medicine and other components of primary care. That's why I think we, as a primary care physician, we are in the golden era of primary care in the region, I would say, and in Saudi Arabia. if you look at health care workforce in Saudi Arabia, and this is a very important document that was developed by the Saudi Health Commission, which describe, and again, this is the impact of Vision 2030. Vision 2030 mentions primary care, and that's why everybody is working in this field to improve from their side in a coordinated effort by the higher authority of the government towards improving primary care. Primary care was mentioned clearly in Vision 2030 in our country. So if you look at this very important document, you can see that general practitioners in our country are getting into the market, non-Saudi, from all over the world, and they are GPs. GPs, again, we mean by GP somebody who's just MD and he's getting into healthcare, seeing patients in our country. So we have around 3,000 to 4,000 every year. Some of them go to governmental sector, others go to a private sector. This is good and bad. This is good that, okay, we are attracting, physicians from all over the world, but it's bad the fact that they are just MDs. They did not have any further training, and they are seeing patients, which maybe not the best, for our citizens and for our country. If we want to improve primary care services in our country. And that's why, again, if you look at Saudi graduate of the different medical schools in Saudi Arabia, and by the way, we have probably one of the highest number of medical graduates in the world, per capita in the world. This is good and bad, but that's a different story. So we have, in 2021, we graduated almost 4,700, 800 new graduate, bachelor degree graduate in our country. And we are coming into around 5,000 graduate soon. And the plan is to move 50% of those graduates into primary care to cover the need that we just talked about, by non-Saudi who are coming into our country and contributing to our healthcare system, but they are just MDs. They did not have formal training. And if you look at those who are currently on scholarship across the world from the Ministry of Higher Education, if you look at local and international scholarship, I will focus here mainly on international scholarship. Internal medicine, more than 100, are receiving training in the different specialties of internal medicine. Surgery 25, OB/GYN 10, pediatrics 14, and in family medicine only 4. Why? This is a big question for me. And I think part of it is many think, that primary care, there is no need to, send people for scholarship, which I totally disagree with. And that's why I think we need to push more for more scholarships in the field of primary care and family medicine. And as you can see, more, internal medicine we're now graduating more internal medicine at that time. This was 2018 actually, than family physician. But now, by the way, that it's totally different. Family physicians are much more internal medicine. If you look at those who were sent, this is a very important document from the Ministry of Health, the annual book. In 2020, how many family medicine trainee local? And as you can see, there are around 170. Now we are seeing the impact of Vision 2030. 170 trainee were sent locally. If you compare it to any other specialty, family medicine is the number one specialty for local scholarship. But unfortunately, still, with international scholarship, zero, nothing. And as you can see, all other specialties, you see physician being sent for scholarship. And I think we need to push more. Doesn't mean that our local training is bad or good, bad or not good, but internal medicine training is also good. locally, surgery, OB-GYN. International exposure is very important to enrich the experience of the training programs across the country. If you look at what's happening with the training programs, again, we are in the era of Vision 2030. Everything is coordinated, and primary care is a priority right now in the healthcare system. As you can see, within the Saudi Commission, the number of residency program has tripled between 2015 and 2020. And by the way, it's increasing with time because we are in an era of coordinated planning towards a goal to improve primary care in our country, and part of it is to increase the number of trainees in our country. And as you can see, residency program in the field is increasing rapidly. As you can see, the number of newly accepted residents have increased, almost doubled over the last 4 years. And right now we are accepting actually more than 700, almost 800 new graduates in the field of family medicine. Currently, around 21% of graduates are going to family medicine. 5 years ago, they were around 10%. So now 20+%, double. And the goal actually is to go up to 50%. I must say that we need to do that slowly and gradually, because we don't want to overdo it, then have a product that does not fit the requirement of Vision 2030 in terms of skills. And this is very important. If you look at this figure, which describe how family medicine trainee perceive their training within the different residency program in our countries. And as you can see, unfortunately, majority of the trainee, they look at family medicine training quality as below the quality of other specialty training. Those are our residents, those are our colleagues, and they think that training in the field of family medicine is lower than the training within other specialties. This is, I think, concerning, and this gives us a message that we need to improve the local training program. And I think this gives us another message that we need more scholarship in the field of family medicine to be able to achieve the need of Saudi Arabia for more primary care physicians, rather than just focusing on increasing the number and expanding the different residency program, because apparently this expansion could affect the quality of training, local training in Saudi Arabia. The new model of care, which is, I think, really it's a blessing in our country that we are seeing and we are enjoying in our country. We're privileged to live this era, have a special focus on primary care. As we mentioned again, Vision 2030 mentioned primary care as a very important service. That's why everybody now is working on achieving that vision. A very important document that was published, which described the new era of primary care, enhanced primary care, which involve also team-based care. Because we have general practitioners in our country, by the way, almost 50% of those working in primary care services across the country, especially in the governmental. In the private, it reached probably to 80 and 90% are just MDs. So in the new era, those MDs, they will work within teams led by board certified, or at least a physician who have some training in the field of family medicine. And there is very clear description within this document that was developed by Ministry of Health and the Vision, and the Transformation Office, what is meant by enhanced primary care, what is meant by team-based care, and they talk about effective care, facilitating access, being comprehensive, coordination of the care, continuity of care, compassionate care. So we talk about, the definition of primary care, if you think about it in the best setting in the world. So it's a very promising document, and the good news, the description of services that need to be covered is very clear, and the whole focus is, building really to achieve and to cover these different areas of system of cares and level of care that the primary care physician in Saudi Arabia will be dealing with. You really need to have skilled clinician. You need to have skilled clinician, and to develop skilled clinician, you need very strong residency program. You need a mixture of, a resident that's coming locally and internationally, actually, to just gather expertise in the field. Otherwise, this will not succeed. But I'm confident that this will happen, and we will succeed in our mission together to enhance primary care in our country. This is actually happening right now. Teams are being built. Enrollment of the population in this new services is happening already right now. As you can see, more than 1,500 teams were built already, and across the country, all over the country, and more than 1 million plus of the population were enrolled within these teams. So this is happening on the ground. So in conclusion, primary care is clearly the key to achieve Vision 2030 and healthcare transformation. Primary healthcare was the only level of care that was mentioned clearly in the main text of the main Vision 2030 document. Scholarships in family medicine need to be supported. It was ignored for years and years and years, and I think need to be supported in this era. And family medicine training need to be improved, upscaled to really fulfill the requirement of Vision 2030. Primary care and community-based research need to be addressed, supported in our country, and I think this is a still missing piece within the different research centers in our country. I think we need to highlight it. We need just, probably the society as a very strong entity to highlight it to these, centers that, okay, Vision 2030 mentioned primary care, you need to abide by it. And I think we need to highlight this issue because many information, by the way, is missing when it comes to the community-based research. Like, for example, what's the incidence of all these diseases that we are dealing with? What is the incidence of coronary disease? What's the incidence of breast cancer? What's the incidence of prostate cancer and colorectal cancer? These are the top 3 cancers in our country. Nobody knows. All these measurements that the national centers are doing are estimation based on the registry. No real, large cohort study. And I always advocate for this. A large Saudi cohort study, like starting from now up to 2030, where we gather information about a specific group of the Saudi population. Then we see that what's the impact of certain things, risk factors, prevalence and incidence of diseases within this up to 2030. And I think this is very important to achieve the goals, the huge and very optimistic goals of Vision 2030. I think the current coordinated initiatives that we see in the field of primary care, guided by Vision 2030, are expected to have, and we are seeing it already, major impact on our healthcare services within the governmental and private sector. Thank you very much.
Thank you very much, Dr. Al-Khanizan. And actually, it is indeed a call for us by our leaders and our nation to take the lead as primary care practitioners and providers to take the lead of that transformation, and we will. The challenges you mentioned, it's a huge opportunity for us to come up with our national plan on how to reform our healthcare system Thank you very much, Dr. Abdullah, and looking for your contribution in the coming events with the society. Just to give some background about how we're going to proceed with the day. As we speak, we have the max Zoom capacity of 5,000 on the stage. The rest will be redirected to the YouTube, so we still can welcome all those who registered, and everybody who will be redirected, their name will be captured, so your CME will be granted, even if you are on the stage on the YouTube, because we do keep monitoring the traffic between the YouTube and the Zoom stage. It's very encouraging actually to see on a Saturday, on a weekend morning, more than 5,000 live, plus up to 13,000 registered who are joining us on the tube. The rest of the day, so today, like so far, we have the background presented to us about the primary care, and the rest of the morning until 1 o'clock, we're gonna address governmental-related primary care opportunity and challenges. After 1 o'clock, we're gonna shift gear and go to private sector primary care. Then we're going to conclude the day with an overall plan on how to integrate both the government and the private sector primary care transformation. I'm going to call to the stage our next speaker, Dr. Cynthia Hag, who is the consultant and professor, chair of family medicine at University of California. She's one of the international experts and from our partners in the American Academy of Family Physician. Dr. Cynthia, it's a great pleasure to welcome you to the stage, and we're looking forward to this collaboration with the Academy. The stage is yours.
Assalamu alaikum. I'm Dr. Cynthia Hawk, and I'm very pleased to be invited to speak with you today. Thank you to the conference organizers and to the American Academy of Family Physicians for inviting me to speak. I'm currently serving as the chair of family medicine at the University of California, Irvine. I've been a family physician, teacher, and for more than 30 years, and have had the chance to work around the world. I'm so excited that the Kingdom of Saudi Arabia is embracing primary care as the foundation of health services. I'll share a bit of my background through this presentation. So first of all, let's talk about the objectives for this session today. We're going to talk about what is primary care, primary health care, and talk about the history of how it evolved over the last. We'll discuss why primary care is so vital for the health of individuals, families, and communities, and how primary care is organized and delivered in many different locations. We'll talk about who delivers primary care, and how primary care relates to other health services, such as subspecialty and public health services. We'll talk briefly about the essential requirements for a strong primary care system and forecast the next steps for the Kingdom of Saudi Arabia. My presentation will be followed by Dr. Alain Montagut, who will be talking in more detail about the implementation of primary care in Saudi Arabia based on his experience and consultations there. First of all, I'll share that my career has been dedicated to primary health care. I've had the opportunity to work in the United States, in sub-Saharan Africa, Asia, Latin America, and even at the World Health Organization in Geneva, Switzerland. It has been my pleasure to follow the development, growth, and expansion of primary care around the world, and to serve as a teacher and a catalyst for triggering the development of new primary healthcare programs in areas of great need. I believe that everyone should have access to basic primary healthcare services. And it's been my honor to be a part of the growth of this specialty and to work with colleagues throughout the world who also share these values and beliefs. And I'm so excited that Saudi Arabia is moving forward with plans for primary health care. I'm going to start with a brief reminder that health begins in the family and in the community. People are healthy not so much because of medical conditions, but because of where they live, work, and play. The family is usually the most important and first source of health care, of education, of health promotion, of training habits to be healthy, to eat the proper food, exercise, get sleep, and look after one another to build healthy social connections. One's culture and one's community also plays a very big role in health because the community and the culture shapes health behaviors. Many of us are as healthy as the community that we are a part of. And so the family and community context are the most important sources of health, assets, but also risk factors, because we often will find risk factors that endanger health in the family and community. And so we need to keep in mind that while we're promoting primary health care outside of the family is the first source and most important source of trusted health information. I'll share a very brief history of the development of primary health care around the world and how this was established in the first place. The prevention of illness and treatment of diseases were integrated into healthcare delivery for many centuries. In fact, primary healthcare was embedded in healthcare services. It was only after World War II that the explosion of medical knowledge and information that developed so rapidly led to many subspecialties of medicine in which primary care became a bit separated from what was happening in the hospital and in subspecialty development of services. And so this subspecialization, while it allowed for the implementation of fabulous discoveries that improved people's lives and lifespans, it also led to a degradation of the important role of prevention and primary care that was so fundamental to healthcare services. In recognition of this fragmentation of care, many international and global efforts began to try to reactivate and re-emphasize the importance of primary health care. Initially, the focus after World War II was on the control of infectious diseases, because infectious diseases were some of the chief causes of mortality around the world. There were selective, or what we call vertical programs, that paid attention to these particular diseases, providing vaccines and immunizations and treatment of tuberculosis, for instance, and malaria. These vertical approaches to control infectious diseases resulted in remarkable improvements in lifespan and in child survival. We had the eradication of smallpox, the reduction and almost elimination of polio, measles, cholera, and tetanus. So many of these killed many people and many children. But we also recognize that while these vertical programs were very successful in controlling individual diseases, there was limited success in reducing non-vaccine preventable diseases, such as chronic diseases. And so the limitations of these vertical programs inspired new integrated models of healthcare. Many people recognized that vertical programs treating one disease at a time was fragmented and was very expensive. And the specialized hospital-based systems did not meet the needs of the poor or people living in more remote and rural areas. International organizations, some governments and non-governmental organizations started experiments to improve the health of populations and to reduce health disparities and inequities due to poverty and rural living. And attempts were made in many different countries around the world to provide community-based, comprehensive healthcare services. These experiments started to show promise and started to show marked improvements in the health of communities and populations. At the same time, the vertical programs led to improvements in life expectancy and shifts in the demographic and epidemiologic profile of many countries and communities. We know the demographic transition is still underway, and the human population continues to grow exponentially. We've gone a few million people living in remote communities around the world to now nearly 8 billion people around the world. The human population is expected to plateau somewhere between 9 and 10 billion people by the year 2050. We believe that's the carrying capacity of our planet Earth. And of course, we're very concerned about many environmental challenges that are resulting from the growth in the human population. While people are living longer, this is also leading to changes in the disease profile. Greater numbers of people who are living into their senior years, suffering from other types of problems that were not a challenge when most people died at young ages. At the same time, we know many countries are experiencing rapid population growth and not able to meet the basic needs of the human population for water, food, education, and healthcare. And many of these challenges are being exacerbated by changes in the climate. We're seeing an epidemiologic transition because improved control of infectious diseases leads to longer lifespan and a greater number of elderly. Urbanization and changes in diet and exercise have led to an increase in the prevalence of chronic diseases such as hypertension and diabetes and cardiovascular conditions. Many countries are faced with the double burden of high levels of infectious and chronic diseases. Additionally, with road traffic accidents and violence, some countries are facing the triple burden of infectious and chronic diseases and traumatic injuries. This constellation of problems creates a challenge for health systems and requires new delivery models to meet the needs of the growing population. I'm delighted to share a bit of the history of the development of the primary healthcare movement, which began really early in my career and partly inspired me to become a family physician and to lead these efforts. In 1978, the World Health Organization and UNICEF held an important conference and invited all the countries of the world to Alma-Ata in the former Soviet Union. The goal of this meeting was to promote child survival, but at the same time, recognizing that child health was dependent on the health of the adults and the community. And it was from this conference that the primary healthcare movement was born. Primary healthcare, first and foremost, defined health as a state of physical, mental, and social well-being. All the countries that attended the conference agreed that primary health care and access is a fundamental human right. And in fact, health is one of our most important human rights because it's a prerequisite to the other rights, including the opportunity for education and employment. Health is so fundamental. We also know that the attainment of the highest possible level of health is an important individual and social goal. Governments have a responsibility to promote and protect the health of their people. We know that health is fundamental to economic and social development, and primary health care is the foundation of ensuring access to the basic services that everyone needs to live, grow, and thrive. More than 180 countries conference and signed on to the Declaration of Alma-Ata, which defined essential health care as primary health care based on science, on social acceptability, that primary health care should be universally accessible to everyone, to individuals and families at the community level. Primary health care was defined as the basis of any country's healthcare system and the basis of social and economic development. And also, primary health care was recognized as being important as being delivered close to people where people live, work, and play. Because in order to have access, it needs to be convenient and affordable. Primary health care was defined as the very first step in a continuing healthcare process. And I'll add that the first step outside of the family, because it's often the family decision about when and if to access other healthcare services. Primary healthcare was defined as both a level, the first place where people go, and a philosophy, a comprehensive package of healthcare services. Primary healthcare is to be personal. Ideally, people should know their primary care clinicians, and they should be feeling comfortable in this environment. It's the first contact, but also continuous over the course of one's life. Comprehensive, to be able to address any healthcare problem, at least to recognize problems and to refer, if needed, up to other levels of care. Primary care plays a very important role in coordinating healthcare services. It must be based in the community in order to be accessible. And it becomes then the hub or the centerpiece of the health system, equitably distributed according to the population, the highest possible quality at the lowest possible cost, so that this healthcare would be cost effective, culturally acceptable, adhering to the cultural norms and traditions, and also accountable to the people being served. This is a tall order and a very broad conception of primary health care services. But it was so important to set the stage for many efforts to follow. And I'll say that we're still trying to realize the vision that was set in Alma Ata. I would like to recognize that Dr. Montaguet shared some of his slides from Saudi Arabia, and while I haven't had the chance to visit myself, I look forward to the opportunity one day. But you might recognize some of your colleagues in the photos to follow. But let me just emphasize, why is primary care important and essential for health? It's the foundation of any healthcare system. Prevention, treatment, quality improvement efforts. It improves child survival, maternal mortality, the management of chronic diseases. In primary care, we can take care of acute trauma, stabilizing patients who may need referral to hospital or other levels of services. We can provide end-of-life care and, of course, referral to others as needed. I've often said to my students, my trainees, one of the most important skills of a primary care physician is to know our limitations and when to make referrals to others. So we're an integral part of this service. I'll share that I had the privilege of working in a small dairy farming community in rural Wisconsin for nearly 20 years, where I cared for up to 5 generations of some families. I delivered the babies. I cared for the mothers and children. I made home visits to the grandparents who may be dying. I took care of acute trauma, chainsaw injuries, kicked by a cow. I had the chance to do so many things as a family physician, which I still enjoy today. I'll share a few examples from my practice early on, and this was at the beginning of the primary healthcare movement. I had the chance to go with my husband and then 3 children to Uganda to survival. Primary health care, we reduced child mortality years. It was such inspiring work. So child survival, prevention, immunizations, monodevelopment, treatment of respiratory illnesses and infectious diseases. I also had the opportunity to work in Afghanistan, the late early 90s. Unfortunately, Afghan women had some of the highest maternal mortality rates for women to receive treatment and prevention and prenatal care and screening, and to manage the complications of childbirth and reduce maternal mortality. Unfortunately, in many parts of the world, difficult challenges in improving and accessing basic health care services. We treat everyone, women, men, children, the elderly, acute illness care. Our doors are open. We're so that any patient can come to us for care and treatment. So we must be prepared with a very broad scope of practice, skills, knowledge, and experience. I'll shift now to the organization of primary health care and how it system. ideally or the hub of any healthcare system, where we provide care to individuals and to families, but we also provide through community health workers, through nurses. We can refer patients to treatment and other types of services. We can refer amelioration programs. We can address domestic violence and provide shelter, safe shelter for families. We can train education programs. And of course, we can refer to the department and or to the hospital when needed. I often told my patients that my job as their family physician as much as possible and at home with their community and experience during the COVID pandemic that we've all experienced over the last few years. Who delivers primary health care services? Well, it takes a team, it takes a village to provide this important members of the team. And in many parts of the world, the bulk of primary health care services, completed postgrad. Primary care can also be delivered by pediatricians or internal medicine generalist physicians, and in many areas by obstetrics, where family physicians may not deliver babies. For a very robust team of actors, these services can be delivered by nurses, nurse practitioners. The comprehensiveness really comes in the team-based care. There are many barriers to implementing primary health. Barriers can be structural, philosophical, considered as prestigious or well supported as others. Specialty should really emphasize the importance and the great value of primary health care. Essential to ensure primary health care delivery, first and foremost, leadership. And that's why I'm so privileged and excited to be presenting to this conference of Saudi Arabian leaders in healthcare today. You will be, this leadership is absolutely the regional and the local level. Dedicated resources, including human resources, training and retaining clinicians where they are needed, financial resources to ensure that those human resources are well supported and incentivized, and physical resources to ensure that the facilities and the services and supplies are accessible to all. I know that Saudi Arabia has done a remarkable job dealing with the COVID pandemic, for example, and this was through collaboration and leadership between public health and primary care. I'll also emphasize the importance of having accurate data. Data must be collected and reviewed on a regular basis to assess the quality and to improve the quality of healthcare services. This also ensures accountability to the population that's being served. Unfortunately, many health systems are diverted from delivering primary health care because many efforts and many resources are concentrated in the hospital or through the private sector or through commercialization of healthcare services. Healthcare is often very fragmented. And so this requires a re-evaluation and a redesign with a focus on health equity, universal access to people-centered healthcare to ensure that we have healthy communities throughout every nation in the world. I'll mention that in 2008, the World Health Organization re-evaluated the progress of the world in achieving primary health care. And they were able to recognize that while some countries had done a very good job ensuring a foundation of primary health care for everyone, many countries, including the United States, I will say, are still falling short, with many people falling through the cracks, many people in remote and rural areas having difficulty accessing the services that they need. And so the WHO emphasized the importance of universal healthcare coverage, leadership, service delivery, and public policy, all fitting together, part of the puzzle to ensure access to primary healthcare for all. All of these components are essential, and all of these come under consideration now in the Kingdom of Saudi Arabia. In order to renew and ensure primary health care is available to everyone, we need to design health systems with people at the center. Primary health care is a set of values and principles that can guide the development of the entire healthcare system. And we know that health systems can be designed to provide these essential services to modern societies. And indeed, we have many examples of exemplary practice from around the world that Dr. Montagut will be sharing with you shortly. How does one move from a disease-focused healthcare system to a people primary care system? It's by focusing on the health needs of the population. The system should be designed to meet the priority needs, to ensure long-term continuity of care and personal relationships between patients, families, communities, and the health professionals, to ensure comprehensive long-term care and responsibility across the entire life cycle from preconception to the end of life. We say from womb to tomb in primary care. And to also activate and invite people to become partners in managing their own health and the health of their community. By activating people and families, they can become the most important partners in their own health and well-being. We know that primary health care is a matter of treating the individual, but also with a focus on caring for the family and caring for the community. So primary health care requires a very careful coordination between individual clinical services and public health efforts. In order to ensure a health system based on people's needs that emphasizes primary health care. We need to activate health professionals, such as in this conference, but also academic institutions, universities, and medical schools, policymakers and governmental organizations, our health managers who ensure that the clinics are operating smoothly with the supplies needed, as well as inviting and activating the community to inform and participate in their own healthcare planning. And I'm sharing this figure from Dr. Charles Boland, a dear colleague and friend who worked more than 30 years at the World Health Organization to promote primary health care and human resources for health. And I had the privilege of working side by side with him for several years. So I'd like to take time to thank all of you, the conference organizers, many colleagues around the world and at the World Health Organization, the American Academy of Family Physicians, for organizing this important conference, for giving me the opportunity to share some stories and the importance of primary health care. I applaud your efforts. I'm looking forward to learning about your progress. I'll be joining you during the question and answer session to follow so that we can talk in over Zoom, not in person, but I hope one day I may have the chance to visit you in person in Saudi Arabia. And thank you so much for the opportunity to speak with you today. And I'm wishing you well. Allah Hafiz. Thank you.
Thank you very much indeed, Dr. Thinsia, for this very informative presentation. We're gonna call to the stage Dr. Khalid Abdul Karim, who is the Assistant Deputy Minister for Primary Care, who is gonna address us about they are the largest sector. The primary care at the MOH is the largest sector of the primary care in the country, and they are the main driver for the transformation. So we're going to hear from Dr. Khalid about the priority of the primary care transformation from the MOH perspective. Dr. Khalid, are you with us?
Yes, assalamu alaikum.
The stage is yours. We are excited to hear from Dr. Khalid, and we're going to hear about your priority when it comes to the primary care transformation.
Thank you, Dr. Hadi, for having me today. I'm really, really enjoying what I heard. It's all, and everyone is enthusiastic to contribute and to push the primary care to the position that we aim always to have. We all know the importance of primary care, and everyone is trying to help from his position to reach the ultimate picture that we all aiming to have in our country. I would make it as a storytelling. I would discuss. Actually, I wanted to share some slides before, but I have some problems with my phone, with my computer. But anyhow, I think the story is very important to understand what's going on and why there is a lot of questions, a lot of things. It looks like an easy fix, but we don't really react to it the right way. To start, let's admit that what we want in our country to reach and to have in primary care is really, we are not even close to that. And we are all not really satisfied with the current situation of primary care. It doesn't mean that those who work in the primary care before, they didn't do their job. They did amazing job. They established a good infrastructure in the primary care, as well as they did a great job on working on the human capital, especially the family physicians. Now we have a lot of residency training program, and we are having every year a good number of talented, skillful family physicians joining the healthcare system. In the primary care, we have to understand in the current, let's say, recruitment system and its current policies, it might be not in favor of primary care, especially that primary care is not a unified or a clear structure unit like the hospital to fund it very well, to measure it very well. And that's why in all, and most of people, when you talk to them about the primary care in Saudi Arabia, they just think about the primary care center. And that's why always when I ask anyone, what do you mean by BHC? C stand for what? Is it care? Is it clinic? Is it center? This is the first thing I need to start my discussion with. We should ignore the setting. We have to think about the care as a structure, as a system. And if you want to see if the primary care as a function is functioning very well, you have to challenge it against the principles of primary care, well known to everyone. I'll take it one by one. Do we have a good access to primary care? Yes, we have access. We have a well-distributed primary healthcare center. But is it an access to the care or access to the building? When you go to most of the primary healthcare centers, you don't get the service that you are expecting to have as a primary care. So that's why I think we have a challenge in the access as well, although we have a lot of centers all over the kingdom. Do we have a comprehensive approach? Everyone can say no. We have a lot of, let's say, gaps, although we are doing very well in the others, but still we have a lot of gaps. Do you have effective care? You can't have effective care if you are deficient to certain tools, medications, investigations, and systems. Do you have cost-effective or efficient system? If you don't deliver what is required, you can't say I'm efficient. Do you have a comprehensive, or do you have a continuity of care? This is the thing that I know very well, and everyone knows the continuity of care is not there. And what I'm really worried about, that a lot of people are misinterpreting the continuity of care, considering that if you have a clear pathway across the systems and going from team to another with a good integration and good coordination, they think this is the continuity of care. Continuity of care, it means that you have a long-term healthcare plan with your provider, with established trust and established relationship with your primary healthcare team. And this is not really existing in let's say, systematic way. With these assumptions, besides the service that we provide, we need to always consider where was the focus and how we can correct that. We were thinking about all the resources that we need, all the challenges that we have, but we said, no, we need to know what is the root cause. The root cause, I can summarize it in number one, the concept. Everyone in the community, everyone in the country, the decision makers, physicians, even family physicians, other specialties, all healthcare workers, as well as the community, as I mentioned, and they are the most important one, should understand the concept of primary care. We need to set our expectations right. And we know how can primary care help us to take care of ourselves and to have a healthy community. And how we focus in primary care to be a person-centered, and let's say, and let's always avoid the term of patient-centered. In primary care, this is a proactive, preventative approach. It is a community-based rather than a facility-based. That's why you need to reach out the community. We need to do your task and your job to maintain their health before you treat the sick ones. So that's why keeping the prevention as a main activity in our work is a very important pillar in the concept that we need always to maintain. Having a reactive approach, having a clinics to become as a walk-in service for some of the minor needs. It's important, but this is not the primary care. Being always doing a chronic disease management with advanced cases, with established complication. Okay, this is a primary care, but why we don't react before? Why we don't work harder to prevent these diseases? Why we don't work harder to help these people before they get the complications? The number two concept, or number two, let's say, root cause, in the system of Ministry of Health, I'm not talking about the other systems in the country, but in the Ministry of Health, we have a lack of leadership. If you talk about the structure itself, it was not designed in a way to have leadership or clear leadership with a clear impact on the healthcare or medical intervention in primary care. We have those inside the centers, yes, but what about the whole structure? You can't have a scattered care delivery units without a good coordination between them. Without a good leadership. That's why we see a lack of talent, lack of training, lack of resources, because there is no leaders who are asking to have that. There is no leaders to follow up, no leaders to execute it the right way when it is provided. And the third one, it's the accountability. If you don't have a clear accountability, no one knows the exact role. Accountability not only within the structure or the a leadership, let's say, scheme that we have. The accountability, it's to our community and to the people we are taking care of. It's usually in the outpatient setting, not only in the primary care. Your relation always depends on what you do within the consultation time. So if you examine very well, if you document very well, you will feel that you did your job. What about a patient with a possible, let's say, cancer? He has early uncertain signs and symptoms, and this is very this is a not uncommon situation that we encounter in primary care. Usually we deal with uncertainty, with early symptoms and signs. If this person came to you and you were worried, and then the patient disappeared, all of us will feel that this is not our problem. We are not accountable to this patient. Although we might deal with someone who's really anxious and will stay avoiding the bad news until he has a complication or reach to a stage in the cancer that you can't really treat. Some of them, they will have a misunderstanding. They don't get it from the consultation. They can't digest the information and the instruction that you gave to them. So you might lose them as well. But if we feel accountability and we have very clear accountability to a clear panel of people, and it's not only on the physician, it's on the team, on the care coordinator, on the nurse, with a clear established relation, everyone in that team will be accountable on this target population. And that's why this is came as a top priority. And we started to do that and working hard to do that during the pandemic. Maybe a lot of activities stopped during the pandemic, but not this one. This one was really important. It was communicated through all levels. And we're really happy that one of the 5 major achievements announced by the Ministry of Health during the budget declaration this year was having the team-based care or family a physician for every family. I want to set our goals to be really realistic and practical. We can't have family physician for every family right now. We don't have enough family physicians, although we have a lot of them in the pipeline, and we are really waiting them to join. And there is a good expansion in primary care activities, residency training, and we know this challenge has been a big challenge before, but right now, I think in 3 years or 5 years, things will be much, much, much better. That's why we need to have the help of every family physician to help our colleagues, the general practitioners, in more training, and to work with them to have these teams effective. If we want to reach to our target, everyone in the primary care should engage, should work in terms to have all of these people or all the targets that we are aiming to achieve is done. As of now, we reached 2 million people registered. During the check and examining what happened already, 35% of them, they were really actively approached. The basic assessment or clinical interventions needed started. We are implementing this concept in 50% of the primary healthcare so far. And His Excellency the Minister put a target this year to reach and register 10 million people in this program. So this is a very important, let's say, activity that we need to focus on. Usually we spend our time talking about the CAPEX, about the deficient, let's say, tools and resources, but we can't quantify it. We can't know where the deficiency exactly in the system. But now, if you have a talented physician who has a clear panel of beneficiaries, healthy one, families, and those with complications, those with chronic disease, we will be able to know where are the needs. And if there is anything deficient to the physician, it's our task to work together to provide it. And that's why we implemented, or we start to have in every VHC a readiness, which is electronic readiness tool that has to be filled every day, as in the morning huddle, where they highlight where are the deficient and the needed, let's say, tool and resources. So the region will react to have that. In terms of leadership, we are introducing, and we are, as of yesterday, we set a very clear target that we need to work in primary care. The primary care as a system, it has to be well defined for everyone. All the interactions, the relation between primary care and the community, the relation between physicians, the relation between all healthcare workers, the relation between the administrative staff, as well as the relation between the primary care and the other levels, with the hospitals, with the admin, with the C-suite, with the CEO of the cluster, has to be well defined. The roles and responsibility. The primary care leaders should have clear roles. We should trust them. We should delegate work to them. We have to give them a clear accountability, and we have to help them and provide the resource to them and give them the chance to work and to show us what they can do in the networks they are in charge of. And when I say network, it means that we will have like units of primary healthcare centers bundled together to formulate the primary care system within a certain cluster. And these bundles will have, of course, primary healthcare centers with the basic, or would say the essential services in the model of care, as well as if we have, let's say, the essential plus services, those services that we don't need to have it in every setting, but it will be like a shared services in a very clear network. And to take care of the teams that we have, the panels, and having the empanelment concept done in Saudi Arabia, like most of the countries, done the empanelment, and it has a very clear impact in health system. Doing this over months, over 1 or 2 years wouldn't be easy, and we don't expect that we would reach the final stage, but we need to carry it out. The pandemic was really helpful to us to evaluate what's going on, and the primary care was one of the most important player in the pandemic. And I had the honor to work in the pandemic, and I saw the transformation and the plans of primary care just right before the pandemic, and all those plans. and maybe I just joined the ministry before the pandemic, just 1 month or 2 months before the pandemic started. We halt certain activities, but we continue in others, especially what I mentioned, the team-based care or the empanelment concepts, to have a physician for every family and for every individual. And we continue doing that. Besides, in the pandemic activity, I had the honor to work in the mass testing, to be in charge of the mass testing, to be in charge of what we call it fever clinics, تطمن clinics. We saw the pressure on the hospitals in the early months of the pandemic, when cases start to spread and people getting panicking and going to the emergency rooms. So while the decision of roll out fever clinics in BHCs was very important to relieve the emergency room, and it was really a very successful story. So far, we received more than 4.5 million people coming to the primary care and to these fever clinics, being managed and referred, if needed, to the hospital. And we just referred 1.5% of those came to us. As well as the being in charge of the vaccination program, I was really enabled to test the system and to see that the primary care contributed the most in vaccination program. Based on the setting and based on the human capital, I can say the primary care did most of the work, and really we vaccinated and we reached more than 70% of the community vaccinated with 2 doses. And that's why we can see the control of pandemic. And maybe Saudi Arabia is the second country in the world in the good control of COVID, because of the activities and the well-designed plans done during the pandemic. Did we know what to do during the pandemic? It was uncertain for everyone. And the common, let's say, word that we hear over and over when we have meetings with the experts from all over the world, it's we don't know. So there was uncertainty, big one. No one was really sure about the steps, but we worked hard. We tested everything. We set everything right, and everyone was contributing to reach to that state. And this is what we are aiming to have in primary care. We want to work hard. We want to test in close observation and trying to work hard to roll out the successful, let's say, projects, and to correct or even to stop the failed one. No one can say that I would start and all of the projects that I'm proposing will be successful. No one can do that. But with the close monitoring, with trying to get the whole resources you need and to arrange the right, let's say, plans, you will have a high chance to get successful. That's why I was really glad to contribute in activity over the last week. All the health care leaders and the Ministry of Health were with us in Rabigh, and we were discussing what to do. And the primary care was 1 out of 9 teams to set their strategy for the 5 years and to set one important project to roll out in 2022. And I was really happy to be with my team, winning the first and announced to be the first among the 9 teams with a clear plan to roll it out. In summary, and I will stop with this, we said primary care as a system is not well defined. And that's why we need to work hard to make it a very clear system, very clear leadership, empowered leadership. And our target 2022 to work with 3 clusters, to work in close with them, to monitor every activity, to help, to provide all the support, and to learn from the mistakes, to reach to 1 or 2 or 3 models that can help the primary care. This is number 1. The number 2, we said we have issue with trust and satisfaction. So we said we have to gain the trust and satisfaction of the community to make primary care is #1 choice for most of citizens if they want to seek help. And to get this care, to get this trust and satisfaction, we have to stop calling primary care as the gatekeeper. If you go anywhere, you don't care about the gates and you don't care about the keeper. You want to get inside the building. That's why we said primary care, and this is the concept it is a person-centered medical home. And when you go to any home, you need to have a partner. The partner is the healthcare team in team-based care. So you will sit with them a long-term plan, and you will work with them in close to reach your healthcare targets along with your family. So we will ensure a healthy life for your kids, for all the age groups and all the health needs, and we'll work hard on the risk factors. And how to carry out this? We will carry out the promise and the plan by His Excellency the Minister when he said the primary care is team-based care is the flagship project, and all the support should be provided to that project. That's why we work hard with engineering department, with IT department, with the finance department, with the human resources department, you name it. All these, let's say, partners would work with us to make and to provide all the needs. We don't want just to register and just to have the activities on paper. We want it to be real, to be calculated, to be measured, as well as to get a high satisfaction based on that. And maybe Dr. Hadi and other colleagues, they have the information. And one of the most important things is to communicate the message right. And we will have a very strong campaign about this project to the community and to the healthcare worker, and everyone is welcome to join. The third one, it's to have the primary care system as one of the best healthcare system in the world in 3 to 5 years from now. How to have that? As I mentioned, we have to make the system very clear, and we have to have the primary care of future. We want to reintroduce the primary care. The primary care center has to be really well equipped and has to function based on the concepts of primary care. We don't want to have a primary care similar to hospital where we have a different specialties. This is not the primary care approach, not family medicine approach. We want to focus on that. We want to have a primary care with very skillful family physicians, and to have it able to provide a comprehensive care, effective, efficient, coordinated, integrated system. So always we think about this, but we don't have a real a model that we want to work on. So we said, why not? We work together to have, let's say, premium outlets for the vaccination. It was a franchise of vaccination. We work hard to have something bigger and more difficult than the primary care. So why we don't focus and to have 10 primary care this year to be the ideal primary care? That doesn't mean that we will not work on the others. We ask every region to work hard, to do their best. Maybe we'll end up at the end of the year of 25% of the existing primary care enhanced, and we'll rebrand it in a way that everyone will try to will really respect and will understand the role of these centers. But we will focus in the beginning on 10 of the primary healthcare to measure and to evaluate every tiny process in the primary care. We want to evaluate where the problem is. We want to know if we invest there, is it cost effective? Is it going with the principles? We don't want just to put money in a certain center and we will end up with a fancy building. This is not the target that we want to reach. It's something that we want to have a very effective primary care model and to scale it up and to roll it out in all centers. I'm sorry to getting much of time explaining this, but I was really trying to summarize all the activities. And my final message that everyone is welcome. We welcome every critique, every point, every suggestion. Everyone wants to be part of these projects. These projects always, and every huge project can't be carried out by a small team, can't be carried out by a certain department or certain entity. It's a national project, and everyone has the right and welcome to have a call in these projects. Thank you so much.
Thank you very much, Dr. Khalid. I'm very thrilled to hear about the plan and the commitment about our primary care reform and about our health home. I wouldn't even call it medical home, it's a health home. And looking at this morning, Saturday morning, where you have with us all leaders of primary care, and till as we speak, His Royal Highness Prince Abdulaziz bin Talal is with us, and we have the crowd on the, like, we reach the maximum on Zoom 5,000, but on the YouTube we reach 13,000 who are very passionate and interested. So I would summarize what you said. It's about leadership, it's about people, and it's about the process. And reform is our target and destination, and we shall be right there to get the support and to your plan. I'm gonna call to the stage our Family Medicine Future. May I call you all please to come up and open your cameras. Can you open your cameras all, please? Family Medicine Future. Okay, so we're gonna share with you what we promised for the 22 plan to support the effort led by the Ministry of Health, led by the whole sector. So we're gonna start about a few initiatives organized by the society, and it's only the beginning, and the sky is home. So let's start with the first one. Dania?
Yes, hello, assalamu alaikum. Good afternoon, everyone. My name is Dania Al-Ghaithi. I'm a second-year family medicine resident, and I'm a member of the Saudi Society for Family and Community Medicine, as well as a member of the Family Medicine Future Group, better known as FMF. In hearing about this conference, Primary Care Now and Forever, I was excited to just attend this conference, and I am beyond thrilled to be here with you today to share with you this upcoming project brought to you by the Saudi Society for Family and Community Medicine, as well as the FMF Group. Primary care here in Saudi Arabia is undergoing a massive transformation that we as family medicine residents get a front row seat to, as well as the unique privilege of participating in and giving energy and strength to. And in the interest of giving new energy to the ever-evolving field of family medicine, I am proud to announce Revive FM. Revive FM is the podcast led by family medicine residents and physicians across the nation. Revive FM is the podcast where we will review pertinent articles, reform our understanding of medical knowledge to be more practical, and revolutionize family medicine with our voices, all with the help of our very own family medicine residents and physicians. Review, reform, revolutionize. The Revive FM team invites you, family medicine residents and physicians across the nation, to come and join us and lend your voice to the transformation. We also invite you to join the Saudi Society for Family and Community Medicine, as well as the Family Medicine Future Group. Stay tuned for our very first podcast coming to you on the very first week of January. Details on how you can tune in, where you can listen to the podcast, and how you can be on Revive FM as well will be shared through our social media accounts on the Saudi Society for Family and Community Medicine Twitter account, as well as the FMF Twitter account at FMF 2030. Stay tuned, follow us closely. Thank you for listening, and I hope to hear you soon on Revive FM.
Thank you very much. Let's go for next.
Assalamu alaikum. Hello, everyone. Hope everyone is doing fine. My name is Daman Mhesh. I'm a second year in family medicine resident. I'm a member of the Saudi Society of Family and Community Medicine and the FMF. I'll begin my talk by emphasizing that healthcare is one of the main focus areas of the ambitious Saudi Vision 2030. We, family physicians, are the focus of attention of this transformation. Family medicine, which promotes the integration of both behavioral and physical models of illness, serves a vital role also in providing mental health care services. We are in the best position to address the behavioral health. Transformation within the primary care have called for the reintegration of mental health into a comprehensive care. From what I've said, I think you've guessed the first conference that will be run in 2022. It is the Mental Health Care Conference, where we'll be covering the most important topics that a primary care physician must be aware of, as mental health well-being serves a part in both preventive and curative purposes. You're all invited to attend this conference that will be held by the end of January 2022, and you're invited to participate in the FMF and the Saudi Society of Family and Community Medicine. Please remember and don't forget that every one of us has a role in this health sector transformation. See you all in January. Sky is home, and thank you.
Thank you very much, Lama. Next.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon for everyone. This is Azzam Al Ghuraini, family medicine resident, second year, and a member of Saudi Society of Family and Community Medicine and FMF. I would like to thank all the speakers before, because they give us an power for do all the best for the future. And within these few minutes, I would like to announce about one of the most important comprehensive urgent care that I know all of us will be exciting to attend and participate in this conference, because all of us know that it's a part of our vision 2030 transformation. As a family medicine, as a family physician, we are a big part of that transformation, and we must continue growing and expanding our programs and services to meet the diverse and changing need of our community we serve. In the Urgent Care Conference, we will talk and discuss about the role of family physician in the urgent care and how they participate in leading the transformation of health, including providing timely, cost-effective care, integrating care of both acute and chronic illnesses, collaborating with national stakeholders to reduce the health disparities, and ensuring that our country has well-trained primary care workforce, and for the future, for the expansion and for transformation of training. Dear audience, don't miss the opportunity to be part of this event, and mark your calendar on February 2022 and make it as urgent for upcoming conference. Finally, be updating with us by following the Saudi Society of Family and Community Medicine, FMHub, and FMF on Twitter. And don't forget, the sky is home. See you there. Thank you.
Thank you very much. Indeed, the sky is home. Next.
Good afternoon, everyone. It is my pleasure and honor to announce one of the conferences that will be held in 2022. My name is Al-Jawhar Al-Jaber. I'm a family medicine resident, a FMF member, and a Saudi Society of Family and Community Medicine. From the simplest primary health care that has a minimum standard of primary care equipment to the mega center that contain different supplies and many facilities, all of these primary health care providers do not never encounter at least one of long-standing chronic condition. So I believe every family physician should expand his knowledge and update his knowledge about chronic diseases. So I would like to invite you all to be part of this huge venue, CDC conference at the beginning of March 2022, that will contain a new modalities of intervention in chronic diseases and a new updated guidelines, of course, from primary care perspective. And by 2030, health transformation, if MOH, Ministry of Health, will mandate the chronic care of a chronic complex patient with the highest level of engagement to the family physician practitioners. So I believe it's quite a huge responsibility that needs a huge effort from us. Hope to see you all there. Don't forget to join FMF and Saudi Society of Family and Community Medicine. Sky is home.
Indeed, the sky is home. Thank you very much. Next.
Good afternoon, everyone. This is Imam Bukhamsin, a second-year family resident and a member of Saudi Society of Family and Community Medicine and FMF. We talked about mental health, urgent care, and chronic diseases. Now it's time for women's health. During the last few decades, Saudi Arabia's population has gone through significant demographical and epidemiological changes, such as increased life expectancies, increased rates of obesity and smoking, and a higher prevalence of metabolic syndrome. However, at the same time, there has been great advances in the services and care provided to women throughout their entire lifespan. This dynamic scene puts us as family physicians in a very peculiar situation where we must continuously and progressively advance our knowledge and skills in this vital field. This is to meet these rising standards of Saudi healthcare and to address the demands of the health sector transformation program, which is a part of Saudi Vision 2030. Thus, it is my genuine pleasure to invite you all to join us in the Women Health Conference, which will be held at the end of March 2022. On this conference, we will talk about the recent updates and recommendation and the guidelines about the field and breakthroughs in the field and the application of women's health within the Saudi local context and culture. Thank you all for your time, and we are looking forward to meeting you at the end of March. And remember to join us in the Society and FMF. And remember, sky is home.
Sky is home. Thank you very much. Next.
Assalamu alaikum. My name is Haneen Al-Jafri, a third-year medical resident and part of the Saudi Society of Family and Community Medicine. I'm excited to announce about the upcoming Deep Dive 2022, which will be held in June next year. Why Deep Dive? Deep Dive is by far the largest gathering for all family medicine and primary care physicians across the country. Deep Dive is not only beneficial for a student or resident who are preparing for their exam, but also it is very useful and comprehensive for all primary care practitioners who wants to boost their knowledge with the latest update in clinical practice. Last but not least, Deep Dive this year will be a platform for all the update announcement for the first family medicine book, Family Medicine, The Essential. At the end, I would like to invite you all to join the conference, the society, and the Family Medicine Future Group. And as we always say, sky is home.
Sky is home. Thank you very much, Haneen. Another invitation, please be all part of reviewing the first national reference, Family Medicine, The Essential, which will standardize the practice of primary care and family medicine across the nation. Thank you very much. Next.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everyone. I'm happy to join you today. Thank you for giving me and my colleagues the opportunity in the stage in this conference with this huge collaboration with big institutes and encouraging us as a young generation to be a part of our transformation. In the beginning, I would like to introduce myself. I am Omar Btaishi, family medicine resident and a member of Saudi Society of Family and Community Medicine, also FMF. Facing challenges and exams are part of our residency program, which sometimes induce an anxiety and stress for us. So we think and we came up with the STORM idea. In this STORM conference, we are going to train our mind to do a brainstorm to solve medical cases and MCQs. Also, we will build a huge storm of knowledge that can smash any exam may face the family medicine residents anywhere. The storm is condensed, concentrated, and customized course to prepare family medicine residents sitting for their promotion and final exam. The STORM is MCQ course focusing on high-yield clinical and exam-oriented topics, using in-depth MCQs discussion and reviewed must-read articles. I would like and have the pleasure to invite all the family medicine residents across the nation and world to be a part of us, to be a part of the STORM in early August 2022. FMF and Saudi Society of Family and Community Medicine is yours, my colleagues. We are waiting for your hands. We are waiting for your ideas. We are waiting for your contributions. Please share with us, contact with us anywhere, anytime. We are here for you all the time. Thank you for listening. Sky is home.
Sky is home. Thank you very much. Now let's come to the last and interesting, exciting idea. Fire, please.
Greetings, everyone. It is my pleasure to introduce myself. My name is Zohra Al-Gahtani. I'm a first-year family medicine resident and a member of the Saudi Society of Family and Community Medicine. It fills my heart with pride and joy being here today, attending and participating in the Primary Care Now and Forever Conference. As a first-year resident, I feel such a great responsibility to make change and to take part in the transformation of primary care. This transformation seeks to improve the quality of healthcare services and meet the Kingdom ambitious vision. Being the change makers, we must be skilled communicators and confident speakers. In order to achieve this, the Saudi Society of Family and Community Medicine and Family Medicine Futures reveals its next project. I'm proud to announce the Toastmasters Family Medicine Club. Globally, about 5% of the Toastmasters member report working in the healthcare field. And we believe initiating a club will help us to be better public speakers and effective advocates. As we know, public speaking is a powerful and influential tool in healthcare. It is a tool that doctors must have. Being a skilled communicator and a good listener enables you to emphasize with others and appreciate another person's point of view. Having such an invaluable asset, whether on stage for hundreds or in examination room between a doctor and a patient, it can make a strong connection, even about an intellectual level. And hopefully, with Toastmasters Family Club, we will be able to achieve that. More to come with Family Medicine Future. Follow us on Twitter for further details on our club and how to join us. Wait for us and don't miss it. We would be delighted to have you as a part of our club, be part of the change, and don't forget, Sky is home. Thank you all for listening and have a good day.
Thank you very much. Okay, so FMF Future, is there any message that you want to share with the crowd?
Yes. تجري الرياح كما تجري سفينتنا.
تجري الرياح كما تجري سفينتنا. نحن الرياح ونحن البحر والسفن.
Indeed, تجري الرياح كما تجري سفينتنا. نحن الرياح ونحن البحر والسفن. Thank you very much. Dr. Khalid Abdul Karim, we're presenting you with the future of family medicine. We are presenting you with the talent that you are looking for. We are presenting to you the potential leaders that are going to lead the transformation. Before going to the break, is there any last 1 minute message you want to say, Dr. Khalid?
Thank you so much. I'm really happy to see that. I remember the announcement of the FMF. And I see now really a great work, a real work, and very ambitious members in this group. And I'm sure that everyone will participate, everyone will be attending these activities. I'll try to attend most of these activities. I know it will be really helpful. We used to have a well-prepared activities when you take care of anything, Dr. Hadi and your team. You are making really a great progress in primary care, continuing what other primary and family physician fellows and colleagues worked hard over years, and we are celebrating now the let's say 33 anniversaries of the Saudi Society of Family Medicine. And now I can see the Saudi Society is even going to expand and the new horizon. And the engagement of residents early on in the activity of the Saudi Society is the thing that we are really looking for, and we want always to engage all people, even medical students as well, early on, because the primary care and family medicine is very, very important. Thank you so much.
Okay, thank you very much. Now we're going to go for a quick 15-minute break, just enough for you to do your prayer and come back. Do not leave the Zoom, because the minute you leave, your seat will be taken away, because we have like we reach the maximum of Zoom, the rest on the YouTube. And in the afternoon, we're gonna start with a very informative session about a real life example of how things happen. So we'll see you shortly at 12:30. Please stay on stage, don't leave your seat. So with that, we'll see you at 12:30, inshallah.
تسعين عاما والشهادة علمنا، وحده توحيد وسيف تثنى، من يوم أبو ترك تنهض ونجم، قاموا لشام العز محد تونى، وخلف رجاجيل على قدر الأحداث، وانصاح صايح قال وفداك حنا، وجسنا على المنوى وعيت على الغير، وما كل عشاق وصل ما تمنى، وإن قالها الله نجعل الحلم واقع، ونطوع الصعبات بالعزم منا، نبني عمار الدار بأفكار وعلوم، ونصنع سلاح جيوشنا في وطننا، طقوا طبول النصر في يوم مجده، وسلوا سيوف بشجاعة تغنى.
من يوم أبو تركي تنهض ونجم، قام ونشام العز محد تونى،
90 عام والشهادة علمنا، وحده وتوحيد وسيف تثنى. من يوم أبو تركي تنهض ونجم، قاموا لشام العز محد تونى، وخلف رجاجيل على قدر الأحداث. وانصاح صايح قال وفداك حنا، وجسنا على المنوى وعيت على الغير. وما كل عشاق وصل ما تمنى، وإن قالها الله نجعل الحلم واقع، ونطوع الصعبات بالعزم منا. نبني عمار الدار بأفكار وعلوم، ونصنع سلاح جيوشنا في وطننا. طق طبول النصر في يوم مجده، وسلوا سيوف بالشجاعة تغنى.
من يوم أبو تركي تنهض ونجم، أبشر قام ونشام العز محد تونى. وحده وتوحيد وسيف تثنى.
بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. Welcome back everyone. And we're gonna have a very strong start for the afternoon where we're gonna share with you a very practical example of the BSc as a foundation for the transformation. It's gonna be presented to you by one of the family physician leaders in the nation, Dr. Khalid Al Mulla, who is a family physician and the CEO of Al Hassa Cluster. Dr. Khalid, it's a great honor and pleasure to welcome you to the stage.
السلام عليكم. شكرا دكتور هادي. وفي البداية أرحب بالجميع وأوجه الشكر لصاحب السمو الملكي الأمير عبد العزيز بن طلال لدمعه الجمعية، وأود أن أشكر جميع أعضاء الجمعية لدعوة الكريمة لهذه الفعالية، والتي تأتي ولله الحمد في ظل وضع مطمئن في مكافحة جائحة كورونا. لا يفوتني في هذه المناسبة إلا توجيه الشكر لجميع زملائي أبطال الصحة، وعلى وجه الخصوص أبطال الرعاية الأولية الذين حققوا الحمد لله العديد من المنجزات خلال هذه الجائحة، واعتلوا ولله الحمد قمة عظيمة شاد بها العالم أجمع. والآن أمامنا تحدي آخر وفرصة غير مسبوقة لاعتلاء قمة أخرى، وهي تحسين الرعاية الأولية. ولعل سعادة الدكتور خالد العبد الكريم الوكيل المساعد للرعاية الأولية أشار إلى برامج الوزارة الحقيقة التي يعني دائما تكون الرعاية الأولية في محور الاهتمامات ومحور اهتمامات التحول الوطني. كما ذكر دكتور خالد، كان ورشة عمل أقيمت الأسبوع الماضي تبلور حولها Primary Care for Future، والحقيقة حلم الجميع وحلم الكثيرين الممارسين الرعاية الأولية أن نصل لهذا اليوم ليكون الحديث عن البرايمري كير هو الحديث الأهم، والحديث الذي الحقيقة يكون محور خطط وأهداف المنظومة الصحية. أنا على يقين ومتفائل جدا بإذن الله سبحانه وتعالى بأن الوقت هو الوقت المناسب الآن لتحقيق إنجازات غير مسبوقة في الرعاية الأولية. نحتاج الكثير من الإصرار والكثير من العزيمة إن شاء الله لتحقيق رعاية أولية غير مسبوقة على مستوى العالم. ومثل ما حصل في جائحة كورونا كانت في إشادة عالمية بأداء الصحة في المملكة العربية السعودية، أعتقد لا ينقصنا شيء أن احنا نحقق رعاية أولية تكون محور حديث العالم في المستقبل. اسمحوا لي أشارككم بعض الشرائح في العرض. الحقيقة حبيت أبدأ العرض والسويتش السبيتش in English. Start the presentation with the basic of family physician. The basic principle of family physician is the core element that will lead the practice and will lead to the change. We all know that the principle of family physician, that number one, the family physician is a skilled clinician. And this is very important. What we mean by skilled, knowledge in most of the aspects in medicine. It is not easy to learn a chapter in each book. It's easy. It's always easy to learn the whole book, but if you have 20 books in the shelves and you need to learn and master a chapter in each book, it's not easy. And that's very important point that I want to share with all residents and newcomers to family physician to use your training program for this component. If you don't get it in your medical school and you don't get it in your medical training, most likely you are not going to get it in the future. And that's very important. Whenever you go to any rotation, like emergency department or cardiology or maternity and children care, you need to know that you need to be a good family physician and a skilled clinician. Don't forget this component. This is my advice to everybody. The second principle, that family medicine is a community-based discipline. Family medicine is not a hospital discipline. It is a community-based. We should be in the community, living in the community, and ensuring that we have an ongoing relationship with the community. And that's very important. Wherever you practice, and mashallah, Al-Hayya Saudiya الآن, Saudi Commission for Health Specialty is graduating hundreds of family physicians annually. And as far as I know, in the next 5 years, we are going to have 3,000 family physicians. So we would expect family physicians to be, inshallah, widely distributed in the country, and be part of that community, establish your relationship with that community, ensure the full knowledge of the community that you will be working with. The third component, that the family physician is a resource to define practice population. And that's a very important point for all my colleagues who will go in this discipline and practice as family physician. Remember that your population, which is anywhere from 1,500 to 2,000 frequent visitors to your clinic, you will be the resource for this population. If there is any weakness in our care system, that you will have a lot of wrong information, a lot of WhatsApp messages, a lot of social media information. You need to be part of that. You need to be the resource for your community and for your population to ask you where they want to ask. Even if they will go to a tertiary care setting, successful family physician will have a question from his patient, whether I go to this procedure or not, whether it is the right time for me to go to that intervention or not. They will trust you, and they will only trust you because you are the only person who deal with them over the years. The fourth principle, that the family physician relation with the patient is unique. The patient and physician relationship is very central in the role of family physician. Feel free to say, I don't know. Feel free to say, I will check and I will get back to you. And feel free to tell him that you need to stop smoking, you need to start this diet intervention, and start to know the patient more and know his family. Out of that, I will also like to share with you sort of a question that always comes to my mind. Why healthcare system always, successful care system always ask for primary care? What is the advantage? Then I'm trying to learn what is the aim for primary care. And if we know really the aim of primary care, we know that why healthcare system always aiming for successful primary care. The aim of the primary care is to be the best possible healthcare service for everyone, everywhere in a country or a region, with the universal goal to ensure adequate access to quality at a reasonable price. And we need to keep this always in our mind. Quality comes first. And when we talk about the principle of family medicine, if we apply the principle in the right way, quality will come as a definitive outcome, as well as a reasonable cost to the system. And we need to keep that always in our mind during our workup, investigation, and also referrals. And from that, there are following requirements for primary care that's needed to improve and maintain the healthcare for population and to restore the services to population health, which is mainly, I try to simplify it for myself in simple word, and they call it 3 A's and 2 C's. So it is accessibility, affordability, accountability, continuity, and comprehensiveness. And I will go over them one by one, what we mean by accessibility. We need to ensure that whatever level we are working on, at individual level as family physician, or at a practice level, or even at a system level, that our services are accessible. And it's very important for us at individual level, such as family physician who are coming from training, to ensure that his service or her service is accessible to his unique population. This is very important point, and I hope our colleague who are program directors will ensure this component and the practice management is included during the training program. And what we mean by that, every physician is responsible about his or her practice in terms of accessibility. So if you have a card which is an appointment that you want to give to a patient in a week, please ensure which patient you will give it to him or to her. We all learn in emergency department, we all learned in the ICU and during ACLS program that if we have 2 patients, we will start the intervention with the patient who will need us first. And I think medical school is very good in teaching that. Yet when we talk about practice in the clinic and in the outpatient, I think during medical school, we have little knowledge about that. And I hope during the residency program, each one of them, family physician resident or medical student who are coming to this field, will ensure how to manage their practice to ensure this accessibility. The second component is affordability. We need to make sure that the service is affordable. So whenever we design any primary care service and we add additional program or additional pathway, we want to make sure that there is a cost effectiveness when it comes to that. The third component, which is equally important, is accountability. Accountability is an essential element in healthcare system, and during any process that we want to ensure that the practice and the family physician is accountable for his defined population. So it's very common in medicine that we have patients coming in a gray zone and we have differential diagnosis. What we mean by accountability, that the follow-up and the continuity of care will ensure that the physician will consider other intervention and other diagnosis during the care. And the patient will not be splitted or go between one service, one provider to another. At the same time, during the accountability, when we design any service, want to ensure that we make boundaries to everybody's roles is very clear, making sure that the function of the nurse, or the function of case manager, the function of case coordinator, the function of family physician is very important, as well as the function of the specialist is very important, and make sure that the duty for everyone is clear. We want to ensure also that there is an adequate support during the system that will help the people to be accountable for the care that they will provide to the patient. The fourth important point, continuity. Family medicine is a unique specialty where you will care for patients and their families for 20, 30 years. So we want to make sure that during this period, there is ongoing continuity. Please ensure during this period that continuity is there. Don't lose the contact with the patient, as well as if there is a high-risk patient, the practice should find a way how to contact them, how to communicate with them. The last but not least important component during designing any service, that the service should be comprehensive. And this is very unique component in primary care. In family medicine, you will deal with a person, not a disease. So if the person has a cardiology condition, make sure that we care about the whole journey of the patient. We want to make sure that the quality of life and his social impact and social function are always maintained, and that's very important component. And from that, I will take you through what we did in our cluster. And this is probably similar to many regions. Al-Hasa consists of a wide range of clinics and practice. We have more than 65 primary care centers distributed in geographical region more than 1,000 kilometers away. Yet the most of the population lives in the main city and in a certain geographical distribution. So we developed the network concept where the city were split into 4 zones. Each zone consists of 10 to 15 primary care centers and linked to a hospital where the secondary care and the referral component are provided during that, in that hospital. At the same time, the hospital provide the support for the primary care, which is not available. We are in the process now to complete our central community lab, where we will have all laboratory workup and diagnostic service are done for primary care physician. They don't need to refer patient to the hospital to do a laboratory workup. At the same time, we have a diagnostic center for screening for cancer and detection of cancer early. And that's, alhamdulillah, equipped with all equipment in terms of breast cancer, colon cancer screening, or even osteoporosis screening. And from that, our probably activity now concentrate on a preventive program, where we have established a preventive program for every comer to primary care. So every patient who come and visit primary care centers depend on his or her age and risk factor. And if he's due or her due for any workup, we enter him during that pathways, and those patients goes during this pathway. So far, we have among around 300,000 population, we have screened 50,000, 300,000 visitor. The population is more than 1 million, but those who visit our primary care center in the last 6 months is around 300,000. 50,000 of them are due for a preventive test one way or another. They are not screened. So we have adapted 7 clinical pathways for diabetes screening, hypertension screening, obesity screening, colon cancer screening, osteoporosis screening, and breast cancer screening. And from that, we receive those, we end up having very successful results, alhamdulillah, in terms of detecting the disease early and start the intervention. Most of those patients, 50,000, they don't have symptoms, yet they do have ongoing disease going on. And one of the most probably great news that I receive, or great message that I received 2 weeks ago from one of my colleagues who work in a tertiary care setting, she's colorectal surgeon, passing me a message telling me that today from your region I receive 6 patient stage 1 colon cancer for the first time in my clinic. And this is that was a great news for me when I found that the early detection program, despite it was started with a simple tools and the simple concept of primary care, lead to this great outcome, and that people will start distinguish that. And this is the advantage and the beauty of family physician. The last point that we are working on, and we are trying hard to achieve it, inshallah, during this year, that the linkage to secondary and tertiary care is very important, where a communication, whether through electronic way or direct communication in particular cases, are essentially needed to ensure the whole journey for the system when they come from primary care to secondary care. With that, I want to conclude my presentation, and I'm quite sure Dr. Hadi or Dr. Khalid, if you have any additional point to add, I'll be more than happy to answer. Thank you.
Thank you very much, Dr. Khalid. I was planning to keep the question till the end of the day, but I can't help it but to have to throw a question. Like, you mentioned 6 cases. maybe the number sounds small, but 6 is a lot. To save, I would say, save 6 lives by early intervention. This is a huge, and I want to compliment you and your team on this achievement. My question to you, what was the main challenge in doing this? Was it resources? Was it people? Or just the decision and getting the people around the target and the mission?
Okay, thank you, Dr. Hadi. Actually, this is a great question. The total number who were detected early as a stage 1 colon cancer are 250, not 6. 6 was an outcome for 1 clinic only. The colleague that I mentioned, she cannot hold things to the end of the day when she found 6 patients in 1 clinic in the same region coming with stage 1 for the first time in her life or in her practice. And she said, you must be doing something different. And actually, we are not doing anything different. The heroes in primary care are doing something different. And this goes to the basic, where they really screen those patients who are 50 years plus. They start with them with a simple test, screening test. If the test positive with hemoccult blood, they refer him for colonoscopy, then the journey starts. And then this is the only way that you detect those 250 individuals in a large city with a population of 1 million plus, that you will find them in stage 1 or stage 2 cancer. And we know that unfortunately in our country, most of the diagnosis of cancer goes in stage 4 because we don't have this linkage. So the intervention is simple. Now, going back to your second part of the question, actually, it was so easy, to the point that when people called me, telling me that, what are you doing different? We are not doing different. We are doing the basic things. Even the diagnostic center for cancer screening was there for the last 5 years, but there were no patient referred to him. And this is more than 20 million real investment for that the country put in that center. There was no enough referral. They barely do 2 or 3 mammograms. So where are the patients? The patients are in the community, and we need to transfer them to this center to get the right treatment. Now, the question, which patient to be chosen, which patient to be referred, this is the duty of the family physician and the practice in the community to refer the right patient in the right time.
Dr. Khalid Abdul Karim, I'm puzzled. Like he's telling me it's so easy to be done, and yet it's not being done. So what's going on? Help me solve the puzzle.
Yeah, this is what really match what I was saying. If you have the right leadership of primary care, the engagement of family physician, we all know Dr. Khalid Al-Mulla is the CEO of Al-Ahsa cluster. He's a family physician by background. We don't want to have all the CEOs as a family physician to have this, but this will give us a good example that Dr. Khalid Al-Mulla, he invested a lot in primary care. He empowered the family physicians in his ecosystem. In the ministry, we know his colleagues, their contribution. They reach us, they work with us. That's why they are empowered. They are utilizing all the resources. To have these tests, it's there, it's available. There is a budget, and it is distributed all on all clusters and regions. Dr. Khalid, he made the difference when he pushed these resources to the community. He invested more in primary care. He linked people to the physician. The physician will know patients. He will know people, and he will reach them out to do the screening and to follow them up. We used always to have aggregates and numbers. We don't say from where we got these people. Now, Dr. Khalid, he knows from which BHC and which physician in the oncology center received them. Before, we just know that we screened 100,000 maybe, and we diagnosed 5% of them. We'd have no clue about the journey, about what was done. That's why we call this. I want maybe to add a little bit point to all my colleagues, the family physicians working in the Ministry of Health, about all what we are mentioning now. What is the difference? Am I going to feel a difference? Yes. you will be linked to a group. You will be in charge with like 2,000 people, and you'll have your colleague working with you. And if there is a trainee, he will work with you. You will search the data. We will equip you with the data. So we will analyze it. You will know it. You reach them out. You will be equipped with a tool to communicate. And now it is in Sihhati. Sihhati, if you go on the services, we have an icon. We call it Tabibi, and this is going to be rebranded to be indicating the family physician. So the only specialty in the kingdom shown in Sihhati, which is the national app with a unique icon, is family medicine. So you will be there, you will be your picture, your name, your background, and your colleagues even will be mentioned there. And this is, I think, a good empowerment for the primary care. Thank you so much.
Thank you very much. I'm truly speechless, Abu Muhammad. يعني 250 like you guys alter the life بعد توفيق الله of 250 people. This is a huge achievement. فالله يكتب أجركم. And I got so many requests coming to me. They put my cell phone on fire. We need a special أمسية with you, Dr. Khalid Al-Mulla, about your initiative حقت الحسا. We want you to share this with the whole nation because it's the right for everybody to expect the same. Whether في الحسا, في حفر الباطن, في نجران, في جيزان. And if the resource is not an issue, then we just need to make it happen. So I will invite you and your team through the society to share your expertise with the whole nation.
Sure. We will be delighted and honored to share the experience. If you allow me to conclude, I think we have 3 minutes. The intervention is simple. It's very basic. We need all to learn, as I think we have more than now 10,000 individuals who are joining us, and most of them are in family physician. We need to keep the principle of family medicine there. We need to ensure that during our training program that we manage the primary care as practice. Physicians are a core element of practicing and managing the practice, as well as the support services and from nursing, case coordinator, and case managers. So we want to keep that in our mind all the time. The other message that, if you allow me, Abdul Malik, to share, so the community are strive to have this going on. In addition to the 250 population, we have found that 1/3 of the population that we screen for diabetes are diabetic and they don't know. 1/3 of the population are pre-diabetic and they don't know. And when we pass this information even to the municipality, to the baladiyat, they start to know what's going on in the community and what burden we will have in the future. I want to conclude with a point that the great team that I'm honored to be associated with in Al-Hasa cluster have published this year 31 articles out of this. So there is a lot of treasure that we can do as a family physician and as a physician and a healthcare system that is available within the primary care that we need to all work on and to reach. And I'll be delighted for any contribution in the future. Thank you. And thank you, Dr.
Thank you very much. We're definitely on the schedule. We're going to reach out to you very soon, Dr. Khalid, to share your expertise along with your team. And I would invite your team to be with you. I'm going to go now to Dr. Khalid Abdul Karim. You mentioned very critical initiative and project about team-based care. And you throw some ideas, but we need to hear more. Like we have a huge community who gonna be your tool to get this plan done. And I wanna make the commitment to the community that I'm gonna reach out to you and your team to make a special event, أمسية خاصة, about the team-based care and how we're gonna, as a community, learn and do it together.
Thank you, Abu Malik. Yes. We are talking about always the transformation. What is tangible? What is the intervention, the single intervention people can feel in the community about the transformation? We believe all in the ministry and even outside the ministry, all levels, that empanelment or registering people with primary care provider is the single intervention that we can add to our healthcare system. Healthcare system become very complex, become very costly. If we don't have this kind of deep relationship, we wouldn't be able actually to do the right intervention. We all, as family physicians, we know how it feels when you have a new patient coming to your clinic with complicated case with multiple diseases. Usually you spend a lot of time, you request a lot of investigations, but this is not going to be the case after third or fourth visits. You will put a certain plan and you'll know what to check, what to evaluate, usually. And usually we achieve a better care on that plan. While if you have the patient is over and over seen by a new family physician, this is not the case. This is not something that we need to do. The concept of primary care should be changed in our mind. I never seen a surgeon who evaluates patient in a clinic and someone else will operate in the OR. Family medicine, it's the same. If you have a plan, you have to stick to it with your patient, and it's a longitudinal. And maybe one of the reasons that we don't feel satisfied, we don't see the effect of our interventions, because every day we see a new patient, we can't feel our input or our intervention and the contribution in their well-being. But if you have a group and you are one of the best providers who's really meeting the targets, preventative before the therapeutic as well, this is going to be really great. Everyone hearing now of the family physicians, if you work in the Ministry of Health, and I know, and Dr. Hadi, you know, that the health sector transformation program are even going to that direction to have the empanelment concept. You have to consider that in future, you will be in charge of a group, and it's better for you as a physician, and you will be equipped with the communication tool. And this is going to be really clear now in the app. If you have already registered with the primary care team, you will be able to book an appointment with them. You'll see their names, the physician, and you'll be able to book virtual or physical clinic. In 2 months from now, this icon will help you to see the entire team, their picture if they want to. You might even book appointment with the nurse if you want to have a vaccine or flu shot, for example. And you will be able to chat with them. You will ask certain questions to your physician, and the physician in a certain time can reply back. It shouldn't be a real time. It's not an emergency tool. It's a question that you can ask your physician and he can reply back. Again, physician can broadcast message to those in his team. Physician can send individual or personal message to his team, not only the physician, even the nurse, anyone having that. Physicians will use Anat, and the community will use Sihhati. You'll be able even to send educational material. You can send some surveys to your team. This is number one. Number two, we will provide data to every team. So as a physician, we'll show you where are you in terms of antibiotic prescription. Where are you in terms of the complexity mix, in terms of your panel that you are in charge of? The system is going to be enhanced as HIS. The command and control center is really evolving very well. That's why I think the practice of family medicine practice will change big time this year. We will feel it and we'll see it in a different way. And this is proof. We are not trying something new. We are not bringing something new. It's been mentioned before, a few years ago, about having family physician for every family. But it wasn't easy to carry it out at that time because we couldn't have the infrastructure and the staff. But right now, we are in a better shape. So I think this is the time now, and it has to be within the transformation. Otherwise, we will miss it. Otherwise, and what I'm really worried about, I'm worried about the family medicine more than the primary care. Why is that? Primary care is area of focus. We have to fix it. There is a mandate. We will fix it. It has to be good. It has to work. But if the family physicians are not putting themselves into this transition with all the challenges, they will lose it, and they can't recover after that. Other specialties might be contributing in that. Some digital tool can contribute in that, and we'll find ourselves not in charge, not the leaders in the primary care. And that's why I want everyone to think always that you have to be in primary care. Don't hide in secondary care or tertiary care facility, unless you are doing a primary care job. But if you feel yourself you are just acting as a triage or a filter, if you feel yourself you are just managing chronic disease, this is not a family medicine practice. And that's why you need always to think where you have to be, even if the setting is not as equipped as the setting that you are in right now, because all of the focus is going to go to the primary care, not to the family medicine clinics. It's going to the primary care. And if the family medicine clinics is positioned very well in the primary care, it will be the most supported discipline in the primary care. Thank you.
Thank you very much, Dr. Khalid. And for the great audience, we will invite Dr. Khalid and his team, Khalid Abdul Karim, to present to us in more detail his plan about the team-based care. And Dr. Khalid, we will not lose it. We are very committed as a community. الأرض أرض وزماني زمانية. It's for us. We will not lose it. يعطيكم العافية.
Sure. We said to win or die in this project. It's the major public health, family medicine, Ministry of Health project right now.
We burn the boat and we shall take the land. It's time forward. Allah يعطيكم العافية. Now it's with a great pleasure and honor to welcome our next expert and leader, Dr. Nahar Al-Azmi, who's the Secretary General of the Saudi Health Council, who's going to wrap to us the primary care strategy from his perspective as in charge of the Saudi Health Council. Dr. Nahar, thank you very much for joining us.
Bismillah ar-Rahman ar-Rahim. Your Excellency Prince Abdulaziz bin Talal Al Saud, Dr. Hadi Al-Anizi, honorable guests, it's my pleasure to participate in this important conference on primary care now and forever. Special thanks to the Saudi Society of Family and Community Medicine for giving me this opportunity to talk about the role of the Saudi Health Council and going through the improvement plan of primary health care generated by the Saudi Health Council. We all know primary healthcare services or primary care as a basic health service for all members of the community and the first level of community contact with the health services. Saudi Health Council, which is the regulatory coordination body in the Saudi system, worked on developing an improvement plan of primary care. Today, I would like to cover this primary healthcare plan and the efforts and initiatives we are working on in the Saudi Health Council. As you know, primary healthcare services are managed and provided today mainly by governmental sectors, especially the Ministry of Health, and in addition to the other governmental sectors. The private sector participate in providing also some role in primary healthcare. In the governmental side, we have 2,227 primary healthcare centers distributed throughout the kingdom, which make more than 40% of healthcare facilities in Saudi Arabia. The improvement plan generated by the Saudi and approved by the Saudi Health Council focus on improving the access to healthcare and focus also in maintaining the health and well-being of the population and working to meet the needs of the population and the citizens of Saudi Arabia. On December 25th, 2019, we held a meeting for the primary healthcare leaders from the different sectors in order to discuss the current situation and the challenges facing the primary healthcare and identify the most important challenges facing the system. Then a national big workshop was also, in fact, organized by the Saudi Health Council in the early 2020. Out of this big workshop, there were a lot of working groups which identified the different themes and areas which we want to prioritize and focus on. We also consider in our planning many studies and data collected in the Saudi Health Council, mainly a big study about the balanced distribution of healthcare services and the public health expenditure review in 2018, and the public health protection program to identify the main challenges and opportunities and the solutions of these challenges. We also emphasize that any initiatives need to be aligned with the big healthcare transformation project and initiatives which are done under the Vision 2030. So there was, some alignments with the Vision 2030 and also the recommendations of the WHO. So we identified 31 initiatives in 5 strategic themes which need to be developed and to meet the improvement model of the primary care in Saudi Arabia. These 5 themes, the first one was governance and funding, which included 3 initiatives, like creating a national entity or a brand for primary care, as this was identified as one of the challenges where the population at some areas don't trust the primary care facilities. The second theme was working to improve the infrastructure and the operations of the primary care. 6 initiatives were identified, like a review of the primary healthcare scope of services and catchment area. The third theme was focusing on curative and preventive services and programs, which included 7 initiatives, like the patient's preferences and developing referral policies and guidelines. The fourth theme was on the workforce, including 4 initiatives, like creating more incentives for the workforce, especially for attracting a workforce to work more in the remote areas and peripheral areas. The 5th pillar was about the role of digital transformation included 11 initiatives like the interactive patient portal and unified electronic medical records and a lot of initiatives. Finally, the Council has approved the National Executive Plan, and one of the major recommendations of this plan was to create a national entity for primary care, so a national committee for primary health care formed of the leaders of primary health care in the different sectors, and also a lot of recommendations like reviewing the scope of services and reviewing also the challenges, especially in the workforce planning in the primary care. Today, we have a lot of efforts and initiatives in different areas. In fact, Ministry of Health is working to improve the primary care services. The same thing happening in the other sectors like the Ministry of Defense Health Services, National Guard Health Services, Ministry of Interior, and the academic healthcare facilities also. In addition to some initiatives also in improving and ensuring the comprehensive coverage by the Council of Health Insurance, where the insurance policy should include the preventative services which can be provided to the citizens and the humans in Saudi Arabia. We are coordinating with the healthcare transformation program and all other services to ensure that all of these efforts are aligned. There is a strong, I would say, commitment and belief that the major success in achieving a real healthcare transformation will be very clear once we have a strong primary care services in Saudi Arabia. I wish you all a successful meeting and conference, and I appreciate again and thank the Saudi Society of Family and Community Medicine for this invitation, and wish you all the best. Wassalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much.
Thank you very much, Dr. Nahar, for a very informative session. Just another announcement. I got lots of questions about the CME. All those who attended live with us or through the YouTube will be getting their CME, so you don't need to worry about your CME as long as you are attending with us. Even if you with the YouTube, since the max capacity for the Zoom is 5K, so all the rest are redirected to the room. Now we're gonna go into a little bit of shifting gears. So we've been speaking all day today about the primary care in general and focusing on the governmental sector. We're gonna reshape again and our thought about the primary care and directing it to the private sector. So we're gonna have another recap of why primary care and the history of primary care in Saudi from an international perspective. It is great pleasure for me to welcome to the stage our international expert, Dr. Muntegat, who is the Associate Professor of Family Medicine at Boston University, and he is the President of the Global Primary Care Consultant, and he is our partner from the American Academy of Family Physician. Welcome to the stage, and we are looking forward for this informative session.
Good afternoon, and thank you for inviting me to participate in this important conference that you are having on primary care. It's such a great pleasure for me to be back with you, colleagues in family medicine, many of you who I've had the pleasure to work with in the past. I'm speaking to you today, and it reminds me of when I was here in Saudi Arabia for the first time in 2007 for the first family medicine Wonka Emro meeting that was held in Jeddah. I am currently an associate professor of family medicine at the Boston University and president of the Global Health Primary Care Consultants, and look forward to spending this time with you sharing my thoughts and then later today in our discussions. Today, my objectives are to describe to you health systems around the globe that are evolving beyond basic primary care. And I'd like to talk about how they're moving towards enhanced primary care models, such as yours. I'll give you some examples from some models from other countries around the globe. One in particular, the patient-centered medical home. I'll then describe how some of these concepts can apply to your situation in Saudi Arabia. And finally, I'll describe how the enhanced primary care intervention of the model of care is now moving forward through pilot programs in the kingdom. So why is primary care evolving from its basic level that we all know about from Alma-Ata and then Astana and how we practice in our countries? And why is it evolving to new enhanced models? Well, there are many challenges that health systems around the globe are facing. Some of them include rising healthcare costs, which are now rampant. There's great variability in the way medicine is practiced around the world, across regions, within cities, and even within the same organizations. And this leads to variability in quality and safety. There are continued problems with access to primary care, shortages of doctors and staff, and we're seeing shifts in the population demographics and disease prevalence. All of these problems continue to evolve, and from them are coming experiments in healthcare to test new models with some perhaps promising solutions. Some of these tests include ACOs or clusters, as you now are using. And some of them include elements of enhanced primary care. Now, there are challenges that we are also seeing in the changes to a new paradigm in healthcare. We're moving from treating sickness and episodic problems to managing populations. We are moving from fragmented care to collaborative care. Specialty-driven care now to enhancing primary care, isolated paper files to very advanced integrated electronic records. Organizations are moving from managing utilization to evidence-based medicine. And also, quite importantly, there are many changes in payment systems that include movement from fee-for-service to shared risk and reward, and from patient payment for volume to payment for value. So all of these, of course, now are leading to so many countries and organizations rethinking the move from basic primary care to enhanced primary care. And so I'd like to share with you some examples of enhanced primary care. And what I've done is selected 5 countries in addition to Saudi Arabia to describe these interventions. I've chosen Vietnam, which is a low to middle income country, which has good healthcare outcomes. Brazil, middle income country with good healthcare outcomes. And then Canada, the UK, and the US. And then we'll spend a little bit more time on Saudi Arabia. Now, Vietnam's healthcare system, as it currently functions, was established in the 1950s. It's a tiered health system with universal health care across these tiers, from primary care in the commune health stations to tertiary care in the large medical centers. And I've spent a fair amount of my career, over 20 years, working with the Vietnamese in developing their primary care and family medicine programs. There are 11,000 commune health centers in Vietnam, And their focus is on immunizations, epidemic prevention, maternal and child health, and the treatment of common health problems. There is a perception of low quality by people, and so they bypass these primary care centers and move to hospitals and secondary care where they encounter a significant amount of overcrowding. Well, as a response to the low quality, in 2000, family medicine was established as a specialty. By 2008, all 12 medical universities were training family physicians. And currently, there are 11 per 100,000 general doctors, so for all the commune health centers, but only 2 per 100,000 family doctors. And family medicine is now also moving into private practices in the urban areas. So there's been a slow response to developing more family doctors. And to that end, in 2015, the Ministry of Health created the Health Professions Education and Training Project. And the goal of this project was to develop education and training programs to retrain the general doctors to eventually grandfather as family medicine specialists. This also was put to improve the quality of care and to create teams by encouraging more staffing of the CHCs with doctors, public health specialists, nurses, and midwives, and to try to improve the competencies of these primary health care teams for their function in the commune health station. Now, the challenges still exist that patients' and attitudes and knowledge of family medicine is still low, and this program is trying to increase awareness. Providers still have a large burden of administrative work, and they still lack training opportunities. But this program is moving forward and is beginning to see some successes. In Brazil, in 1989, the government created primary health units, a network called Sistema Único de Saúde. These public primary care units provide universal health. Family medicine training was established in 1994. Family physicians there are called clinic doctors, and working in the primary health units, there's one family physician for approximately 4,000 patients. They address acute and some chronic care. Education plays a very important role in the primary health units, where the doctors and staff there train undergraduates and residents. Currently, there are 2.64 family physicians per 100,000 people. In 1994, the Brazilian government created the Family Health Strategy. And this program was to provide integrated primary care. The aims were to provide preventive and basic health care, developing multidisciplinary professional teams, including physician, nurse, and community health workers. The successes have shown that more preventive health is being practiced. There are significantly increased vaccination rates, increase in cervical cancer screening, more health education, and more registration of school children with health needs for monitoring. The challenges remain of too few family doctors, which leads to ongoing limited access. The care remains more for acute than chronic problems, and there are long waiting times for secondary care. Emergency services remain overwhelmed. In Canada, as we know, the health system is delivered through the provincial and territorial system of a publicly funded healthcare network. It is guided by the provisions of the Canada Health Act of 1984, which decreed universal health care. Family medicine was established in 1966, and in 2004, the government established a goal for 2011 that 50% of Canadians would have access 24/7 to multidisciplinary primary healthcare teams. Currently, There are 115 family physicians per 100 patients in Canada. And the role of the family physician is really mainly oriented towards universal clinical skills, comprehensive healthcare and community health, and the family doctors serve as gatekeepers for access to secondary care. In 2009, to enhance primary care, the College of Family Physicians introduced the patient medical home. Now, the vision for the patient medical home is to provide Canadian practices a shared PMH framework. It presents a set of indicators with which family practices can be monitored and evaluated. There are 5 principles to the PMH: accessible care, patient and family partnered care, continuity of care, comprehensive care through the primary health care teams led by family physicians, and community adaptiveness. As well, this model specifically calls for quality improvement and training and education. The successes are strong, focused, team-based care, again led by family doctors, improved education, and improved use of electronic health records and interconnectedness across the system. Challenges remained with access issues, too few primary care doctors, and only modest gains in quality improvement. In the UK, as we all know, the National Health Service began on July 5th, 1948. The RCGP was established in 1952, and in 1974, mandatory vocational training for GPs was established. In 2009, the RCGP published a document called Transforming Community Service, one of whose principles was to create large polyclinic centers and hub and spoke networks with central facilities to be used by local practices. In more recent years, there's been the establishment of more group practices and networks. In 2015, the RCGP launched the Primary Care Home. Now, there are 4 key characteristics that make a primary care home. The first is an integrated workforce with a strong focus on partnerships spanning primary, secondary, and social care. The second is a combined focus on personalization of care with improvements in population health outcomes. The third is aligning clinical and financial drivers, and the last is provision of care to define registered populations. Currently, there are 60 GPs per 100,000 people. The successes of this program have been enhanced patient satisfaction, some improvement in quality of care, and increased access to services. The challenges are patients feel that they've lost the choice of choosing their GPs. And although there is improvement in quality, there is still variation in quality of care. And many of the clinic doctors continue to manage their decisions reactively rather than proactively, which means that there are few incentives to promote earlier management of some health conditions. The physician shortage remains, and this currently puts a strain on this medical home system. Let me mention briefly the United States. So in the US, healthcare payment is based on an employer-based insurance program, which was initiated in the 1950s. In 1965, a public program for the elderly, the poor, and the disabled was added. And in 2008, a plan to provide healthcare coverage to the uninsured. Currently in the United States, about 8% of people are still uninsured. In the US, care is organized primarily around large private groups and hospital-owned groups. Family medicine became a specialty in 1969. There are currently 27 family physicians per 100,000 people. Now, in the US, primary care is defined not just as including family physicians, but also pediatricians, geriatricians, internal medicine doctors, and obstetrics and gynecology doctors. And so taking all of these physicians into account, the ratio of primary care doctors is 156 per 100,000. In 2007, these specialty organizations providing primary care came together to adopt the joint principles of the patient-centered medical home with 5 principles. I'd like to spend a little bit of time talking about the patient-centered medical home. There are many similarities of the patient-centered medical home in the US to what we explored in the UK and Canada. The patient-centered medical home approaches primary care with 5 principles. The first is patient-centered care, and that's defined as supporting patients and families to manage and organize their care and participate as fully informed partners in health system transformation at the practice, community, and policy levels. Some strategies that are used are to dedicate staff to navigate the system, create care plans. They are called patient navigators or family health coordinators. Other strategies are to focus on developing strong and trusting relationships between physicians, care teams, and patients with open communication about decisions, health status. Some impacts are that patients are more likely to seek the right care in the right place and at the right time. The next principle is comprehensive care. This is defined as a team of care providers who are wholly accountable for patients' physical and mental health care needs. It includes prevention and wellness, acute care, and chronic care. Some strategies used in comprehensive care are that the care team focuses on the whole person and population health. Primary care could locate and should locate with behavioral medicine, oral health, vision health, maternal and child health, and pharmacy. Special attention is paid to chronic diseases and complex patients. Some of the impacts of practicing comprehensive care include that patients are less likely to seek care from the emergency room or hospital or to delay or leave conditions untreated. The next principle is coordinated care. Coordinated care ensures care is organized across all elements of broader healthcare systems, including specialty care, hospitals, home health care, community services, and public health. Some strategies are that care is documented and communicated effectively across providers and institutions, including patients, their primary care providers, specialists, hospitals, and the communication and connectiveness is enhanced by high-performing health information technology. Some of the impacts are that providers across the network of care are less likely to order duplicate tests, labs, or procedures. The next principle is accessible care. This is defined as delivering consumer-friendly services with shorter waiting times, extended hours, 24/7 electronic or telephone access, and strong communication through health IT innovations. And certainly through the last 20 months of the pandemic, we've seen great advances in accessibility through high IT innovations. Some strategies include appointment systems that can be efficient to offer same-day or 24/7 access to the care teams. The use of e-communications and telemedicines as alternates to face-to-face visits. Some of the impacts are focuses on well and prevention, reducing incidence and severity of chronic diseases and illnesses. Finally, the last principle of the patient-centered medical home is quality and safety. Now, the definition is that this demonstrates commitment to quality improvement through the use of health IT and other tools to ensure patients and families make informed decisions. Sample strategies include the use of electronic health records, clinical decision support, medication management to improve treatment and diagnoses, establishing quality improvement goals and using data to monitor and report. Potential impacts are lower use of emergency rooms and avoidable hospital tests and procedures and more appropriate use of medicines. Underlying all of these tenets for a successful delivery model must be health information systems that not only support but guide the practices within themselves and into the broader healthcare delivery system. Studies of the patient-centered medical home have shown several outcomes. The first is that cost can be reduced in overall medical expense. Utilization shows fewer emergency room and hospital visits. Access seems to be significantly improved for patients. There seems to be an improvement in health through process measures and outcomes, better results in diabetic control, higher rates of cholesterol management. And patients quite often report a higher satisfaction when engaged in a patient-centered medical home. Preventive health measures are improved, with, in some studies, 95% participation in annual physicals and preventive screening visits and diagnosing of conditions. Behavioral health management is better. There's a decrease in emergency room use and decrease in hospital admissions. But I really must be clear that health systems that adopt this model still have many challenges. There's still lack of access to health care, often due to shortages of primary care physicians and nurses. In the US, there's still lack of universal coverage. High cost of care continues, although in some recent studies beginning to show some trends down. There remain inefficiencies in systems of care, in particular when the systems are large networks of healthcare. Now, I've described what we can call supply-side reforms. That is, delivery reforms of the supply of healthcare services. Now, there are also demand-side reforms. These are reforms that will change how consumers and employers select and purchase healthcare services and or insurance. Now, if a payment system has a very basic or crude cost-sharing mechanism, or if it maintains third-party financing, or if it continues to provide very strong financial and social rewards to doctors and medical institutions, such as unrestricted choice of doctors, hospitals, and medical systems by patients, or the unrestricted use of technology, or sometimes the use of heroic yet not evidence-based treatments, this can make difficult times in reforms. So how can we motivate consumers to actively seek out the expertise embodied in a well-functioning, patient-centered medical home if there are no incentives? If there's no consumer outcry or demand for better, stronger primary care on the demand side, then the supply side has no reason to change. This is what is being explored through value-based purchasing and value-based insurance designs. These demand-side reforms incentivize consumers to use higher value services and instills competition for these services, and they discourage the use of lower value and non-evidence-based services. It really becomes quite clear that any changes in health systems need significant engagement by the population, and that the population can really drive the move to these enhancements and reforms, such as ACOs or clusters or patient-centered medical homes or high-value networks. Well, I'd now like to turn our focus to your country And although much of what I'm going to share with you initially is quite familiar with you, I think it's worth a review. Now, in 1926 is really when the healthcare delivery system was initiated in the Kingdom of Saudi Arabia. Not that any of you here would remember that. But there was the establishment of the Health Directorate in Jeddah and the opening of the Ajiad Hospital in Mecca and the Bab Sharif Hospital in Jeddah. In 1970, there were 74 hospitals in the kingdom. In 1971, the government began developing a succession of 5-year national health plans. In 1978, following Alma-Ata, the government developed a concept of the 3-tiered healthcare system in which community-based primary healthcare would serve as a vehicle to achieve universal access for all people. Through the 1980s and 1990s, there was a major expansion of your healthcare system with a large number of hospitals and primary healthcare centers built. And the Ministry of Health began to orient more towards primary healthcare-based services. And in 2019, there were 500 hospitals and a little over 2,300 primary healthcare centers. Family medicine started in the 1980s in the military hospital in Riyadh. 1981, the fellowship program in family medicine was started. In 1995, the Saudi Board of Family Medicine created under the umbrella of the Saudi Commission for Health Specialties. And in 2008, the Saudi Diploma of Family Medicine was started and then upgraded in 2014. In 2007, something extraordinary happened. Under the guidance of the Minister of Health then, His Excellency, Dr. Hamad bin Abdullah Al Maini, a new look at primary care was initiated. The Vice Minister of Health, Dr. Obaid Al Obaid, made a statement that the Ministry of Health wanted to increase its number of family doctors to 13,000 to work in the primary healthcare centers. And the kingdom was planning to soon have over 2,000 primary healthcare centers. In order to better understand the situation then in the kingdom of both primary care and family medicine, His Excellency the Minister Al Maini asked the Vice Minister to commission a study in the kingdom. So in 2008, Professor Nabil Al-Qurashi, the then founding president of the Emro region of WACA, working through the Arab Development Institute and what was then Dammam University and is now the IADU, engaged the Boston University and what was then the Global Health Primary Care Initiative to participate in the needs assessment. I was very fortunate to be the person from Boston University to work with Professor Al-Qurashi in this needs assessment, leading our 2 teams. The outcomes of the needs assessment, as reported directly to the Minister of Health, included that the kingdom had a well-established network of primary healthcare centers. There were a large number of GPs in the primary healthcare centers, no primary healthcare teams. People perceived low quality in the centers, and in urban areas, many people chose to go to specialty care first. There was an inadequate number of family physicians. There were few family medicine training sites and few trainers, no accredited centers for training of trainers. However, there was great support by the Saudi Commission for Reform and support from the Saudi Council and the Saudi Society of Family Medicine for Reform. Now, at the time of the study, the population in the kingdom was 24 million. There were 500 family medicine consultants. And that study team used a formula of 1 family physician per 2,000 people to project an actual need in 2008 of 12,000 family physicians. The study projected the population to be 37 million in 2023 and a need of 18,500 family physicians at that time. The study group went on to make some recommendations to the minister and reported to him directly on 3 potential projects to include access and to improve quality. These included the first, to fill the need for more trainers for family medicine, the creation of faculty development centers and joint training programs, initially with international partners. The second, to begin the longer-term production of family physicians, the creation of family medicine training centers in the primary healthcare centers, networked together with hub and spokes with more central hospitals and universities and the faculty development centers. And lastly, to rapidly expand the number of family physicians would be to develop an on-the-job retraining for the many GPs working in the primary healthcare centers. Now, since 2008, some changes were made. There has been a modest increase in the number of graduates from universities, and there was the creation of the training academies. And in fact, your colleague and friend, Professor Adnan Al-Abar, was very instrumental in some of these changes. But now, 13 years later, of course, some of the same challenges remain in primary care. And you're quite aware of these challenges, and it's these challenges that are driving the changes that you are all talking about today. I reviewed several studies performed by your professors and your universities in 3 areas of challenges: workforce, facilities, and patient experience. One study said that family medicine is the most needed specialty in Saudi Arabia and estimated that the current need is about 15,000 family physicians. So actually not all that far from the need that was recommended in 2008. Family physicians represent less than 28% of the total physician workforce at the primary healthcare level. And the study recommended that there would needed to be more emphasis at all levels of family medicine in order to obtain an appropriate workforce. I examined the Saudi Balanced Distribution Survey of healthcare facilities, and this determined that there is a large capacity in terms of the primary healthcare facilities. Distribution of the health centers is an issue, especially when it comes to the distribution of health workers. There's great variation in services, workers, various measures of infrastructure, and drug availability. The capacity of primary healthcare centers does not meet the demand of the population now, and particularly when the increased demand as brought by the health system reforms relating to the new model of care. In reviewing studies on patient experience, there are several points made by patients. One is they felt that there was an inadequate interaction between primary, secondary, and tertiary healthcare services, low quality of physician-patient communication, and they felt that there was an inadequate provision of information about test results, diagnoses, and treatments. So, of course, to meet these challenges, it was the National Transformation Project, which was stood up by the Ministry of Health as part of Vision 2030. And through that, the great work done on developing the new model of care and the creation of the enhanced primary care program. When we study the enhanced primary care intervention, we find many similarities to the other enhanced primary care models around the globe. For example, the service design principles include population needs-based care, integration with the whole system and network, adherence to national practice guidelines, multidisciplinary approach to healthcare, and that the system be designed to rebuild trust from patients, and that it be outcomes focused. The required capabilities must include multidisciplinary teams. Enhancing and improving the workforce is important. Enhanced IT capabilities and the design of a quality infrastructure. This must be measured by improvements in service quality, patient trust, and workforce enhancements. Next, let's talk about the implementation of the Enhanced Primary Care Program, because it has finally gone from study to development, now to implementation. Now, there are three groups that have been given the opportunity to roll out pilot projects. The Suleiman Habib Group, the Nasser Group, and a partnership between Health Power Medical and Ascend Healthcare Solutions. This last partnership was created specifically for this project. Together, they created a work plan and project plan and a work team assigned to the project. Now, this project, these pilots, are to run over 2 years and in 3 phases. And so I want to describe for you the early work being performed by the Health Power Ascend team. And this is just one example of the pilots that are now functioning. First, let me tell you about Health Power Medical. This organization is a medical company. It is owned and operated by Saudi family doctors. The company was started in 2016, and it spent the first 2 years networking with many family doctors, health organizations, and the Ministry of Health to determine what was needed in the kingdom. Out of that came the strategy and the goals of the company. The company then spent the year of 2019 developing its model of care, which they have called the Health Power Medical Care Model. And this is based on the international principles that we reviewed on medical home concepts, as well as incorporating the principles of the enhanced primary care intervention. In 2020, Health Power launched a family medicine center in Riyadh, and in 2022 in Khobar. Both of these sites were launched as pilots and to determine proof of concept of the Health Power Care model. At the end of 2020, the partnership of Health Power and Ascend were assigned the Al Azhari Primary Healthcare Center in Medina and a primary healthcare center in Abha to launch their pilot programs. In May of 2021, Health Power and Ascend received the handoff for the Al Azhari Primary Healthcare Center in Medina. The team started with phase 1, the needs assessment and gap analysis. This process took 3 months, and it included a significant Health Power team on the ground, an Ascend team on the ground, and a UK team working virtually as consultants. The phase included a complete technical due diligence of the primary healthcare center and a full portfolio analysis of the site that included but wasn't limited to the facility, the staff, doctors, policies and procedures, and technology. Following these activities, the team prepared a comprehensive commissioning and service design. And once this was completed, it was presented to the Ministry of Health at the end of August. In October, after having received feedback from the Ministry of Health, Health Power, as the operator of the primary healthcare center, was given permission to begin phase 2, the implementation. This phase is designed to take 3 months, and Health Power has a designated team assigned in Medina. And this team includes a project manager, an operations manager who will work intimately with the primary healthcare center administrator and the staff, a medical director who will work principally with the doctors, and a Lean Six Sigma Black Belt improvement specialist who will work with the entire center. The goal of the implementation is to roll out the care model as it incorporates the patient-centered medical home and the enhanced primary care intervention. This implementation of 3 months will include several activities, and let me just review those with you briefly. The first activity is to improve the facilities. Now, of course, there are several reasons to improve facilities. You want to improve the look and feel for patients to make the facility more modern, more comfortable for patients, and this will lead to a better patient experience. The improvement of a facility needs to provide an efficient layout for workflow optimization and to bring the health center into SBAHI compliance. In phase 1, the team assessed the facility, and the facility assessment team included engineers and architects from Ascend and Health Power. There were many deficiencies that were found. Some were cosmetic, but some were functional, and some were actually much needed for improvement to meet SBAHI compliance. So the team made recommendations and made designs and submitted these to the Ministry of Health for 2-stage improvement. The first stage was for minor changes to enhance the look and feel and to improve the layout for workflows, providing enough examination rooms for the doctors and the healthcare teams to take care of the patient population and to provide training space. Phase 2 of the improvements would include significant changes that would transform the health center into a modern facility that is expected by patients and needed for the practice of enhanced primary care. These 2 stages of recommendations are still being reviewed by the Ministry of Health. But this has not stopped the team from moving forward. The team is on site and is working with the next activity of workforce enhancement. This is the development of the primary healthcare team. Studies have shown that when a care is delivered by a team, that there will be reduced clinical errors, improved patient outcomes, improved process outcomes, increased patient satisfaction and staff satisfaction, reduced staff turnover, and reduced patient and family grievances and complaints. So the current staff was evaluated during phase 1. They were all given the new job descriptions, and these were reviewed with them. And the teams are now being formed. The teams will include a doctor, nurse, family health coordinator, population health nurse, behavioral medicine specialist, receptionist, dentist, and dietitian. The optimal team, as conceived for the Health Power Care model, is a family medicine consultant, 2 GPs, 3 nurses, 1 or 2 family health coordinators, a population health nurse, receptionist, and then the behavioral medicine specialists, dentists, dietitians to be used across the entire practice. Now, the family health coordinator is a new position that was created, and it's very important. This is the role that will help coordinate the care of the patients within their care teams as well as across the system of care. So there has to be significant training when you redesign healthcare and jobs. The staff need to be trained that they will move from a single focus of healthcare to working in a dual focus of clinical and team skills. They will move from just individual performance to team performance, from under-informed decision-making to informed decision-making. They will need to have a clear understanding of teamwork, how to manage a workload, how to share information, and working from a place of self-advocacy to mutual support. Team efficiency is a very key indicator. The next action is providing access to patients. Now, this is a critical activity because this is what will bring patients to the primary healthcare center. The key is to establish the patients with a family doctor and the healthcare team to provide continuity of care. The catchment area for the Al-Azhari Primary Healthcare Center is 20,500 patients. Currently, there are 8,500 patients who are registered. And at this time, these registered patients are being assigned to specific doctors and teams and being invited to come to the primary healthcare center to meet their teams and to begin to establish their personalized care. The teams are being trained on improving access and how to improve patient experience. The next action is standardizing the care. Across all industries, organizations of every size try to deliver a consistent consumer experience. For healthcare systems, that means providing the same care quality and experience for all patients and employees, that all areas of the organizations are working towards the same goals, and that there is consistency of processes, protocols, and outcomes throughout the organization. For healthcare leaders looking for competitive advantage, and this must be the case in the primary healthcare systems because they are competing with the private sector for patients, the leaders must have standardization to represent efficiencies, standardization to help decrease variation, which will increase quality and safety. And from the healthcare manager's perspective, standardization will foster an environment of quality patient care. However, we have to note that you cannot improve what you do not measure. And that is why the team has a Lean Six Sigma Black Belt assigned to this project at the site in Medina. This specialist will lead the improvement activities in the health center, and these will include the development of metrics, both organizational and quality, the use of metrics and measurement display boards, and rapid cycle events with team huddles. Continuous improvement is a major key to success. As well as standardizing the organization, standardizing of care and measuring outcomes is very important. So the team will implement the use of practice guidelines. Protocols and checklists have been shown to reduce patient harm through improved standardization and communication. And since 1994, after the publication of the Checklist Manifesto by a Boston surgeon, which he wrote because in operating rooms there was no standardization and many errors were being made. So by implementing checklists and guidelines, he was able to improve the outcomes of the surgeries. And so now checklists and guidelines have become an important part of high quality of care. It's important to know that combining the standardized practices with personalized treatment plans is important, because this is what will lead to informed discussion and decision-making. Checklists and protocols should be incorporated into the systems of care, in particular into the electronic health records. By embedding these checklists, protocols, and practice guidelines in the electronic health records, it will help the practitioners to provide the best evidence-based care to their patients in real time at the point of care. With data as the common denominator, healthcare can get to a place where standardized care and personalized care can meet. And this is really the best of both worlds. In addition to standardizing the actual healthcare, there needs to be standardization of the operations. And so setting up standard workflows is quite important. An increasing number of studies show that when patterns of care are widely divergent, clinical outcomes suffer. And as a result, as we have heard, safety and reliability may be compromised. Standardization of workflows may help to increase the uniformity of the practice, increase safety, and improve the patient experience. Now, HealthPower has developed workflows and used them in their prototype clinics. And again, these workflows were embedded in the electronic health record. These are now standardized and have been tested, and these are the workflows that will be rolled out in the Al-Azhari Center. This process will also take significant engagement and training of the staff. The purpose of healthcare policies and procedures is to communicate to employees the desired outcomes of the organization. They help employees understand their roles and responsibilities within the organization. Another purpose is to provide uniform policies for all employees so that there are no discrepancies. During phase 1, the assessment team reviewed all of the policies and procedures at the health center and the Sabahi standards. The team reviewed the last Sabahi accreditation site visit at Al-Azhari and found that the center only received provisional accreditation, which is now overdue. So the phase 2 work will be to implement policies and procedures that are current with international standards and used in the Sabahi standards. This will also take tremendous effort in training of staff and doctors, but the goal is for the health center to achieve full Sabahi accreditation in the final phase. Population health is an important part of any of the work for any primary healthcare center. Its aims are to improve the healthcare of specific groups and to reduce health disparities among populations. Population health studies in communities lead to the provision of improved access to care. A focus on population health also promotes better patient engagement. By meeting patients in the community and focusing on the community and population needs, we can expect to see patients feeling empowered so that they can better manage their own health. For this project, HealthPower brought in a population and community health specialist onto the team, and in phase 1, he did a community assessment. Following the assessment, he developed programs to be rolled out in the community. And these programs include population health diagnosis, family and patient support groups, community empowerment, and health school programs. Finally, health information technology. And this is the backbone for any successful health delivery system, and of course, for the success of any primary care project. The technology, of course, is used to move data and to connect patients to their providers and those providers to other providers of care within the local health system. Now, this is a particular challenge in this project. The due diligence team made a very close examination of the LLM system now in use in the Al-Azhari Primary Healthcare Center. It found it to be usable, but not designed at all for the elements of the enhanced primary care intervention or of the HealthPower care model. In fact, patients, physicians, staff need to use multiple systems to complete the full cycle of engagement and care. Now, HealthPower has worked for 3 years with a health IT system that is fully integrated to provide a patient portal, appointment scheduling, the electronic health record that has the embedded guidelines and workflows, e-prescribing and telemedicine, as well as a fully integrated and fully functioning patient-facing app. This system is called System 1, and it was designed and is supported by an organization called TPP UK. Now, some of you may be familiar with System 1 as it has been deployed in several primary healthcare centers in the kingdom. It is currently in use by 80% of the UK general practices and hospitals and is also deployed in other countries. TPP has established interfaces with other healthcare organizations linked to the System 1 system used in the Health Power clinics. A full head-to-head comparison was made between System 1 and the L-ELM system and was included in the due diligence report to the Ministry of Health. The assessment team requested that Health Power be allowed to use TPP System 1 in the pilot sites. Now, this is still under consideration by the Ministry of Health. So in the meantime, Health Power is working with the L-ELM system to help with enhancements to make it more usable for the enhanced primary care intervention. Phase 3 will be the phase for sustainability and measurement. This should be starting in late winter or early spring. Phase 3 is to be used to sustain the interventions made in the primary healthcare center, to provide continual improvement and rapid cycle improvements and continued measurement on which to make the improvements, and to allow integration of the primary healthcare system with the local health system. This phase will last for 18 months. The goal for the Ministry of Health for the new model of care is to move from a health system that can be chaotic and confusing for patients, a system that currently has not been delivering high quality of care or a good patient experience. The Ministry of Health wants to move to a system that is focused on the patient and the family and rooted in a strong base of primary care through family medicine. The enhanced primary care pilots are moving forward. And as the projects are moving forward, they're beginning to engage patients, doctors, and staff in the transformation to develop and improve the workforce. Over the next 2 years, these projects will begin to demonstrate early improvement in the quality of service and hopefully the quality of the medical care and some outcomes. These pilots will demonstrate that through these projects, the patients will have an enhanced patient experience. The fundamentals for the enhanced primary care project are now in place, and they're beginning to regain the patient trust. These pilots will demonstrate that in a new model of care, the enhanced primary care intervention can be successful in Saudi Arabia. I want to thank you again for inviting me to participate in this conference. I appreciate your attention to this online presentation, but I look forward to meeting you in person live at the end of the conference, in which we can engage in a discussion about the future of primary care in your country. So please formulate your questions, and myself and Dr. Haq will look forward to seeing you later today. Once again, thank you, and it's such a pleasure to be here with you today.
Thank you very much, Dr. Montague, for an excellent overview of one experience, the Powergate, through trying to establish a primary healthcare in partnership with between private and public. Now we're gonna look for another experience about running primary healthcare service at the private sector from the Healthgate. Gonna present it to us by their Chief Medical Officer, Dr. Haneen Al-Awaini. Dr. Haneen, thank you for joining us, and we'd love to hear your experience in Healthgate through establishing primary care in the private sector. Floor is yours.
Good afternoon. Thank you, Dr. Hadi, for this introduction. I'd like to thank all the organizing committee for this beautiful conference and their beautiful organization. Thank you again for this opportunity. I'm very honored to be sharing our experience as a private primary healthcare. Now, as a private provider, we have our own set of challenges. However, we share a lot with the public sector as well. We share our seek to provide quality healthcare to our patients. Health, as defined by the World Health Organization, as I'm sure all of you know, is a state of complete physical, mental, and social well-being, and not merely the absence of disease. This comprehensive definition, along with several statistics confirming that a lot of our patients, around a third of our patients presenting with physical complaints, have an underlying behavioral or mental disorder, has led Healthgate to make it part of its strategy since day one to include a unique biopsychosocial approach and a holistic patient care. Our integrated primary care is patient-centered. It is led with medical services provided mainly by family physicians, primary pediatrician, primary OBGYN, an urgent care unit to care for walk-in patients and urgent conditions, and an ENT clinic. You might think that ENT is not usually part of primary care. However, due to auditory testing being part of school checkups and the need from the pediatrician and the pediatric psychology for auditory testing as part of assessment for we elected to provide private outpatient ENT services within our primary care. As I said, we focus on medical and other parts, including the mental part or mental care for patients. So our mental health department includes psychiatry, adult and pediatric psychology, and lifestyle medicine clinic. We also have dietary consultations and dental services. This medical team providing medical, mental, dietary, and dental services is completed with the work of our supporting departments, starting with the patient experience officers who receive patients at entry point and help with registration and appointment and direct communication with the patients. Nursing, of course, the hidden soldiers in every health institute. The laboratory department, providing also COVID PCR testing. Our radiology department, including ultrasound and X-ray, and also screening mammography. Now, although the definition of health includes a holistic approach and the statistics show the importance of integrating the mental services, we also depended on several research showing and confirming that integrating mental and behavioral health services within a primary health care setting can increase patient satisfaction. Studies also show that with the known mental health stigma, patients reported that it is more convenient and more accessible to go to a mental health clinic if it is available in a primary healthcare setting. This point specifically had been a part of our consideration, even our design in the center. As you can see, the door of each clinic does not have any big sign that declaring what type of clinic this is. There is only a small symbol of a stethoscope, a brain, and a tooth to make it more convenient for our patients. Studies also show that patients prefer that their primary provider have direct communication and coordination with their mental health provider. As a lot of speakers has already mentioned about the importance of accessibility for the primary healthcare services, we make sure that not only our center is accessible to patients, but also our doctors. Patients can call during all working hours to talk to their primary care provider directly. We also have almost agreements with all insurance companies to be able to serve all insured patients. We strive to increase accessibility to certain services as well. We had a healthy diet initiative last year where we provided free dietary consultations for patients who needed dietary consultation but could not afford it. Also, in an effort to increase accessibility to mental health, we offer a free of charge introductory session with mental health providers, where the primary healthcare provider can introduce the patient to the mental health provider in the clinic, so they can meet, and the mental health provider can explain the type of services he can provide and how he can help for the patient's well-being. This model is described in some of the literature as a warm handoff. Of course, continuity of care is an important part of primary care, as a state of health cannot be reached or maintained with one encounter. Continuity of care is important KPI for us. We ask all our providers to call patient next day by phone to make sure the patient is improving, there are no side effects of the medication, and there are no unleft and unanswered questions. We are improving and finalizing our telehealth platform for patients' convenience and to ensure and encourage follow-up. It is currently available for the mental health services, and soon it will expand to cover other services as well. Continuity of care includes even after patients get out of the primary care, referral to secondary care is part of continuity. We follow up our referrals and our feedback process as well. Our team take care of all the paperwork, referring and getting the feedback, reports, lab results, a plan, so the patient does not have to worry about any of the referral process, and his care can be returned and continued with his primary provider after discharge from the hospital. We have developed our electronic system to facilitate and support this approach. So our system has a built-in psychosocial assessment. There is one page of a collective record of all management plans developed by all of the providers. So, for example, as a family physician, I can read within one page the plan developed for my patient from the dietitian, from the dentist, and from the mental health provider. I can easily access my plan from last visit to build and continue care as smoothly as possible. There is a built-in chat within the system, so providers can communicate directly and easily without having to wait a free chance between appointments, so patient care do not have to be delayed. The system also allows us to set reminders to follow up. For example, I can set a reminder to call my patient, my diabetic patient, in 3 months to ask him to come back to repeat his A1C testing, or in 1 year to repeat his annual assessment, or within 1 week to check up on an acute matter. As a primary healthcare, we see ourselves as a part of the community, and we take our social responsibility seriously. For example, within the last 2 years, we have worked with Zahra Association to support breast cancer screening. We offered free screening last year during the month of October. This year, we provided discounted screening for breast cancer for the month of October, November, and December. Also, in celebration of the World Mental Health Day and the month of October, we hosted a free live stream on YouTube where our psychiatrist, Dr. Tariq, interviewed a breast cancer survivor to talk about mental health and its role in the cancer journey. Starting from our commitment to help our patients to improve and maintain their health, and understanding the strong social fabric that creates our community and culture and affects almost all aspects of our lives, we are working now on a new exciting project, which is the Family File. The idea is, since family members share a lot of their behaviors and genetic risk factors, approaching and treating the family as a unit would provide positive outcome. So because healthy families build a healthy community, we offer this 1-hour comprehensive assessment free of charge. The process starts by creating a shared file for the family members, of course, without disregarding the individual file, booking appointments with a case manager and a family physician. During the appointment with the case manager will get to know the family, and help the head of the family, whether the mother or the father, to fill health surveys about each member of the family. After that, the head of the family will have a comprehensive assessment by the family physician, and together they will share a plan for the family's health, set goals, and continue monitoring and follow up. This assessment can be repeated as needed based on the family's needs. Elements of the comprehensive assessment include documenting consanguinity, family cycle stage, significant inherited diseases, family dynamics and social profile, and assessment of each member of the family based on the previously filled health surveys to include any chronic diseases, adherence to age and gender recommended screening and supplements. For example, during an early pilot for this family file process, we found a family with several members with iron deficiency anemia. And during the family dynamics and social profile assessment, we found out that the mother has an underlying psychological problems. And based on that, we have prepared an intervention to treat and prevent recurrence for this simple problem. We take good care of details because we understand how much it can affect the patient's experience. The real life experience of our patients start from an easy parking, where we have more than 70 parking spaces, to a naturally lit reception area, then to be escorted by the nurse to the vital signs room, and the nurse will continue to escort the patient throughout the facility until the patient is discharged, to the clinic, where the patient can sit next to his provider with no barriers and spend minimum 15 minutes of quality time. Patients can choose to leave their children in the playroom while they get their appointments and procedures done. The dental clinic, where patients can have a beautiful view and see the color of their teeth in natural light due to the skylight. I don't know about you, but the first time I heard about this concept, it felt a little bit too good to be true. But after working and seeing this on the ground, I can assure you it is available and it is true. And numbers also support this. During the last quarter, for example, we saw over 3,000 patients. If we took these patients as an example, the average cost per visit, including diagnostic services, was about 254 Saudi riyals. Referral to secondary care for these patients did not exceed 1.7%. Of course, as I said in the beginning of my talk, life is not always rainbows and butterflies. We do have some challenges. Unfortunately, patients do not share our definition of health. They do believe that health is the absence of disease. So the low level of patient awareness is a challenge, especially when trying to explain the concept of family medicine and the importance of preventive care, checkups, and screening. And with the lack of any sort of gatekeeping strategy or concept, patients elect to go to secondary care instead of the primary care. Another challenge is the payers. Unfortunately, majority of payers do not cover a holistic care plan. They do not cover a mental health assessment. They do not cover dietary consultations. They do not cover any type of preventive services and screening. Another challenge is the availability of qualified healthcare providers, especially family physicians, psychiatrists, and psychologists. However, regardless of all these challenges, we'll work hard to continue to provide comprehensive, integrated, accessible, and continuous care for our patients, because we believe that healthcare is not a privilege. Healthcare is a human right. Thank you so much for your time, and I'm available to answer any more questions.
Thank you very much, Dr. Haneen. My question to you, you got a mix of practitioners, family physician, internist, pediatrician. how would you distribute patient among all these different providers?
Yes, excellent question, Dr. Hadi. Thank you. Usually, based on the availability of the subspecialty, pediatric patients are seen by our pediatrician, adults are seen by family physicians, ladies with specific concern can see their OBGYN. However, the subspecialties do not cover the entire working hours, but family physicians are. So in the absence of subspecialties, family medicine see the patients.
Okay, so the other question, as a private sector, and we have lots of family medicine graduate, how do you see employment options for the private sector for the family medicine, for the family medicine graduate?
It's really promising. I hope anyone interested can email me.
No, I don't want you to advertise for your center per se. I just need a general impression, like from the work perspective, from payment perspective. I got lots of a question about the employing a family physician in the private sector. How do you see it?
If I wanted to be honest, I felt like it's a dream come true. As a family physician working in a facility, giving me the opportunity to serve my patients to the best possible care, ensuring that I should give my patients the best possible quality. I felt that I'm providing the message that I wanted to give for my patients as a family physician. That's regarding the work side. Regarding other incentives, our providers don't have to worry about number of patients, how much they get income for the center. Their salary is fixed regardless of the other things. I hope this answers your question.
Okay. Now, when it comes to the patient, from your practice, have you seen they prefer to seeing you as a family physician or see other provider like internists, for example?
So far, I think our patients prefer to see family physicians. They're starting to understand how family physicians can have a comprehensive assessment, can help even with mental health. They can help with consultations and counseling. So I think from my experience, our patients do prefer family physicians.
Okay, I'm just gonna call to the stage Dr. Khalid Abdul Karim, who is the Assistant Deputy Minister for Primary Care. Dr. Khalid, you heard two examples of a private sector trying to get primary care as a business, which is, I do see is the way forward. However, I want to hear if you have any other ways of inviting the family physician to take part of this momentum in a different ways.
Sorry, Dr. Hadi, this question for me?
Yes, Dr. Khalid. Question for you. Let me repeat. So we heard two ways of trying to get the primary care into private industry. From the first example in Medina, then a different Healthgate in Riyadh. We have an excellent number of physicians who are graduating in every year. Are there any other potentials where we can see improvement of the contribution of a primary care physician to the private sector?
Yeah, I believe, yes, there's other ways we can think outside the box. We know that we can't now keep expanding to have more primary care centers. It's really very costly to have all the equipments and that. And now even we think to maybe outsource or to have a community diagnostic center to have all the labs and imaging in that center and to maintain a good quality calibration and up-to-date interventions. Based on that, I think it's really open to have more solo practice. We can have like family physicians
to own their own clinics when they don't need really to invest millions to have the whole infrastructure of all labs, all services. They will be like in their practice, they will take care of the panel they are in charge of, and it's in a way to contract with them in a value-based model. If they meet their targets, they will be compensated according to this, considering as well as the satisfaction and the experience. They can be equipped with the appointment system and the platform of the Ministry of Health. They can work with the hospitals and with the with these diagnostic centers if they are within a certain network in the primary care. This is really something. It's not really implemented or planned, but it is in the discussion right now. I think if we want to go and to move forward, we need to think outside the box. Maybe this is going to be really a good news for the family physicians, where you can work harder, we can show yourself, you can gain even more income in your practice, as well as you do the practice in a way where you achieve and you can manage your own practice. Still, this is new. This is not something that we are saying that we are planning for or something that we announce. This is an idea between us. We think maybe I had discussion with you and some of our colleagues, but it's not something to be considered as a future project yet, or to be as a news to be shared yet. It is something to think, to consider. Maybe we can even think with more possibilities and more solutions. But all the options are available. Now moving to the separating the operator from the regulator and the payer, having the accountable care organization concept, privatization, all the options are on table. Thank you.
Thank you very much, Dr. Khalid. Now, I know the future and the payment system is going to be the main factor driving the practice. And if we as a country can come up with a way that those who hard worker who provide value will get compensated and rewarded for their effort, and at the same time they are enjoying their practice, I think it's going to be win-win solution. There is another proposal that was submitted to the society, where people are thinking of creating a virtual care provided by a primary care physician. And I'm just wondering, Dr. Khalid, is there the potential for such effort to encourage the frontliners to at least start thinking outside the box, like what you said?
Okay, virtual care, I think it's we shouldn't resist the virtual care. It's really it's proven its importance and value, but my personal opinion here, it's not to rely only on virtual care, to have only relation between you and the patient only through the virtual. I don't believe in it. Actually, it might be as an advice, but not entire consultation. As a consultation, I might do the virtual consultation to someone who is registered with me, to someone who I know him very well. I can ask him to come to the clinic if I don't feel comfortable with that. You can do it for like a refill. So that's why we are providing it right now in the primary care. There is a virtual and physical appointment. You don't need sometimes to call someone to come again and again to the BHC for evaluation, then for taking the test, then coming back to review the test. You might do and cut it short with a virtual visit to minimize it. This is going to save time and save cost. But having a full solution, independent solution of virtual care and registering people only on virtual care. You don't know them. You haven't seen them in reality at all. I don't believe in that. This is my personal opinion. It's not the ministry trend or belief. But this is my personal opinion as a family physician. I don't think that myself, I don't think that I'm capable to manage someone that I never seen him for a new problem, complicated issue, without doing physical examination, without having more close. Now in the family medicine clinic, we are removing the table. We advise against having the table between you and the patient. What about now having only the relation through screen? I don't think it has to be independent solution. It has to be within the solution of individualized person-centered primary care. Thank you.
Thank you. One of the dreams that I hope we accomplish one day, Dr. Khalid, where let's say myself and 2 other colleagues, 3, or like we create our own group of practice. Like we as a group, we just gonna come to you and the Ministry of Health, we tell you, you know what? I trust this group of people. We want to have our own practice. Contract us. Let's go to E1, go to E2, go to whatever provider. And as a group, we want you to contract us. Is this too much of a dream?
Yeah, I think this is maybe similar to what I mentioned earlier. Yes, if we have some group practice or solo practice, now if you want to have your own setting, it means that you need to spend millions to have all the requirements in your setting. But if you are in a contract with the ministry and having this independent outpatient office-based care, you don't need really to have all the required setting for imaging or labs as what is happening now in the polyclinics. I think it's a good idea if it is done within a certain arrangement to ensure quality, to ensure maintaining the same scope of service, ensuring not to have overspending. Things should be efficient, value-based payment. So physicians, I think, will believe to work more, to gain more, having the control on the environment that you work in. You will maintain a better quality. It will be your call. Myself, I think this is my dream job as a family physician. If I work in a setting that I can design it the way I want, and it's similar to my home, and that's why we call it a patient-centered home. You feel the ownership. You feel that everything is reflected, that you have accountability on. Why not? Again, this is not something we declare. This is not something we say that it is on plan right now, not to be misinterpreted. This is idea like any other ideas might be explored. But when we see the trend of privatization, when we see the trend of expansion, I don't think that we need to use the old way, having these primary healthcare center everywhere. This is not cost effective. It's really difficult to establish, to expand quickly. We need to think outside the box. Thank you.
Indeed, Dr. Khalid. And if as a group, now we're just like thinking loud in front of only like around 10,000 people. That's all. Like around 10,000 people are thinking loud. Maybe we as a family medicine community need to be more proactive and come with solution rather than waiting for somebody to tell us what to do. So as pure primary care physician, I think it is time where we show us as a part of the solution, be proactive. And if you go to the whole transformation, it's actually encouraging and pushing for the small businesses to establish. And what a better than a small business of talented primary care physician providing creating a small home for their patient.
I can't agree more.
Excellent. So just I want to reconfirm. So what we are sharing with you right now is just thinking out loud. It is not a plan yet. It is an idea. And I will call out as the society for all of you who are interested to formulate a plan and set a proposal for our leaders in the Ministry of Health and that transformation. It is the time. Let's capture the opportunity. Let's be more proactive. And the only limit is us. So let's come as a community with more ideas and the proposal and how we're going to work forward.
Of course.
Okay. Thank you very much, Dr. Khalid. We'll be calling you so often today. We just want to make the use of your time. Thank you for being with us all day.
My pleasure. Thanks.
Okay, so ladies and gentlemen, we have very important 3 sessions left. So we heard about 2 experience about starting businesses in a private care and as primary care from 2 different sectors. And we heard an informal discussion with Dr. Khalid Abdul Karim about the potential of how the primary care in the private sector might look like. And after the break, make sure to join us. We're going to share with you first an experience of a very mature private healthcare sector running, I would say, state-of-art primary care. So if you want to know how you should dream of primary care in the private sector, join us right after the break, where we're going to hear from Dr. Saeed Al-Qahtani, who is the chairman of the Wellness Institute at Johns Hopkins, to talk about primary care in the private setup. Then after that, we're going to call to the stage Dr. Shabab Al-Ghamdi, who is the Secretary General of Council of Health Insurance, who's going to tell us about his plan as a regulator of the private sector and the insurance business, how they are planning to inject the primary care within the private industry. And we're going to conclude the day with a very important and must-attend session with Dr. Khalid Al-Shaybani, who is the CEO of Health Sector Transformation Program, who's going to put all in together about the move and the plans, and we'll touch on the primary care specifically. We will leave the some space to interact with our national and international expert at the end of the day. So for now, I will leave you to go for your break and prayer, and we're going to start our session a little bit earlier. So take 15-minute break, and we're going to come back at 3:05. So make sure here 3:05, and I have still Dr. Saeed Al-Qahtani with me. So Muhammad, 3:05 will start your session. And till now, enjoy your break and do not leave the Zoom. Your place will be taken out. Stay on, stay tuned. See you shortly.
توحيد وسيف تثنى من يوم ابو ترك تنهض ونجم قاموا لشام العز محد تونى وخلف رجاجيل على قدر الاحداث وانصاح صايح قال وفداك حنا وجسنا على المنوى وعيت على الغير وما كل عشاق وصل ما تمنى وان قالها الله نجعل الحلم واقع ونطوع الصعبات بالعزم منا نبني عمار الدار بافكار وعلوم ونصنع سلاح جيوشنا في وطننا طقوا طبول النصر في يوم مجده وسلوا سيوف بشجاعه تغنى
من يوم ابو تركي تنهض ونجم أبشر قام ونشاء ما العز ما حد تونى
90 عام والشهادة علمنا، وحده وتوحيد وسيف تثنى. من يوم أبو ترك تنهض ونجم، قاموا لشام العز محد تونى، وخلف رجاجيل على قدر الأحداث. وانصاح صايح قال وفداك حنا، وجسنا على المنوى وعيت على الغير. وما كل عشاق وصل ما تمنى، وإن قالها الله نجعل الحلم واقع، ونطوع الصعبات بالعزم منا. نبني عمار الدار بأفكار وعلوم، ونصنع سلاح جيوشنا في وطننا. طقوا طبول النصر في يوم مجده، وسلوا سيوف بشجاعة تغنى.
من يوم أبو تركي تنهض نجم أبشر قاموا ونشاء ما العز ما حد تولى أبشر تسعين عام والشهادة علمنا
Ladies and gentlemen, welcome back. We are up to a next session about primary healthcare in well-integrated practice in the private sector with Dr. Saeed Al-Qahtani, who is the chair of Wellness Institute at Johns Hopkins Aramco Healthcare, and my bosses. Welcome you, Abu Muhammad, to the stage. We are looking forward to hear your presentation. The floor is yours.
Well, good afternoon, Hadi, and good afternoon, colleagues, attendants to this great day and a great conference. I have really enjoyed the lecture this morning, and I would like to present something that we've been doing for some time as a showcase of a primary care model that could be used or could be implemented elsewhere. So, as you know, that we have a legacy with primary care in Aramco, in Johns Hopkins Aramco Healthcare, that has been running for many years. And you know, healthcare in Saudi Aramco established in the 30s. And you know, from the pictures here, you know, it's a primary care clinic, as you've seen, doing immunization and helping people in the community. It was a community-based services at that days, and there was no family doctor at that time, but I'm sure it was run by efficient general practitioner and doctors at that time. So let me give you some background about how healthcare was evolved in Aramco. As I told you, the first clinic was opened in the region in 1936. In 1955, medical organization in Aramco joined the Harvard School of Public Health to eradicate trachoma. Also, late in that decade, malaria was eradicated in the Eastern Province through Saudi Aramco collaboration. And in that era too, you know, the Johns Hopkins, or the hospital, the Aramco hospital, it was not Johns Hopkins at that time, of course, was the first JCI accredited hospital in the region. But let me speak and focus about really primary care, since the talk today is about primary care. In the early 80s, they start really to build a satellite clinic in all region, in Dhahran, Ras Tanura, Abqaiq, Al Hassa, Udayliya, and some of the industrial area. And most of the doctors at that time are experienced GP, some of them with the training and some of them without training, at least in medicine or surgery. Some doctors are, and mostly the doctors are not, are from outside Saudi Arabia. So, but they realize with time that they need to have a trained doctors. So in the late 80s and early 90s, the first few family doctors were hired or sent for training. They realized the importance of building a good primary care center, and then in the late 90s, Saudi Aramco, with the collaboration of University of Toronto, have decided to send a mass training for a family residency program. And at the same time, they came and visited the area where they have reviewed the practice in primary care, and they have recommended to start with a group practice. So they have created multiple group practice within Dhahran, Ras Tanura, and Al Hassan, and all the clinic that belongs to Saudi Aramco. Those group practice were a group practitioner work together with their own resources, and they cater for certain population. And of course, they have accepted yearly 5 to 6 family doctor specialist trainee for specialty training. So by 2004, we had at least 24 or 25 Saudi family residents trained in the University of Toronto, and they came back as well. So in 2004, capitalizing on the knowledge and that those residents have gained, we have established the first diabetic care center in the hospital, run by family doctor. However, because of the high prevalence of diabetes at that time, it wasn't inclusive of every patients. So what we have decided later in 2009 is to start patient ownership, where we assign patients to individual physicians, and I'll talk later about this step in the ownership. In 2014, Saudi Aramco made a joint venture with Johns Hopkins International, Johns Hopkins Medicine, to create the Johns Hopkins Aramco Healthcare Center. And one of the early agreement is to review primary care in a initiative called Partner Contribution Agreement, where they come and assess our primary care and give recommendation. And we were looking for adapting the model of patient medical centered home. So, and they come up with recommendation to establish a patient medical home, patient-centered medical home in our practice. The involvement of patient medical centered home, although we are not certified center yet, I think we have all the element to be a certified patient medical centered home, has started then. And I think we will talk about it in the next few slides. So I'm not going to repeat, I'm sure this since the morning, my colleagues already talked about patient medical centered home concept. It's a team-based, knowing and managing your patients. It's about person-centered care, case management and care coordination, care transition, performance and accountability. So really, we wanted to adapt the footprint for a person-centered care. So our service provision, we wanted to be accessible for quality care. We want to be a gate for quality care. We are a referral-based system. We would like to provide a good preventative and curative and holistic approach according to the three A's and 3 C's that my colleagues, especially Dr. Mullah, was talking about. So let me speak about the patient ownership. So in the ATIA committee, this was tasked to tell us whether we need to do a patient ownership or not, because the care really at that time was you can come at the morning and select who's available that day. The committee decided that yes, it's the way to go. We have to have a panel empanelment, and we have to have patients for all the benefit of the patient. So the good thing in Saudi Aramco is that we have a captive population, and we are serving Saudi Aramco employee and their dependents. So we have decided to create panels for each physician, and each physician would have a panel size of 1,600 to 2,000. And we have decided to take care of mainly and make a focus on the high-risk population. So we have all the high-risk population distributed among all the physicians, so that we will not overload someone with most of his patients as a high risk. The aim is to have 70 to 80% of the time that you see your own doctor, because sometimes patients do not wait until to see their own doctor. And ownership is not without challenge, by the way, until now. It's a very challenging, implementation is not that easy because of the waiting time, the access to care, and etc. And patient rush. Patients want to be served the moment they are feeling they want to, so they don't want for their doctor to be free to see them. Sometimes when you open schedule are full in advance by many weeks. So we want to improve accountability, access, quality. We want to reduce referral rate and cost to the specialist. So let me speak about how is the access to care in our organization. In our organization, we have a regular scheduled care where patients are able to follow with their own doctor in a regular basis. We have same-day appointment, and we reserve slots for same-day appointment to improve access for those who want to see their doctor in that same day. But both regular and same-day sometimes are not enough to meet the demand of the patient. So we have the walk-in care clinic. We called it in the past an urgent care, but we realized that it's not real an urgent care center because we receive patients who does not meet an urgent care criteria with the acuity, and most of our patients are really walk-in care patients with medical problem that they couldn't find an appointment and they need a walk-in care. Before the pandemic, we had started the virtual care. Fortunate enough that we tried the system through telephone visits and video visits. And it's only really few months before the pandemic that we have tried the virtual care. During the pandemic, we were lucky. Hello, Hadi. Hello. Am I okay? Are you
Hey,
hearing
you're
me?
good to go, Mohammed. Yeah, we can follow our following.
Okay, sorry, because I received something that I'm interrupted. So during the pandemic, we were 80% virtual, 20% in person. And thank God that we have tried the system before the pandemic started. What we have now also is trying is a web-based visit where a patient could send you a message and it comes to your electronic health record as in your inbox, and you can reply to the patient with his concern. And the last thing that we will be trying, inshallah, from January is something called physician on demand, and it's about medical condition that a specific medical condition that we have listed, that the patients, if he fits those medical condition, he could request, coming to you, and you would see him either using the video or the telephone without the need for the patients to come to the clinic. The services that we will be providing are mostly an acute. It's like a walk-in care that is virtual. So what are the services that our primary care is offering to the people? We are offering chronic ongoing care for medical condition like diabetes, hypertension. We don't have any middle-level care now. We don't have office internal medicine. So most of our doctors the family doctors are doing all of these cases. And if they need someone to refer, they refer to subspecialists. We don't have any medical care anymore since the last decade. We have geriatricians. We have 2 geriatricians. We have a pediatric care. We are optimizing our procedure and wound care, and we have just recently opened a new procedural areas like a small OR in the building to do minor procedures like lumps and bumps and joint injections and etc. We continue to have our walk-in care. We have a treatment room that we offer iron therapy, immunoglobulin, vitamin B12, all kind of asthma medications and etc. We are doing preventative care, and we screen for cancers and chronic diseases as well. We have a well-established women health where we do mammography and breast examination, pap smear. And we have also pain management. We have a doctor who's interested in pain management, and we have a clinic for pain management. We have a palliative care, but it's not really now a part of primary care. It's part of the Cancer Care Institute. So our staffing, 70% of our staffing are family medicine consultant. Good number of them are Saudi. They are having either local or international board. The rest are having training or experience. We have a couple of physicians who are in RCGP International or having family medicine diploma. We still have few GP, but they are experienced. We have geriatrician, and we have adolescent medicine specialists coming in the way. We had a trial of nurse practitioner. Unfortunately, we did not go forward with nurse practitioner because it's not yet a job category in Saudi Commission. I think maybe it's something for the future to consider for Saudi Commission and for Ministry of Health to cover the gaps in rural area probably, or to help underserviced area. We have general pediatrician and OBGYN services. They do on office with us, like office OBGYN and pediatricians. We have experienced nursing with diverse background. So, and we have really resources, and why I'm speaking about resources, I think it's vital things to speak about resources. If you're putting a qualified doctor without resources, then you lose the trust of the patients. Our physicians have an access to good laboratory, unlimited tests that they can do. Some of them even including tests that can be even sent to Mayo Clinic. We have state-of-art pharmacy. We have the first robotic pharmacy in the region. We have access to imaging. Doctors can order CT or MRI. They can order stress echo, any respiratory test like pulmonary function test, neurolab, nerve conduction, and etc. We have physical therapy also attached to us, and we have one of the greatest electronic health record, which is called EPIC. Some of you knows about EPIC, in those who work maybe in the state or in Riyadh. I think that one of the cities in Riyadh has also electronic health record of EPIC. So as I told you, we had this partner contribution agreement with Johns Hopkins in 2015, and so we have decided that we will move into this concept. And what we find is that our high-risk population, and as you know, 5% of the population consume 50% of the resources, are not receiving really well-coordinated, care. I think they received scattered care and etc. Once they leave from you, no one is following up with them. So we have gathered all the high-risk population, assign them to a case manager, and each case manager would have around 200 of high-risk population where he takes care of them. And we have set a criteria and KPI for us and for them to establish. So we have assigned around like 200 per case manager. He will take care of their A1C, their immunization, their blood pressure target, their LDH target. And we will, it's not only for chronic disease, but also those who are admitted to the hospital are frequently, or those who are visiting the ER. And this is what we have done in 2015. We have enrolled around 2,000 patients who meets the criteria at that time. And by the end of 2016, we were able to discharge around 500 patients from the program because they don't meet anymore the criteria of that program. So, and we have reduced, for example, A1C from 10.9 to 8.1, LDL from below 100 to an 88, and we raised the foot exam for all of them, a comprehensive foot exam by a foot specialist, to 96, from 20 to 96, and we increased the pneumococcal vaccination to 81 for this high-risk population, and we were able to give them a flu vaccine in 60% of the time. So also we decided that, as I told you, the pyramid here, we served the upper part of the pyramid with the case manager. But we have people who are potentially will go into the higher pyramid, which is the second level 2. So we have developed the care coordinator, and each care coordinator would take care of around 10,000 populations. So we have a ratio of 1 coordinator to 5 to 6 primary care doctor. Those coordinator will look into your daily list and see who's due for preventative screening, who's due for blood test and who's due for immunization, and they will put a note for you from the morning or from the previous day. They also, you can, when you have someone with abnormal finding in your test, send them a text. They will call the patients and they will tell him, for example, come to the clinic tomorrow or take this medication prescribed in the pharmacy or do that lab test. Unfortunately, with COVID, nurses were scattered everywhere. They are needed in immunizations and they were needed in facilities, facility quarantines, and they are needed to, do triaging gates and etc. This function has been suspended for some time. We're trying to get it back to be functioning, inshallah, once the pandemic is down or is gone, inshallah. And also we have advanced nurses to even take care of some patients. In primary care, we had 30 to 35 for patients. URI, I'm sure those practicing doctor knows that we have many URI visits. So for example, we have done a protocol for the nurses to manage URI. And they are supervised by a doctor who's there. So we have that in our walk-in care, there is always a senior MD who supervises the whole area. So the nurse would work through a protocol, and the protocol will be followed. So if those patients do not need to see the doctor or they made the criteria to see the nurse, so they discharge those patients. And we were able to avail multiple slots for people who needs really the doctor's services. And nurses were able to, I think we satisfy nurses. Nurses in the past are used to do only, like vital signs or do immunization or something, but we moved them into a job that is really more rewarding. They feel that they are using their maximum, used at their maximum potential. And they're helping us really improving access, improving patient, physician morale. They don't see like 30, 40% of their schedule as URI. So we tapped in this potential and we moved forward to other things that like lower back pain, mild cystitis, wound care, and others are currently really dealt with nurses without the need to see a doctor. And if they need a doctor, there is a backup doctor who can help them. And we established an nurse care line that also people, if they had difficulty contacting their doctor, they can press a number in the call center and they are connected to a nurse. A nurse worked through a protocol and educate patients, and if they have any doubt, they send a message to the patients through the electronic health record. The doctor will go to to his messages every day and call patients. Moreover, we have a doctor who are available as well to see those patients virtually in that day if needed. This is something that I'm sure Dr. Anizi maybe, I'm just making a summary of family medicine residency. But I think family medicine residency introduced in our practice in 2017. And really it has done a major transformation in our practice. So we have around 60 residents now. We're all proud of them. We have one of the best training. I think we are ranked one of the best training in the kingdom. We have 40 TOT certified staff. 70% of our staff participated in the family medicine, the essential. And as you see, most of the conferences that are run currently are our staff are contributing to those conferences that is run by the Saudi Society of Family Medicine. They do audit activities, and audit itself is a subject that needed to be presented. And we have participated actively in the national guideline in collaboration with CCHI. How do we measure our success? We measure our success by measuring our access to care, and currently access to care for regular appointment is 3 days. And for a same day, we have access for the same day appointment. When patients needs, they can come for same day appointment. We measure our activity. We measure our patient satisfaction and we score very high. We are at 92 for physician satisfaction. We are one of the best departments when it comes to staff engagement because we measure our staff engagement. We have quality metric for chronic disease like diabetes. We do prevention. We do all kinds of prevention. We do colorectal cancer, mammography, pap smear, and immunization. And one of the things that I am proud of is the COVID response. I think primary care kingdom-wide and in Johns Hopkins have done extremely, but in Johns Hopkins, primary care really take the heavy lift of COVID COVID outbreak, and we operated 8 facilities quarantine. We created respiratory area with 5 negative pressure rooms. We created the first drive-through swabbing in the region at that time. After they closed the facility quarantine, we continue to care for our positive case patients, which are massive. We had 12,000 positive cases in our population. We cared for them through daily call on home monitoring program. We call them daily until they are discharged, until their day 10, and we ensure that if they are sick, we take them to the hospital. We had COVID care line, and in the meantime, we continue our business as usual. We run vaccination centers in all area, and we vaccinated more than 200,000 candidates. What is our future aspiration? We want to be main enabler of Johns Hopkins if they move into an accountable care organization. We want to be, we revive our family advisory committee and encourage patient participation, and we want to be person-centered department. We will enhance in our preventative program. We will do more procedure. We will enhance our virtual care, enhance our residency program, and we will expand in the community and collaborate with all organizations outside, including MOH. This is the last picture. This is where we are. I show you the early picture in the early inception of the clinics in Aramco, and this is our latest clinics in primary care. Hadi, before I end this, I see a great momentum in the country moving for primary care forward. What we need is really support, resources, and a trained individual to go forward. Thank you, Hadi. Thank you, the team. Thank you all.
Thank you very much, Dr. Saeed. It's such a very interesting journey through the primary care services in the private sector, with lots of opportunities where we can share experiences with the rest of the country, and also we can learn together to make use of the momentum. I would just throw one question at you, Dr. Saeed. Among all what you've mentioned, what was the main driver for success for this transformation in primary care in Jaha?
I think what changed it is really bringing trained family doctor on board. Because, you know, after we trained 25 family medicine with the University of Toronto, when they come back, they have done the transformation. I think the leadership in Aramco realized that the importance of primary care on multiple domains: the cost, the access, the comprehensive, the need for the patients really to receive a good care, and no doubt the one who made the decision really to send people for training and transform it from GP led to like a family medicine led has really created the change. Plus the resources, Hadi, I think we have unlimited resources. I think we have unlimited resources. We're practicing like like a hospitalist, like other colleagues in the other services.
Thank you very much, Dr. Saeed. Ladies and gentlemen, we heard lots of discussion today about the private sector. We heard a couple of experiences from Medina, through Powergate to Healthgate in Riyadh. We heard from a well-established institute running primary care. Now let's call the person in charge of reforming the private sector industry, Dr. Shabab Al-Ghamdi, the Secretary General for the Council of Health Insurance, along with the Executive Director of Enablement and Supervision at the Council of Health Insurance, Dr. Nasser Al-Jahani. They will be driving us through their plans and passions on how to reform the private industry focusing on primary care. Dr. Shabab, it's an honor to call you to the stage.
Good afternoon, ladies and gentlemen. It gives me a great pleasure, my colleagues, Dr. Nasser Al-Jahani and myself, to join you today. I hope you enjoyed your day so far. Is the voice clear, Dr. Hadi?
Yes, clear, Dr. Shabab.
Okay. Today, if we can go to the next slide, we thought it's really very important for the family physician to understand our strategy as a CHI strategy. Also, Dr. Nasser will shed some lights on our population health and primary care advancement project. Definitely, one of our objectives as a private health insurance regulator is really to improve the access to a quality primary care at the private sector. And it's part of our overall arching strategy. As maybe some of you understand, CHI is part of the executive program of transformation for health transformation program. Today in Saudi Arabia, we have around 34 to 35 millions. 30% of them are privately insured through their employer. By 2030, we would think at that time 55% of our population will be insured by private health insurance through their private employers. As you can see, our country is going through major transformation where the private sector is growing. So as of that, the shift, the private coverage will be more than public, and that will help us to sustain the system. Definitely the main objective of the transformation program is really to facilitate access to care, to improve quality of healthcare, and to promote prevention. And most of these functions are done by you guys, family physicians. So even the fourth pillar of our transformation strategy is really improving road traffic accidents. So I think if we go to the family medicine practice, I was discussing this with Dr. Hadi earlier. Even we, during our well baby visits and teenager visits, we speak to them about safety belt and helmets. And it's proven to have an evidence to really make it as part. So I think primary care and family physician and qualified primary care will be able really to contribute to the four pillars of our transformation fund. I think we carry a great responsibility. It's an honor for all of us, and I'm sure we'll be able to deliver, especially we are going through a major transformation. I was happy to hear Dr. Saeed earlier. I think what they did with diabetes in Johns Hopkins Aramco Healthcare Company is great. That's really value-based healthcare. When you really know your target population, try to have an outcome measured, move the target. That's really a live example we see in Saudi Arabia today, applying what we know, value-based healthcare. Next, Dr. Nasser, Allah yahinak. So that's our kind of projection for the future. Our contribution to the economy will increase from 1% now to 2% almost. There will be also another insurance program for all Saudi Arabia visitors, i.e. Umrah, Hajj, business travelers, and tourism. And we are expected to receive more than 30 million by 2030. And our Crown Prince he said that one of his speech that we have the potential to receive 100 million. So this market is huge. It's really medical insurance for travelers. This will bring more business and will allow us to have more people without burdening our public healthcare system. Next. So every scenarios we project, we have the optimistic, the pessimistic. However, it was done on scientific basis. Next. So what is the CHI strategy? Based on the 4 pillars of the health transformation program, CHI built their strategy around that. So our objective is not anymore to expand the market only. It's really to promote population health. How can we improve the beneficiaries' health? This is our mission. And out of that, we came with 5 principles or 5 strategic imperatives. One of them is being beneficiary-centric. How can we enable the target population to have the right coverage, to have the right access, to have the right satisfaction, to have the right quality? Can we measure that? Yes. Well, today, we do some of the measurement on the satisfaction through risk gaining, either in the hospital or across the whole journey. And we are trying to improve the touch point between all stakeholders. Also, we start to collect data across the whole system so we can identify our target population that we need really to pay more attention to. In addition, improving the access to care through enhancing the primary care with a qualified caliber. Enabling the sector, how can we make the payer and provider speak one language? We launched several projects like the unified contract, the unified coding system, and also we are building the Nafis digital platform. And it is one single platform for the whole nation where the payer and provider will communicate through. This will help us really to ease the burden on the payer and provider by managing only one platform. 2, it will improve the data quality. 3, it will improve access. In addition, we will have a better data so we can have better planning. Definitely, we are also adopting value-driven sector principle. Value-based healthcare is a simple formula. The value equal quality plus satisfaction divided by the cost. So how can we do that? That's the foundation that we built. Now we are having a unified platform, measurement tools to measure satisfaction, outcome to be measured, and then also we have an eye on the cost. So every time we improve quality and satisfaction and at least keep the cost at level or marginal increase, that's the values is how can we do that? We are moving now from fee for service to DRG and bundle. DRG is really bundling the care in one bundle. So this will help patient to receive the best care. In addition, it will reduce unnecessary services. Also, we adopted being progressive regulator through really attracting the right talent from the market, training them, and also sharing the knowledge with the market. And 5th, last but not least, is really digital. Everything is going digital. I'm glad that 2 of our big hospitals in Saudi Arabia went with Epic, and there is other systems around the whole kingdom. And our experience now with the Nafis, the platform that I will speak about later on, it's National Platform Health Information Exchange Services. It's a platform where we integrate with HIS of hospital and claim management system from the payer. From our experience so far on the adaptation of this platform, every hospital who is HIM7 during the adaptation, they were very successful, and it shows really the maturity and the accuracy of their data. So I would encourage all providers really to aim for HIM7 because it will improve your visibility to your target population. You'll know your performance, you'll measure your metrics, you know what is the area that you can expand on because you do well, and you know the area that you need to improve. So as we can go bold to HIMS7, that will definitely improve your capability as a provider and improve your customer services. Next. So this is just kind of general our house strategy. These are the programs. We have around 21 programs and more than 95 projects. Next, some of them I just mentioned to them. This is what happened in 2020 and next in 2021. I'm sure Dr. Nasser and the team of the conference can share with you all this presentation. Next, Dr. Nasser, and can we go back? Yeah, these also some of the initiatives during or major milestones during 2021. So there is a lot of implementation of a lot of products. CHI, even from digital maturity, we score number 4 across the whole kingdom in terms of digital maturity by the governmental authority for electronic الهيئة الحكومية الرقمية, our digital health authority. So we are also targeting to improve our digital maturity, which will help us really to aim to serve our provider and payer the best way. Next. So how can we really improve private health insurance pillars or make them speak the same language? It's really through 4 main domains. It's really how can we really focus on measuring quality and improving efficiency? How can we focus on promoting health? Our essential benefit package or the extent of medical coverage now are moving toward prevention. So most of the new changes that was adopted in the new policy or the mandatory policy أو هي حدود التغطية التأمينية الصحية, it's really to cover the prevention as per Saudi CDC and international best practice. So starting July 1st, 2022, all preventative health screening program will be covered, and payer will be compensating provider on it, and also will be asking them to reach similar target that Dr. Saeed is speaking earlier. For example, flu vaccine, I was expecting actually more than 60% because it's really something that we can do more and protect our elderly. Next. And definitely, I'm sure with sharing benchmark, with sharing performance of hospital, will be able to compete and improve the transparency and competition for the best interest. We also work on the journey of improving beneficiary experience through studying the touch point, and we released Breast Genie survey. It's different from the survey you do in the hospital. It's really touching when the beneficiary start to pursue his medical insurance, communicate with his payer, communicate with his provider, the approval cycles, the claim cycle, all the touch point that it's important to him. So there was almost 14 touch points, and we are measuring them now quarterly, and we are sharing this with the payer and provider. And starting next year, we will put it publicly as per the directive of board of directors. So all payer and provider, their performance will be public, and beneficiaries will see them, and they can use that as a reference when they purchase their medical insurance or choose their provider. Next. So these are the performance. Even we measure our performance as CHI, we think the insurance company need to improve. Healthcare provider is at a better edge. However, our benchmark in international for provider, it's 85 and 90 plus. In the payer side, internationally, it's really 75 plus. So we are aiming really over the upcoming 3 years to at least to achieve some of the target reaching to the international benchmark. And I'm sure with the kind of digitalization and measurement and enhancement that the whole country is going through, our chances to achieve the target and then compete internationally is better. Next. I think these are more details on the Breast Genie. Next. Okay. Next, Buyara. So this is just a benchmark against neighboring nation and maybe Ministry of Health. However, I'm sure provider varies. Some of our private providers are reaching 77 or 78. So they are almost there, but need a bit of push so they can go to the 80s and 90s. Next. So we have developed our ABP, essential benefit package. Any nation cannot cover everything. So how can we really determine our priority from healthcare perspective? And this is through, it's a science, it goes through cycles. It changes on the healthcare priorities, your population needs, and you do it on a regular basis. You review, you update, you monitor, and then you get feedback from the market and you measure. And every year you look to your data, and based on it, you update your essential benefit package. I'm sure with the data maturity that we are reaching at, we'll be able to do better in defining our essential benefit package, so we can really cover what's important for people rather than having some waste that will not help to sustain the system. Next. Okay, so how can we, our vision and mission adopting value-based healthcare. So how can we really explain what is value? Everybody, I'm sure, has their understanding what is value. However, from National Health Program point of view, is really, it's a journey. Today, if we just move toward having a better data and better electronic health record, better visualization of our captive population, that's value by itself. So, and the next is really to build other models like DRG and the BREMS and PROMS, but it requires a lot of data maturity. So our focus, the first and second year, is really to have a better data, and then we can build on it till we reach a full maturity, where we pay for performance rather than we pay for services. And everybody is doing better, they will be compensated more to encourage them to improve their services. BREMS and PROMS, to those who are not familiar with the terms, patient-reported outcomes and patient-reported experience. Now, some of the payers around the world, they are adopting those survey. For example, if someone received surgery and they will ask specifically for that type of diagnosis, what is your experience with first, and how have you benefited from the procedure? And there is a standard questions that is really measured and validated and adopted by several international agencies like International Consortium of Healthcare Outmeasure, ICHOM, and it's becoming like a standard practice. And I'm sure next year our team will do the BREMS because we start to have good data, and then the year after we will start to do the PROMS with international company. Next. Okay, these are more details and give you our roadmap, and there is project to support each pillar. Next. And definitely, any strategy, it's a dream unless it is really executed. So how can we measure our execution? This is our balance scorecard. Walillah alhamd, all of our governmental entity now are geared toward really measuring performance. If they anchor any strategy, they are responsible to provide the right measure to assess the development and the milestones. So we have a balanced scorecard that measure all of our projects, and we are accountable in front of our board and in front of our stakeholder to achieve the target for the upcoming 3 years. Next, we are out current. Okay, so what is Nafis? Maybe, the best explanation to Nafis, if you'd like to really, as an insurance company, to build a relation with the provider, you have to connect with them. In the old days, it was the fax. Then it became like in a special portal. So we have 27 payers around the whole kingdom. So they have 27 platforms. And every hospital have to have different type of interface with those 27 payer. So the idea of Nafis KMN, how can we build one platform so we reduce the burden of the payer and the provider and to communicate it through one unified language? And this will help really to ease in the journey of the beneficiaries, and it will add also and will be a major part of our national electronic health record. As you know, most of the transaction between the payer and provider, it is really around diagnosis, minimum data sets, services provided. So a lot of medical information that will be part of our national electronic health record, or what we call it health information exchange services. And it's phase 2 of Nafis. So Nafis has the first part, which is the insurance, and the second part, or the second phase, will be the health information exchange services. So as a provider, you will be able to access your patient data if they go to other facilities. So instead of calling that hospital and asking them to send a record, if you are connected with Nafis and you are accredited and you have your privilege giving you to the health information system to access certain patient information, you'll be able to access this similarly through Nafis, but in the background. Next, Abuyara. I think this is definitely into, data is the new oil or a new business or the fourth evolution. With data, you can really define your needs, define your population. Our national platform will have also the national address of all beneficiaries. So you will know really where is your population. So you can plan, know what's their need, primary care, secondary, tertiary, specialized center, in addition to having, tackling all chronic disease, tackling, I'm sure AI will help us to define more opportunity as we grow. Next. So this is the journey so far. لله الحمد عندنا اليوم we have 134 qualified provider and payer, which constitute 65% of the market. They are up and running on the platform now, and we are expecting by mid next year most of the market will be on board on the private health insurance part. Next. Okay, so I think this is where I end my part, and I'm sure Dr. Nasser will have you through journey or the roadmap of CHI to develop our population health for the upcoming 5 years. Without any further ado, I'd like to thank you again for being patient, listening, even though I couldn't open my camera, my deep apology. Thank you, Dr. Hadi, and I'm sure Dr. Nasser now is showing up.
Thank you, Dr. Shabab. And there is lots of buzzword that you throw at us, and we're going to call you and your experts from the CHI to educate the primary care community about what you mentioned about the DRG, the bundle payment, the value-based healthcare, along with the PRIMS and PROMs, things that I think it is time for us primary care to be on board with these terms. Thank you, Dr. Shabab, and looking forward for your contribution with the society in the future.
I would suggest one full day to explore what is value-based healthcare, Dr. Hadi. I think you said really those terminology for me as a family physician was really a puzzle. However, after I learned from my colleagues and from the expert, I think it's not really something that we cannot learn. I think we should learn as a physician, so we can really not cater for only the patient that in front of me. I can cater for the whole community around me.
Okay, so I'll take that as an invite from you to call on you again and your expert to partner again with us in the society to bring this and share this knowledge. Thank you, Dr. Shabab.
Shukran.
Dr. Nasser, welcome on board.
السلام عليكم ومساكم الله بالخير جميعا ويكند سعيد على الجميع. هل صوتي واضح دكتور هادي؟
Yes.
Okay, جميل جدا. Okay, so I'd like to welcome everyone. And can I ask you, Dr. Hadi, how much time left do I have? Just want to calibrate my time.
So you get 15 minutes, Dr. Nasser.
15 minutes, excellent. Okay, so I'll talk with you about two topics. One is about our population health program 5x5, really an overview. And then I'll talk about how primary care is going to drive our private healthcare sector, as well as our population health 5x5 program. So in CHI, we thought about how we can advance our healthcare sector. And we know we can't do everything at the same time. So how we can really focus on the things that are high burden and high impact on the sector. So we did our research and talked to multiple stakeholders, and we identified 5 diseases that are causing the highest impact and highest burden in the system. Those are diabetes, hypertension, coronary heart disease, tobacco, and obesity. And we put together a plan on how we are going to target these 5 diseases in 5 years and create a population health management program. Our strategy towards value-based healthcare really stands on important pillars. And those important pillars are categorized into 3 important categories. One is what we call models. That is how we are going to deliver care. And 2 is payment, how we are going to pay for care. And 3 is measurement, how we are going to measure how well we are doing with our healthcare system. So zoom in on the population health management, which is in Arabic, إدارة الصحة السكانية. I'd like to give you 15 seconds here to pull your phone, pull your camera, and put it toward this QR code in order to find our white paper that we just released a week ago. We released this white paper that explains what population health 5x5 is, what population health management is, and what is our plan towards this program. So an extra 5 seconds here. Okay, excellent. So population health management basically means that you are trying to identify those diseases and then try to segregate and segment the population that has those diseases, and then work on interventions that are going to target improving the health of these people. So for diabetes, we know we have about 14% of adults, and there is an increase by 53% between 2009 and 2019. And now we're working on how we can identify evidence-based proven interventions in order to lessen the burden of this disease. This is just an example. So track outcome measures examples here are looking at utilization. So for example, ED visits and hospitalizations for patients with diabetes. Clinical metrics, how well they are doing with A1C, weight loss, blood pressure, short-term patient engagement, long-term patient engagement, medication adherence, cost of care, return on investment, and return on engagement. And for outcomes, we're looking at things like reduction in A1C, short-term patient engagement, and cost savings. And then, because we realize that we are a regulator, we're not a provider, and we're focusing on how we can increase and enhance the interaction between the payers, and this is the healthcare insurance companies, and also the providers who are going to provide care, how we can enhance those policies and those interactions. As you know, healthcare is a complex adaptive system, and you really can't over-regulate, but focus on relationships and enhance them, and empower and enable people in the sector. So we started working on our chronic diseases registry for those 5 diseases, and thus we pull from data that we have in CHI from the market, and those are claims data to identify where these patients live, where do these patients go for care, which insurance companies do these patients belong to, which companies or employers these people work for, how is their utilization, do they go enough to see physicians, or do they go way too frequent to the ER or hospitalizations. So we are in now working on our first registry, which is diabetes. We are expected to deliver a publication every 3 months or so on how well people are doing in the sector for these diseases. And then we're looking at our clinical effectiveness measures. We have about 14 measures that we identified for those 5 diseases, and we are planning to introduce them gradually to the market and start with 2, then year 2 we'll do 4, then 8, 10, till we go to full measurement of 14. And this just shows you how we are kind of gradually introducing these measures for the private health insurance sector. Okay, so going into the primary care advancement project. So we realized early on that in order to deliver population health management, you really need to advance and strengthen our primary care. And so we started looking at primary care and how we can advance it, really basically going back to the goals of Vision 2030 and Health Sector Transformation Program. It's basically access, prevention, and quality. So how we can deliver those goals down to people like Ahmed. Ahmed is just one of our beneficiaries. So how we can cascade those goals through the Health Sector Transformation Program strategy and goals, the Saudi Health Council strategy for primary care, our strategy, and then create our primary care advancement project with collaboration with the healthcare entities. So we looked at what we have done in the past so we can build on it. So there are 2 articles we have in CHI that are trying to strengthen and improve the utilization of primary care. One is we mandate that each network for beneficiaries have a first-level primary health care. So health insurance companies issuing policies must include primary care. 2 is that the beneficiaries must visit primary care in order to get a referral before they see a specialist. 2 is through our essential benefits package, which is حزمة المنافع الرئيسية أو الأساسية, which is the floor of the market. So no insurance company can issue any insurance policy unless they have these mandatory benefits. So we looked at how we can adjust the copay in order to push traffic towards primary care without jeopardizing access. So one is if patients, and this is going to start July 1st of 2022, if a beneficiary visits primary care, there is a 5% copay with a max of 25 riyals. This is a huge reduction from the current state of up to 20% copay. If a beneficiary chooses to go to a specialist with primary care, then they pay a 10% copay with a maximum of 75. If they choose to go without primary care referral, they pay 50% copay with a maximum of 500. So you can see the gap between going to primary care and between going to specialist without primary care. So that gap hopefully will create that traffic. But we still understand that people like Ahmed have trouble or problem finding primary care in the healthcare sector and coordinating care for themselves. They feel that they are in a maze in our healthcare system. And why is that? So we've done some workshops and researched the topic, and we identified, just to keep it very simple here, 3 important reasons of why Ahmed is having difficulty capitalizing on these policies and capitalizing on primary care. One is Ahmed doesn't really know what primary care is. If you ask someone here with a health insurance company and say, do you know what primary care is? They'll probably know what polyclinic is, what a hospital is, what ER is, but the term primary care seems a little bit not clear for them. So, and the reason is we don't have a unified definition. We don't have a unified standard for primary care yet. 2 is Ahmed doesn't trust primary care, even if they know there is a primary care, because there is no reliable measurement of performance. So we are not measuring how well primary care is doing. So Ahmed really doesn't have that tool to measure and be able to trust primary care. And 3, Ahmed can't find high quality primary care because there is no much investments in primary care. The investments usually go towards hospitals and ER because those have higher margins and better incentives. For primary care, Ahmed can't find a high quality primary care because there are no incentives for people to invest in primary care. So how we can solve those three important root causes, we developed the 3 steps towards advanced primary care. One is we're going to establish primary care standards for CHI accredited centers. Then we are going to create performance measures to measure how effective our primary care is. And then down the road, we're going to use payment mechanisms in order to incentivize people who are doing well in the primary care sector. So basically, if you go look at licensures from MOH, you still find a general medical complex, a specialized medical complex, polyclinic hospital, but no specific license for primary care that identifies primary care on its own. So our standards are built on a concept of creating a home for the beneficiaries. We call it a home because the beneficiaries are going to find their basic needs, and they are going to find a place that is safe and quality. Also, they are going to find a place where they are familiar with everything in that place and people there are familiar with them. So familiarity of your own home. And 4 is a patient after any long journey in the healthcare system, either in the hospital or in the ER or in the specialty clinic, a place for the patient to always go back to and find the people who are going to take care of their basic needs and coordinate care for them. So it's basically built on primary care physician leading team-based care, safe and quality care, screening and prevention. This is these are just 2 important. If you remember, if you remember 2030 goals, and population health management 5x5 program implementation, enhanced access with virtual care. If you remember the 3rd goal of Vision 2030, care coordination and integration, and all built on the health information technology and data. So we built our first draft of the standard. Now it's being reviewed by multiple stakeholders from the sector. We are almost heading towards our final release late this year. And we believe primary care is going to be delivered either in the community, where you have your own clinic in the community, or it's going to be a department in any hospital. So a hospital can build their own primary care department and integrate with primary care, or integrated with payers, which is something that is being under review by concerned governmental entities, where primary care is integrated with health insurance companies or any payers. And also we're starting a program alongside the accreditation standards that is towards registering beneficiaries with primary care centers. And we know we can't register our 10 million in the first year, so we're going to start gradually with targeting our chronic patients with chronic diseases, especially those with priority diseases, like the 5 diseases we talked about, and then go to the rest of the diseases, then target the rest of the population. This is our general timeline. So we're planning to finalize our manual in about 2 or 3 weeks and start accrediting programs in January. And really our goal for next year is to find pathfinders. We call them pathfinders, are the people who are going to be early adopters and pioneer the new primary care. Also, we're going to start registering beneficiaries with the primary care physicians. For care performance measurements, we have 5 domains we identified: screening, prevention, chronic care, acute care, and mental health. And we are utilizing HEDIS measures in order to utilize them for this project. And again, we're going to take the market gradually through reporting those measures in alignment with the population health 5x5. Then starting next year of 2030, we're going to really look into how we can pay the better performing primary care centers. So we're really looking toward improved healthcare delivery. moving Ahmed from a maze into a coordinated healthcare system. And we're looking for experience for Ahmed where he can pull his smartphone, connect with his primary care center, and that primary care center is integrated with healthcare settings through referral arrangements, data sharing agreements, tele-consultations, and care transitions programs. This is our general timeline. I'm really thankful for your attendance. I'm happy to receive any questions and connect with you after this conference. Thank you, Dr. Hadi and the rest.
Thank you very much, Dr. Nasser. The very ambitious plan that I'm calling for all the wider community of primary care to jump into the opportunity and be part of the change. You mentioned that you're going to soon release the manual for primary care, and I'm sure our frontliners across the nation are very interested to learn more about this manual and standard, because at the end of the day, it's all about the primary care, and these are the primary care group who wants to be part of the change. I'll take this opportunity to call on you, Dr. Nasser, and the team to join us in the future, even to address more about the project Hadi. Now I will come back to you, Dr. Nasser, and the rest of the panel in 20 minutes after the last lecture of the day, which is being presented to you by Dr. Khalid Shaybani, who is the CEO of the Health Sector Transformation Program. Dr. Shaybani will present to us the program, initiative, and the plan, and how primary care is seen as the cornerstone of the transformation in this journey. Dr. Khalid, thank you very much for joining us, and we look forward to hear from you.
بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Ladies and gentlemen, dear doctors, healthcare workers, it's a privilege and an honor to talk to you today in this primary care for now and forever. I am Khalid Al-Shaybani. I am a transplant surgeon, and also today I am the CEO of the Health Sector Transformation Program. And in the next few minutes, I will share with you primary healthcare as a foundation, as a part of the integrated healthcare system strategy that we are working on. Next, please. Of course, all countries globally are now in search of new ways and paths in the health system. And transformation is not an uncommon word to be utilized in these countries, especially the advanced ones. And that's largely due to the factors that you can see here in front of you. We know today that the costs of healthcare are ever increasing. They're increasing faster than the gross domestic product. And all countries that are focusing on treatment rather than prevention are struggling to face that challenge. Of course, all countries are also seeing larger ratios of patients who are, or individuals who are becoming from the older age category. And also the population growth in itself is another factor. Similarly, there are almost always disappointments with outcomes of care and the quality of care. And hence, this is a point of intense scrutiny and hope for a reform. And lastly, the global burden of disease, chronic diseases, and their impact on the community is now far bypassing the non-communicable or the communicable disease component. Can I go to the next slide, please? And in order to meet these challenges, our vision has been created along the main strategic objectives that you're all familiar with, having a vibrant society, an ambitious nation, and a thriving economy. Along those, 4 strategic objectives have been developed to aspire to for the health sector. One is around easing the access of health services. The second around improving quality and efficiency of healthcare services. The third about promoting prevention and health security. And lastly, about enhancing traffic safety. Next. Now, transformation really started in 2016. And the healthcare transformation was a portfolio amongst many portfolios in the National Transformation Program, برنامج التحول الوطني. And for the first 5 years, there were 7 entities that you see on the bottom of the screen that were engaged with this healthcare transformation. And largely, we dealt with the 4 objectives and 70 odd initiatives with 22 KPIs that we were observing. Now, we started a new phase of reform in 2021. Please, next page. This phase is really focusing, or the previous phase, before we move on to the second phase, the previous phase was focusing about the Ministry of Health as a regulator. We all know that the Ministry of Health provides care for about 70% of the population, and most of its care is really through 280 hospitals, 2,300 plus primary care centers. But the ministry is acting as a regulator, as a provider, and as a payer. And that is a conflict of interest. And hence the reform was mainly about the Ministry of Health's reform, so that first of all, a provider entity will be developed. And these, if you've been hearing about cluster formation in the different parts of the country, 11 clusters have been formed so far out of 21 potential clusters. They're all under one management, under Health Holdco, still under development. It's not out yet. And a payer system that will also be providing payment for those clusters. And the ministry will be developing its capability as a regulator. Of course, these 3 very important initiatives are also based on certain enabler initiatives relating to workforce, private sector participation, and digital transformation. So all of this work has been ongoing for the last 5 years. Next slide, please. The next phase of the reform was started by announcing the program, or the Health Sector Transformation Program. Again, with the same 4 strategic objectives. However, 16 additional objectives were added that are not direct objectives. And out of the 70 initial initiatives, 40 remain. Most of the others have been closed and finalized, plus the same 22 indicators. However, this time, as you see from the bottom line, we have 18 entities engaged in the sector. These are different entities, such as security health entities like the Ministry of Defense, the Ministry of National Guards, Ministry of Interior, and also other players like the Ministry of Education and other players in the healthcare ecosystem. Next. So if you look at the journey, the legal journey of the program, you can see, first of all, of course, in 1438, the initial royal decree about national transformation started. 2 years later, a royal decree approving the governance and revised governance of the health sector and nominating the Ministry of Health to be the sole regulator in the system. Then the strategic committee of SIDA had approved back in 1441 a series of decisions to approve the MOH transformational approach and model, and establishing a health holding company, and which is a government non-profit company, and establishing a Center for National Health Insurance, which is the payer model. Now, last year, there was a royal decree to approve the creation of a health sector transformation program as one of the kingdom's vision realization programs, or VRPs as they are known. Next, please. So the program and the royal mandate, it was very clear, and I will speak in Arabic. يهدف البرنامج إلى إعادة هيكلة القطاع الصحي ليغدو نظاما صحيا شاملا وفعالا لتحقيق رؤية 2030 واستيعاب طموحاتها ومتطلباتها من خلال تعزيز الصحة العامة والوقاية من الأمراض وتطبيق نموذج الرعاية الصحية الحديث المعني بالوقاية من الأمراض قبل وقوعها وتعزيز وعي المجتمع بالسلامة المرورية، وكذلك من خلال تحسين الوصول إلى الخدمات الصحية عبر التغطية الأمثل والتوزيع الجغرافي العادل والأشمل والتوسع في تقديم خدمات الصحة الإلكترونية والحلول الرقمية، ومن خلال الارتقاء بجودة الخدمات الصحية والتركيز على رضا المستفيدين عبر تطبيق واتباع أفضل المعايير الدولية المبنية على المراحل. In a sense, this was a royal mandate to restructure the healthcare system so that it becomes a much more value-based healthcare system. Next. Now, our program is mandated to work over the 12 months, really, since its creation, to develop a strategy that is across all the sector. And this journey is, there is clear steps that are to be undertaken to define high-level strategy architecture, business case, and then to detail the strategy with all the stakeholders in the ecosystem to come at the end of the year with a comprehensive, what is called strategic objective delivery plan that entails initiatives and clear process, clear KPIs to deliver the transformation that is required. Next, please. Now, this is the strategy house here, and there is 11 components of the strategy house. There is 4 core pillars headed by the governance and regulation, basically the regulatory landscape and any role mix-up and any new requirements for new roles will be looked at. Also, another core pillar is the value-based funding and payment mechanisms. The Ministry of Health Transformation and its payer methodology has been already approved. However, this is talking about the whole system. So again, all the other public providers, which constitute 20+%. And then integrated healthcare delivery, which is talking about all healthcare delivery components, the way that we deliver care and the way that our patients and population journey through different healthcare systems. And also the public health and health security, to have a unified public health strategy that's not only affecting the direct providers of healthcare, but also other government agencies that deal with health in its widest terms. Then there is 3 inputting pillars, one around workforce and education, one around procurement and supply chain, and a third around facilities and assets. These are self-explanatory. And also there is 4 enabling pillars, one around private and third sector participation and their roles in the sector, one around research, development and innovation, and economic contribution, and one around data and digitalization, and lastly about leadership and cultural transformation. Each of those pillars, there is an agile structure that is, there are teams that are working in those areas with different stakeholders from the ecosystem to deliver, in order to deliver through this one-year journey, inshallah, the strategic objective delivery plan with its details. Next slide, please. Now, based on IHI's triple aim, we could definitely anchor our vision and through those objectives, and our 4 strategic objectives are quite linked to health, being well, to care, and to value. Next, please. Now, if you look at the last 40 years, it becomes clear that Saudi Arabia has done a tremendous job in the last many decades, really. So if you look, for instance, at life expectancy, we've improved from 62 back in 1980 to 75 now. The mortality rates for those under 5 has tremendously improved and been reduced from a very high number of 90 to 8.5. We've added almost quadruple the number of physicians per population. We've reduced death rates, improved immunizations. Here, measles is an example. Actually, we're one of the top countries that are compliant with immunization rates. And we have added more beds to our healthcare system, almost raising to the level of 2.2. So those are tremendous achievements. However, we recognize that the challenges that I mentioned before, and next slide, please, will continue to challenge us in the future. Here, I'm just detailing some of those. For instance, the population in the kingdom, we all know that it's going to reach almost 40 million by 2030 as per vision targets. And then we will have the ratio of the elderly population will increase from its less than 2 million currently to almost 5 million that day. So that in itself provides a big challenge for us. As I mentioned earlier, non-communicable diseases remain a very high challenge to all different countries, and particularly in our country, where obesity, heart disease, stroke, diabetes, respiratory diseases, even mental health, and have not really been well controlled and addressed on a preventive basis. Primary care definitely continues to be a problem for us, although we have spanned the country in terms of the availability, and the Ministry of Health in particular has a large number of primary care centers located in the different areas of this large continent that is our country. However, in terms of the quality of services and the range of services that are provided, is a huge variation in terms of the protocols that are utilized, and also the degree of reliability that the population puts on the primary care services. Next. Another element is the unwarranted variation in access and investment, and also in overuse and underuse. A study was done by CNHI to just see in one segment provider or one public provider, where they discovered that a certain cardiac procedure would have a totally different both outcome and also cost. And they are not related. So you could have a great outcome with lower cost, you could have a much worse outcome with a higher cost. And but nevertheless, all the centers that were looked at had different kind of overuse and underuse. When you look also at our system and how it is structured today, even our hospitals, they're all really built about or around the institution itself. They are not centric around the patient or the individual. And this is a big mental and mind shift that we need all as healthcare workers to undergo. Of course, number 7 here is the workforce capacity and capability. If you look at the whole value chain, from entering or from exiting from high school, all the way to getting employed and through the career path, we have a challenge. Oftentimes there is a gap in one service that we try and cover, and we add capacity in medical or allied health schools. But then there isn't enough residency program, there isn't enough postgraduate program, there isn't enough opportunities that are required in order for the programs to succeed. So those are all challenges that we aim and object to manage them, hopefully. And lastly, of course, the public expenditure. And as I mentioned, the sustainability, financial sustainability, especially as our country is moving away from the oil era into relying on our own resources. Next. Now, this is an example where, just to demonstrate the primary care issue and why our current model of care is shifted not in the right way. So here in this slide, we've benchmarked some of the well-known countries like UK, France, Australia, Sweden, and Canada, and look and try to answer 2 questions. Is care delivery efficient? And is it effective? We looked around some of the services ranging from promotion, prevention, through screening, chronic care management, urgent care, women and child, support services, which includes virtual care, radiology, laboratory service, physiotherapy, and others, hospital services, and highly specialized care, and lastly, end of life. There is a very clear shift that we have in our care towards secondary care rather than primary care. 70 to 90% of care is provided in these countries at the primary care setting. we provide it at a secondary and sometimes even in tertiary care organizations. And hence, our care is not really effective in promotion, prevention, in screening, in chronic management, or end of life. We're definitely not utilizing secondary and tertiary care efficiently, and also not utilizing our primary care system efficiently. Next, please. So, from the HSTP's point of view, primary care centric system is well proven that it has very important implications on the reform of healthcare. From our perspective, we know that a strong primary healthcare is directly to really will be worked at the integrated care pillar and the public health and health security pillar for both of those roles. We will do our utmost really to align and synergize the effort and create a momentum to meet the national demands of building a strong primary healthcare across all sectors and regions. Next, please. So what are the specific challenges in the journey to enable and empower primary care? The fact that I'm sure many speakers have said today that most of the primary care in terms of physicians are really GPs. They are not formal primary or not formal family doctors. And a lot of work has been done to add to that. And I'm sure you've heard about the multiple family health academies that have been started, the reduction of the training period or study period. And also, unless we really shift our graduates to almost 50% coming out to have the postgraduate training in family medicine, this model, the future model for transformation of the health sector is not going to work. So this is how important it is for us. And here, I don't just say physicians, but also other healthcare workers that work in the primary care setting. Then, of course, there is the challenge with this microenvironment within the primary health care. There is the variation also in the resources that are available. And there is the macro environment, which is the poor alignment and integration between the primary care and secondary or tertiary care, and also between primary care and the public health services. This loss of alignment and loss of empowerment by the primary care pushes the population really to seek services in hospitals rather than in primary care. So it's not really, this is a very complex situation, and we need to work on all components in order to really empower the primary care as we would like to do. Next, please. So as I mentioned, this is why it's very important, and we are yet to start our integrated care strategic pillar. However, because of its importance, probably most of you are aware of His Excellency's Dr. Tawfiq Rabia, the previous health minister's announcement to enable each family to have, or each individual to have a family doctor or a team looking after them, which is called empanelment, and I'm sure you know that more than I. And empanelment had started already in the Ministry of Health. I believe Dr. Khalid Al-Abd Al-Karim, the Assistant Deputy Minister, who is also overseeing the primary care in the MOH and the clusters currently, is addressing that side. But the program is started also with the rest of the ecosystem, with the rest of the healthcare providers, to develop an empanelment strategy across the sector. Now, why is it important? Next slide, please. Because at the end of the day, we healthcare workers have gone into health practice to get the one-to-one engagement with the individuals and with the people and the patients. Patients feel confident, they trust the team when they see it, when they see the team regularly on a recurring period. And that's been proven and seen in many studies. But also that because there are a lot of significant reductions with this kind of continuity, reductions in hospital admissions, reductions in visits to the emergency department, and lower costs of home care. And point that was put to me lately. I wasn't aware of it really, but it's quite significant. As we know that we have mental health needs in the country is not really tapped to very completely now. And we're only seeing perhaps the tip of the iceberg. But 4 out of 5 mental health needs could be managed through the primary care. This is why the empanelment is felt to be very, very important to create a team. And the Ministry of Health, as I said, has started, and we're working now with the rest of the sector to continue the empanelment, hopefully across the whole sector. Next, please. So, again, I want to really emphasize here to all respected audience and colleagues that although they have been hearing probably for decades different health leaders coming and saying prevention is a priority, primary care is the essence. Maybe also we've heard about a physician for each family. However, this time, because of the vision, we are extremely serious. Previously, it's not been materialized for a single very good reason, and that is there is different components to make it happen. Unless you reform your financial, your different structural operating model, your model of care, all these will enable the reform really to occur in the right way. And I would like to assure everybody here today that this is a priority for the HSTP, for the health sector. This is something that the population will feel very quickly, and hopefully will put the pyramid, which is now reversed with the services provided at secondary and tertiary hospitals. Hopefully we will leapfrog and be able to allow the services to happen at the primary care level and allow the confidence of the population to grow in primary healthcare centers, and hence be able to fight all the tsunami of the obesity, hypertension, diabetes, and all other diseases that you have been hearing. With that, I come to the end. Thank you very much for listening, and have a good day.
Thank you very much, Dr. Khalid. Indeed, what a reassurance for the wider community of primary care from the top leader in the transformation office that primary care is the cornerstone. May I ask all the panelists kindly, please, to open your camera and join me on the stage. Dr. Khalid Shivani has to leave for an urgent meeting, and we got Dr. Ayman Al-Khadra with us from the Health Sector Transformation Program. Dr. Ayman is in charge of the integration pillars of the transformation. In addition, being a board member of the 2 cluster, well-experienced clinician and an ex-medical director at big private institution. We got our international expert with us. Today, we've heard a lot about the importance of a primary care. So we will not talk about why primary care important. All what I want to address, critical question that I've been receiving through the Twitter and through the audience, the way forward with the primary care. We heard different models. We heard from Dr. Khalid Al-Mulla about primary care being a part of an ACO cluster in the public, in the government. We heard Dr. Saeed Al-Qahtani from Johns Hopkins Aramco, how primary care is part of well-matured organization. We heard 2 private sector, Dr. Mondegate presented one of them in Al-Madinah. We had another one from Healthgate from Riyadh. And we had a very ambitious plan by our regulator of the private sector about the way to move forward to make the primary care as part of the private industry. Earlier, I had a chat with Dr. Khalid Abdul Karim, who is the Assistant Deputy Director for Ministry of Health and Primary Care, and just an idea came. It's not a plan, it's an idea. Well, why don't we have independent group practice? Myself, Saeed, and Nasser going to have our own group as a primary care physician. What's wrong with that? Dr. Montegit, I'll start with you. Is there any model better than the rest? Is the primary care should be one of an ACO? Should it be an independent practice? Should it be linked to the hospital? What's the best way forward, if any specific way forward?
Well, Dr. Hadi, thank you very much for the introduction and this question. This is a great question, and this is a question that's being faced all around the world. Where does primary care fit? And specifically for this group, where does family medicine fit? And I think that there isn't one answer to this question. I think that one of the things that we all know is that family medicine and primary care as the base of any healthcare system is going to improve health outcomes, reduce cost, and so many of the things that we've talked about. I think certainly the path forward through the enhanced primary care intervention, where family medicine is the base for the wider ACO type of development, I think that makes a lot of sense within the kingdom. And parallel to that, with the enhancements in the private sector, being able to align the family medicine groups and the multi-specialty groups with family medicine integrated, I think that these two parallel tracks will allow incredible access. And then, of course, built onto that needs to be how do you train or retrain the doctors that are in the primary healthcare system to allow that access.
Thank you. Dr. Shabab, you are the regulator of the private industry. Will you allow me and two of my friends to have our own independent practice in the coming near future? Or we have to be part of a system?
Definitely, I think the question very important, very valid. Moving forward, we believe of integrated system. As long as you are part of an integrated system where you can serve your patient the best and adopt all the requirement that was just shared today by Dr. Nasser, which one of them is the Ministry of Health license. Definitely, I'm sure, especially now, we can connect with any other provider, build a platform, share information, especially we are building health information exchange. I think that the future is full of opportunity of this kind, because we believe as long as you are integrated and you are providing the requirement to our beneficiaries and we are able to measure your performance, I see no reason why not to allow it. However, I think we need really to tackle it carefully to make sure that we define the right model. One of the issues really, how can we make sure those primary care, either in solo practice or group practice or part of the system, how can they earn the trust? You know, one of our biggest barrier for primary care in Saudi Arabia and maybe in the Middle East is really people culture are still believing in hospital medicine, going to specialists. So unless we earn their trust by having the right image of primary care, where they receive a comprehensive care with the best evidence available, engaging one, community one, we will not be really able to divert or drive them to go to primary care. So the short answer is yes, as long as it has all the other governmental approvals, governmental regulatory approvals.
Thank you, Dr. Shabab. Dr. Ayman, I'll come to you. I totally acknowledge.
One point, just Dr. Hadi, I think even it has an advantage edge if you go in a group, because your overhead will be much lower. So that's really will add to value-based healthcare, since it will help us to sustain our system.
Great, thank you. Dr. Ayman, we're thinking outside the box today with the national and international expert, with the wider community of primary care. While I totally acknowledge that you still working on your strategy for primary care at the STB, the idea of a group practice as a small business, where we know small business is one of the new driver of the country, how would you see this idea as part of the solution and opportunity for the rest of the community to jump in?
That's an excellent question. Thank you very much.
From a wider perspective, group practice is not out of the question. My major concern, if you will, I mean, I would support it in many different aspects, but my major concern would be if we impanel people geographically, and if the expectation, and you know my bias, that primary healthcare will be one of the executive arms of public health and public health agenda, it is not going to be easy for a small group practice to do that. So I would love to see, perhaps if you can say a statewide large group practice that will take care of 1 million population divided into teams, then I could understand if you would do something more similar to what Kaiser is doing. But to have a small group practice of 3 to 4 family physicians within a large geographical area is probably not going to be very helpful for me from a public health perspective, from looking at my preventive programs. In addition, it will be really a major cost on that particular group because they really have to negotiate contracts with all other levels of care within the model of care. So we're talking about what do they do with labs, radiology, with secondary care, tertiary care, as well as long-term care. So there is a minimum size that you would appreciate in any group practice these days, that would that's where profit cuts between a positive and a negative profit margin. So I tend to think of large group practices as being potentially discussable, and again, they have to operate within the wider system.
Thank you very much. I want to bring another interesting question from the audience, and I will direct it to Dr. Hag. Primary care is not all and only family medicine. We do appreciate family physicians are the cornerstone. However, earlier presented, we have lots of internists and pediatricians among our current graduates. How do you see them as part of primary care from your own experience?
Assalamu alaikum. Very nice to see you, and a wonderful conference. And I'd just like to say I agree with the prior speaker, all of the recommendations. And certainly there are many people who can contribute to primary care, including general internal medicine, pediatrics, and in many cases, OBGYN physicians. We also consider mental health a very important part of primary care. Of course, family medicine physicians can do all of these things, but we also feel our brothers and sisters in other specialties can contribute greatly. And so there's room for everyone, because if you put patients and families first and ensure that everyone has access to high quality primary care, 24 hours a day, 7 days a week, it takes a team. Not just one person can deliver that care. But the family doctor can be a very important contributor.
Thank you. Dr. Saeed, you come from a practice where actually, as of today, you have like pediatrician, other obstetrician as part of your profile. From your experience, is this something that you would love to replicate, or you want to just do it all family medicine?
No, Hadi, I think, first of all, from a practice perspective, I think pediatrician, OBGYN, and maybe internal medicine really could be part of the team for a few reasons. One of them, first of all, when you talk about payment in the structure, pediatrician is the same cost as a family doctor. From experience and quality, pediatrician does 3 years training or 4 years in training in primary care, while family doctor does 2-3 months. So from quality, I think you would provide more of a quality. Pediatrician in the state or internal medicine go into either two branch, either they are a hospitalist or they are office doctor. So I think they could be good. There could be a great addition to the primary care. Plus, you know, in Saudi Arabia, the big need is the epidemics of chronic disease. You know, we have obesity, hypertension, diabetes, and etc. We continue to need family doctor really to shift this high risk down, to suppress it down. And we don't have too many family doctor, at least at this stage. And I think the family doctor, OBGYN, pediatrician, OBGYN, and internal medicine should be part of primary care here. I don't think that the cost will be high. Maybe OBGYN are costly, but we can have office OBGYN for a group who doesn't want to practice, for example, delivery and in the ward or hospital OBGYN. But pediatrician definitely, internal medicine definitely.
I know, Dr. Shabab, you've considered in your proposal these specialty as potential partners of in the practice of primary care. What was the main drive for you to come with this proposal?
I think I would agree with Dr. Saeed and Dr. Haq, what they mentioned. We are not reinventing the wheel. We saw in Canada and US, neighboring doctor with the same group practice. As a family physician, we have a pediatrician who sees the same population and also the internist. So I think qualified family physician is equivalent to pediatrician and an internist of catering care. However, in Saudi Arabia, we don't have many of them. And we have good number of general pediatrician and general internists. So I think that's really will help us really to come up with a model that based on our available resources. I'm sure with the time will mature, and as mentioned earlier, we have enough space for everybody. However, I will allude to what Dr. Ayman Khadra mentioned earlier regarding what is the right size, if you allow me, for the group physician. I remember very well when we were practicing back in North America, there was actually a trend where group are merging together to overcome the overhead that Dr. Ayman is saying. So I think learning from that lesson, I do believe, yes, as you grew as a group is better. However, if you look to our group practice here or polyclinics in private sector, it's not really a group practice. You have an overhead for a lab, an overhead for a radiology, an overhead for an ambulance, which is dusty and it's not used. So how can we really make sure that the unnecessary core services are carved out and expanding the group practice? Because there is after hours, there is urgent care, there is on-call. So I do believe even physicians, they find it as a solo practice, it's burned them out. So I agree, it's big group, but bigger group without the aligned services that could be independent.
Thank you. Dr. Ayman, primary care is not all family physician. HSTB preliminary perspective on such question.
Absolutely. We don't feel that it should be limited to family physicians. It definitely has to be led by family physicians. And, you know, if we think of the hub and spoke model, then, for example, you know, you could have a geriatrician for a bigger panel size, depending on the region you're with, pediatrician for, again, areas where there are large number of babies. But we need to also keep in mind that other practitioners can be part of the primary care team, and maybe health coaches, trainers. The community pharmacies could be and should be part of the primary care team in some locations where they can provide certain services. So having a flexible model, if you will, but again, it remains to be led by the family physicians. That's one reason for looking into other specialties. The other reason is because you don't have enough family physicians. And if you want to empanel properly the correct number benchmarked, you will find that you'll have significant shortage. So perhaps an empanelment project would try to address more complex patients with family physicians, and with their assistant team, you could impanel, school children or healthy populations, and they are supervised by a family medicine consultant, for example. And the family medicine consultant has access to a slightly more complex, specialized services if it's needed within that community.
Thank you, Dr. Shaher. You are the president of the Society of Family and Community Medicine. For some reason, the founder of the society from its early days merged it with the community. Today, we are talking about the huge burden of the chronic diseases that may not be only fixed by a physician sitting in the office. How do you see the role of primary care physician in handling this epidemic of chronic disease?
Yeah, as you know, we are talking about family and community medicine. We are talking about two things: about the patient, dealing with the patient, and about the dealing with the community. I think the primary care, it must be now a setting to deal with this two things. So there is a role now for the community medicine physician to be apart from the primary health care, especially when we are talking about the health population. We cannot run it alone if you are just concentrating in the family medicine without going inside. And you heard the early morning from our colleague, Dr. Khnezan, when he talking about the incidence of disease, the prevalence of disease, and that problem. If you are working as a comprehensively and dealing with the health more than dealing with the disease, we have to integrate the community medicine and our colleague in that branch. It must be more active and integrate with us together and under one umbrella. We are talking primary care. Well, I'm just talking now. We bring a pediatrician, medicine, pediatric. The community medicine is the most with us in this issue. And really now in our society, we work hardly to raise this issue and how to integrate this to specialty to be as a part of the primary health care.
إذا تسمح لي دكتور هادي بس أعلق على النقطة هذه على السريع. فيما يخص primary health care versus community care or preventive care, I do like to think about this as a bi-directional process. And you remember we discussed this before. For most of medicine, unfortunately, you wait for patients to develop symptoms to reach out to the physician. We don't commonly go through our panel. For example, I have 1,000 patients. I go through them and think, okay, when was the last time I did, rectal occult blood, or my at-risk women had mammograms? So there is an active process. If we are to contribute by primary healthcare to the community health, then active movement, active processes have to be initiated by the physicians and by the primary healthcare team towards the community, and not wait for the community to come back to them, because you will only be providing health care if you wait for people to come to you, but you will be providing health if you reach out to your community. And that's very important. That one of the things that we've discussed, and I did ask questions about this to many of our colleagues from different countries, is what % of your time is dedicated to reaching out to your community and contributing to that health part, rather than sit in your office and wait for people to reach out to you where you're just providing healthcare.
Thank you very much. Dr. Nasser, you presented the earlier, yes, you got it on. So can you, CHI, tell us what is it that we should learn from this slide? Dr. Shabab or Dr. Nasser, if you can comment.
Dr. Nasser, are you with us? CMC?
Yes. Yes, sorry, I was trying to unmute. So I think what we're trying to tell from this slide is that the patient, so one of the biggest challenges in our healthcare system is healthcare gaps, meaning patients always will have a journey in our healthcare system, and they will always move between healthcare providers, between specialists, between ER, hospitals, home health, telemedicine, and they will eventually need one place where they can always go to for their basic needs, their needs, what that place looks like, how we're going to build that concept. So this slide shows that it's going to be a home. They need to feel that they have that deep connection with that place, and that place will have their basic needs to address their basic needs. So it has the 3 goals of the Vision 2030, which is access, prevention, and quality. It has also a very important concept here, which is care coordination and integration. Primary care cannot function on its own. It has to be integrated with other healthcare settings. And the patients don't know how to coordinate their care. There must be professionals who are going to help them coordinate their care for them. Also, the population health management aspect, which is really we cannot do everything for everyone. Who are the population that we need to focus on? And also we need to be digital. We know we're going digital, everything is going digital, and our next generation expect their healthcare system to be digital as well.
If you allow me, Dr. Hadi, to just, I think from family versus community, I do believe the screening part and the population part and the care coordination part, direction and strategy are usually done by the community people or the people who are specialized in community medicine. So they will put the guidelines, the rules of engagement, the metrics, and they will dictate it on practices. However, the execution arm will be through nurses and physicians in those centers. So definitely the role of community medicine is really to define the role of engagements, the target, the disease burden, and then also to give some insight and direction on how to execute. They are the brain. I think the primary care are the troops on the ground.
Thank you. Dr. Haag, I think you have something to share.
Thank you. I just wanted to emphasize the important comment that within primary care, you can have clinicians who have subspecialty areas of focus to complement the primary care team. And for example, in my department at the University of California, Irvine, we have family doctors who have completed fellowships and have extra skills in geriatrics, sports medicine, palliative care, integrative medicine, psychiatry, women's health, and some who specialize in population health management. So all of these skills can complement the primary care team to create the health home that you've mentioned here, which is so beautiful and comprehensive.
Okay, so I want to hear from you, Dr. Haag and Dr. Montague. You practice in very private, pure private-driven setups in the state. How do you see the involvement of you as primary care in the public health activity and the prevention, and what the tips and tools from system perspective to overcome this challenge of being in a pure private fee-for-service zone?
So I'll mention that I work in a university system. So we are part of an integrated academic health system. And we have within our system a lot of different types of patients that are covered by different types of insurance. Within our primary care home, we provide preventive and therapeutic services. And we also work in coordination with our public health department. I think the COVID pandemic has been a fabulous example of the importance of the partnership between primary care clinicians and the public health sector to quickly ramp up testing, treatment, and vaccinations for COVID. We work very closely, hand in glove, with our public health department to ensure that all of our population, all of our communities, even patients who were not registered in our practice had access to come in for the COVID vaccination. And so it really required a partnership both within our integrated health system, but also outside with the public health department so that we could provide these comprehensive services.
I work in an integrated health system on the East Coast, similar to Kaiser Permanente. So integrated, not just in care, but also in providing the reimbursement or the insurance, and integrated with the hospital systems. So there, the integration with the community is, I think, on a smaller scale than what Dr. Huck mentioned at UC Irvine. The large group practices in the different communities are linked to the community services, both electronically, as well as having the community-based services embedded in the primary healthcare teams in the larger group practice, so that there is, as well as the electronic communication, there's actually active communication during primary health team meetings with the community services. And that includes behavioral medicine. And that was mentioned earlier that mental health really has become a crisis. And so embedding mental health within the primary healthcare team, as well as we've discussed, can internal medicine doctors, pediatricians, can they be primary care? Well, as I mentioned in my talk earlier, in the US, the number of family physicians per capita is not as high as it is in the UK or Canada. And so pediatricians, geriatricians, general internists work as primary care doctors. And the best situation, of course, is when all of these providers are all integrated together.
Thank you very much. Now, building on this theme, I'll take this opportunity to invite all audience and our great panelists for a very important evening that we're going to run on January 5. We call it the 5 Bs. Is it complementary or contradictory? Where we're going to address the interaction between public health, population health management, preventive medicine, and primary care. So the 5 Bs, we're going to invite experts from CHI, Public Health Authority, MOH, International, to come and have that discussion about how to address the interaction and synergize the 5 Bs. Now I'm going to each one ask of the panelists to one take-home message for the society and for the wider community of people who's watching us. Dr. Shabab, let's start with you.
والله, I would like really, Dr. Hadi, really the number of attendees and the event organization and the agenda is really rich, and really I congratulate you and your team and the whole Family Medicine Society in Saudi Arabia on this kind of great work, and I'm sure we aim high. Such a momentum is needed. I think it's in the right time, and I'm really excited to continue the partnership of CHI or Council of Health Insurance in Saudi Arabia with you, and to make sure that we synergize and we make sure we complement and integrate.
Dr. Haag.
So I would like to congratulate you on this very inspiring conference. What I've learned is that you are going to be leading the way, and you are absorbing lessons from around the world, but developing primary care in a unique way that will serve the people of the Kingdom of Saudi Arabia. I will encourage you to think about putting patients and families first. What is the type of care that you would like your family to receive? Saudi Arabia has resources to be able to deliver this care to everyone, but it's leaders like you and the participants in this group that will be responsible for implementation and ensuring that this care, high quality care, is available for everyone in the country for many, many years to come.
Thank you. Dr. Montagat?
Well, also, thank you very much for allowing me to participate in this very important conference. I think my take-homes for this audience as a whole is to improve the access and to, as that happens, to really base it on the family and individual patient's needs. And then I think for the society, I think the society has a great opportunity to really quickly develop the primary care, the family doctors. I think the number of GPs in the kingdom, these people, I think in great part have a strong willingness and capability to perhaps retrain and to develop retraining programs so that they can grandfather in as the much needed family doctors in the kingdom. Thank you.
Thank you. Dr. Saeed?
Well, thank you, really, Dr. Hadi, for a wonderful day, really. I enjoyed from the first moment until now, really, listening to all the wonderful speaker today. They are saying if there is a will, there is a way. And I hope, inshallah, we are in the right track. We are not, we are in a better shape than 5 years ago, and more than 10 years ago as well. So there is advancement. But my take-home messages is that we are graduating nowadays a good number of family doctors. We need from now really to give them the support and resources, because if you leave them in the practice without support and resources for the next, for example, 5 years, I mean, imagine what would happen to them. So I think we should start from now, giving them enough resources in their practices to do the other milestone. Thank you, Hadi.
Thank you. Dr. Nasser?
I really would like to thank you, Dr. Hadi, and the group for being here. I'd like to thank the 4,500 attendees who really kept being attendant to this conference. I think what we need to do is really to go into execution and show successful pilots. I think we need to start small, grow big, really prove the new primary care concept. Primary care has been there for centuries. It's not something that, it's not a new invention. I think we lost the way in medicine throughout the last probably 5 or 6 decades when specializations started. Now we need to go back to the original path and take the patient journey through primary care. Successful pilots, that's very important. I'd like really to see people go into proving there are early adopters so we can scale up. Thank you so much.
Dr. Haneen, if you are with us. Okay, Dr. Shahir, I want you to wrap up as the president of the society, the take-home message, and present it on behalf of the society to the whole crowd community there.
Thank you, Dr. Hadi, for this event. And also I thank everybody share with us this amazing event. Even I saw the number of the attendees in the YouTube, and that's high. And when I go back 10 years ago, the situation and the picture is completely different. That's why that means we are now in the right way. But we have the same thing, we have a challenge to pass this golden era about the national health system as all. It is built in the primary healthcare and in the family medicine. But we need also to enhance our colleague and different organizations with us to think innovatively how to deal with the family physician, how make this family physician can run this service and work by innovative way. I think what is going now about the incentive and how to deal with him by salaries or something like that, I think if especially Dr. Khalid Shaybani with us, we need to think in this era and this issue, and we can help him from our organization. And also we have a different international model. Even inside, you have a good, excellent model. And when I hear from Dr. Ayman Khadra, that's a good model. The power of health power. It is there is now a model. How to make this running. We have to think also outside of the box to make this what is called this plan, this amazing plan, this excellent plan to be work innovatively. And I am confident Saudi Arabia, it will be the leading of the family medicine, inshallah, in our area. Thank you for everybody share with us this activity, and thank you. I have a special thanks to Dr. Hadi, because he is the catalyst and he's the one to make this one coming. And he gives all the time. He's sitting from the beginning to now. So I thank him a lot in front of you. Thank you, everybody.
Thank you, Dr. Shahir. And on behalf of the Saudi Society of Family and Community Medicine, I want to take this opportunity to thank His Royal Highness, Prince Abdulaziz ibn Talal ibn Abdulaziz, for opening this conference. He was with us for majority of the conference. I want to thank each one of you, our great speakers from local and international, and very special thank for more than 10,000 who were with us today, either live through the Zoom or through the YouTube. Very special thank to our great organizer, even to Troop. We couldn't done it without you. And if I want to conclude, I will use some Arabic words. Please allow me. I'm just going to use quote from Prince Mohammed bin Salman. He said, ما نمر به اليوم تاريخ لا ينسى وتحد مع الزمن سنجني قريبا منجزاته وأعمالا لا تخطئها الأنظار وأخيرا همة السعوديين مثل طويق ولن ينكسر. أستودعكم الله والسلام عليكم ورحمة الله وبركاته وسكايز هوم. في أمان الله.
90 عام والشهادة علمنا وحده وتوحيد وسيف تذنى من يوم أبو ترك تنهض ونجم قاموا لشام العز محد تونى وخلف رجاجيل على قدر الأحداث وانصاح صايح قال وفداك حنا وجسنا على المنوى وعيت على الغير وما كل عشاق وصل ما تمنى وإن قالها الله نجعل الحلم واقع ونطوع الصعبات بالعزم منا نبني عمار الدار بأفكار وعلوم ونصنع سلاح جيوشنا في وطننا طقوا طبول النصر في يوم مجده وسلوا سيوف بشجاعة تغنى
من يوم أبو